am delighted to welcome everyone. You have registered for what promises to be a rigorous, evidence-oriented, and genuinely interactive day of dialogue. Today's question, what can genomics and implementation science really change in Nigerians' infectious disease response, is not rhetorical. We intend to walk through it seriously with the evidence and with the expertise assembled here. Before I hand over to our director for the welcome address, a few brief housekeeping notes. This session is being recorded, and if you have joined via Zoom, please keep your microphones muted unless invited to speak. Our Q&A platform is available throughout the day. You will see the link in the Zoom chat. We encourage you to submit questions early and often. It is my pleasure to welcome Dr. Olabisi Flora Davis, the Director of JBI Nigeria Evidence-Based Healthcare and Genomics Center, who doubles as the Executive Director of the Florette Center. Dr. Davis, you have the floor.
Thank you very much, Miriam. Good morning, everyone, distinguished speakers, colleagues, partners, researchers, clinicians, policymakers, public health professionals, students, and participants joining us from across Nigeria and around the world. On behalf of JBI Nigerian Evidence-Based Healthcare and Genomics Center and Florette Center for Advanced Genomics and Bioinformatics Research, it is my great pleasure and privilege to welcome you to the JBI Local Solution Room, Nigeria 2026. We are truly honored by your presence and grateful that you have chosen to spend your time with us today for what promises to be an insightful and important discussion on a topic that remains central to the health and well-being of our nation and the global community. Evidence-based responses to infectious diseases in Nigeria. What can genomics and implementation science really change? I would like to extend a special welcome to our distinguished speakers and moderators, panelists, collaborators, and guests who have generously committed their expertise and experience to this program. Your willingness to share knowledge and engage in meaningful dialogue is what makes this gathering possible. Today's event is part of the global JBI gLocal initiative, an international movement that seeks to bridge the gap between global evidence and local action. The concept of glocalization reflects the understanding that while healthcare challenges may be shared across borders, solutions must be adapted to local realities, contexts, resources, and needs. JBI, formerly known as Joanna Briggs Institute, is a global leader in evidence-based healthcare, working through an international collaboration of centers and experts committed to improving health outcomes through evidence synthesis, implementation science, and knowledge translation. Across continents, JBI supports healthcare professionals, researchers, institutions, and policy makers in ensuring that decisions are informed by the best available evidence. Here in Nigeria, the JBI Nigerian Evidence-Based Healthcare and Genomics Center is proud to contribute to this global mission by advancing evidence-informed healthcare, promoting research excellence, strengthening capacity for evidence synthesis and implementation, and fostering collaborations that improve health outcomes. We are equally proud to co-host this event with the Florette Center for Advanced Genomics and Bioinformatics Research, an institution dedicated to advancing genomics, bioinformatics, and evidence-informed innovation through research, training, scientific partnerships, and capacity development. The center works to strengthen the role of genomic science in addressing pressing public health challenges and supporting sustainable health system improvements. Together, our organizations share a common vision, a future where evidence is not only generated, but effectively translated into policy, practice, and meaningful health outcomes for individuals and communities. The vision is particularly important in the context of infectious diseases. Nigeria continues to bear a significant burden of infectious diseases, including long-standing and emerging threats that challenge our health systems, healthcare workforce, and communities. At the same time, advances in genomics surveillance systems, implementation science, and data-driven decision-making have created unprecedented opportunities to improve how we detect, understand, prevent, and respond to these diseases. Yet, despite these advances, important questions remain. How do we ensure that scientific discoveries translate into better patient outcomes? How do we move evidence from journals and conference presentations into everyday clinical practice? How do we strengthen implementation in resource-constrained settings? How do we bridge the persistent gap between what we know and what we do? And perhaps most importantly, how do we create systems that can sustainably transform evidence into action? These are questions that bring us together today. Throughout this program, we'll hear from experts representing clinical medicine, public health, genomics, implementation science, academia, policy, and health leadership. We'll explore the current realities of infectious disease response in Nigeria, examine the contributions of genomics and implementation science, discuss successes and persistent challenges, and identify practical pathways for strengthening evidence-informed healthcare. Importantly, this event is not intended to be a series of isolated presentations. Rather, it's designed as a solution room, a space for reflection, dialogue, collaboration, and collective problem solving. We encourage all participants to engage actively throughout the day, ask questions, share your experiences, challenge assumptions, identify opportunities for collaboration. The diversity of perspectives represented here today is one of our greatest strengths, and meaningful solutions often emerge when people from different disciplines and sectors come together around a shared goal. As we begin, I would like to express my sincere appreciation to our speakers, moderators, organizing committee, technical team, institutional partners, and everyone who has worked tirelessly behind the scenes to make this event possible. Your dedication, professionalism, and commitment to advancing evidence-based healthcare are deeply valued. I would like to thank every participant joining us today. Your interest in evidence-informed healthcare and your willingness to engage in these conversations are essential to the progress we seek to achieve. It is our hope that by the end of this event, participants will leave not only with new knowledge, but insight, but also with renewed commitment, stronger networks, and practical ideas for advancing evidence-based responses to infectious disease within their own settings and spheres of influence. Once again, thank you for joining us. We are delighted to have you here and look forward to a productive, engaging, and impactful day. Welcome to JBI gLocal Solution Room, Nigeria 2026. Thank you.
Okay, good morning, distinguished colleague. I'm Dr. Amos Solomon, a consultant pediatrician with Federal Medical Center, Bida. I'll be presenting on behalf of my medical director, Dr. Abubakar Usman, who is, apart from being my medical director, also double to be my trainer from the time of medical school up to throughout my residency, and also my mentor. So I do not actually fit to wear his cap, but when a boss sends you on errand, you have no any choice than for you to do that. So I will be speaking his mind, and first I must congratulate the organizer of this very event for choosing him. He fits all the aspects of what we are going to discuss today. He is a teacher, a clinician, a researcher, and presently, even for so many years, he has been a leader. So you could see that he touched every aspect of what the organizer have chosen for this scientific forum discussion. He has directed me on what to say, so I will be speaking directly from his mind, and whatever you hear from me saying is what I was directed by him to present to the audience. So I will be talking about advancing evidence-based care in Nigeria, perspective from federal clinical leadership on the realities of evidence-based care delivery in Nigeria. And the theme of our scientific forum discussion today is evidence-based responses to infectious diseases in Nigeria. What can genomics and implementation science really change? This is a very robust topic, and I believe there are a lot of researchers here, senior colleagues, who are going to do justice to this very topic. I'll be speaking from the leadership perspective from my box, and I want to say that before discussing the genomic and implementation science, it is very important to recognize a fundamental reality in healthcare. Scientific discovery, no matter how groundbreaking they are, they do not save lives by themselves. So their true value is realized only when they are effectively translated into routine clinical practice. Scientific discovery, no matter how groundbreaking they look like, they do not save lives themselves. And their true value is realized only when they are effectively translated into routine clinical practice and public health action. You will bear with me that Nigeria has made significant progress in controlling infectious diseases through research, innovation, policy development, and healthcare interventions. However, despite these advances, preventable illness and death remain substantially across many parts of the community in Nigeria. So now, the challenge before us today is no longer simply generating more evidence. There are a lot of evidence lying fallow in the journal, in articles, in archives, in various policymakers' desk. So what we have now is that we have growing amount of research guidelines and technological innovation. So now the critical question is how to ensure that this evidence consistently reach patients and influence clinical decision, healthcare policy, and public health program. So this is where genomic and implementation science become particularly relevant. Slide 2. So why this conversation matters today? We come to realize that Nigeria continues to face a significant burden of infectious diseases, and malaria, top on the list, remains a leading cause of morbidity and mortality, particularly among children and pregnant women and the elderly. As if this is not enough, tuberculosis continues to challenge our health system, while HIV/AIDS remain an important public health concern despite considerable progress in treatment access. In addition, diseases such as Lassa fever and cholera continue to cause periodic outbreak and havoc across the nation. At the same time, antimicrobial resistance is emerging as one of the present threats to the modern medicine. Therefore, these diseases place enormous pressure on the health facility, healthcare workers, government resources, and community. So as new epidemic continue to emerge globally, and if we could see, every nation now is on alert concerning Ebola virus arising from Congo, and we are on surveillance to see if this will not cross to the other parts of the country. So now our capacity to direct, respond, and prevent infectious disease has become more important than ever. And that's why I think our discussion today is very, very timely. So the discussion is not yet merely academic. It is directly linked to improving health outcomes and strengthening health system resilience in Nigeria. Next slide. So now, what actually do we know? we know that one of the greatest challenges in modern healthcare is the evidence to practice gap. There are a lot of evidence in the journals. There is a lot of evidence that have been researched on. But the problem is, how do this evidence actually get to the people that need them? And we know that effective intervention exists for many infectious diseases. And we have evidence-based guidelines, proving treatments, vaccines, surveillance system, and preventing strategies. So, however, what often happens in practice is different, entirely different. And what usually happens is that the adoption of evidence can be delayed. Implementation may vary across facilities and regions, and some intervention may not even be sustained over time. And access to effective care may remain unequal. And that is why we gather today to look at what is the way forward. So as a result, the benefit of scientific discovery do not always reach the patients who need them most. So hardly do they get to the bedside. So the gap between what we know and what we do represent is one of the most important opportunities for health system improvement. And that's where we gather today to discuss this. So now let's simply tap into, next slide, let's really tap into what evidence-based care actually is. Evidence-based care is often misunderstood as simply following a research finding. It is not that. Right patient at the right time. So that is what evidence-based care is all about. So evidence-based care, therefore, combines science with practicality, not just on paper, ensuring that healthcare decisions are informed and they are patient-centered and contextually appropriate in treatment programs, which have significantly improved access to life-saving therapy. And today we could see that with PMCT services, children born to HIV-positive parents are no longer positive. And this is one of the breakthroughs. Nigeria has also made remarkable progress in immunization program and achieved historic success in the fight against white polio virus. What about in disease surveillance? The disease surveillance system has been strengthened through the work of Nigerian Center for Disease Control and Prevention and other partners. In terms of laboratory capacity, it has been expanded. And, well, I would say thanks to the COVID-19 era, some molecular laboratory hubs has been developed across the 6 geographical parts of the country. And furthermore, digital health innovations are increasingly supporting healthcare delivery and data management. So this achievement demonstrates that when evidence-informed policy and implementation, meaningful health improvement can actually be achieved. So we are not doing badly, but we are not yet there, and we have to move forward. So now, let's look at some challenges, some persistent challenges that has made this very progress to be slow. While progress has been made, important challenges still remain. And this includes that many health facilities continue to operate under significant resource constraint. And workforce shortage also plays an enormous and patient outcome. So data system also remain fragmented in some settings, limiting timely decision making. There are some parts of the country where network does not even appear to be there. And where it is present, it's actually very difficult for you to connect, just as the network challenges we experienced this morning. So about the supply chain disruption, you can see that there is problem with supply chain, which can affect the availability of medicine, vaccine, and laboratory supply, even if you have evidence that this actually works. And there is also significant inequality that exists between the urban and rural healthcare services. So majority of the technologies that could be employed to achieve these evidence-based practices of care at the bedside are not even present in some rural area where majority of this infectious disease actually dwell. So finally, research findings are not always translated effectively into routine practice, especially in hard-to-reach areas. And even in urban areas, they are also limited. So this reality remains with us, that evidence alone is insufficient. So successful implementation is equally very, very important. So now let's divert a little bit into understanding what genomics is. As I told us earlier, it's a kind of wetting the ground for for a lot of discussion that will be made by various scholars that are present in this scientific discussion forum. So I will be touching briefly on understanding the genomics. So when we talk about genomics, we refer to the study of the complete genetic makeup of organisms. In the concept of infectious disease that we are discussing today, genomics focus on understanding the genetic characteristics of pathogens, such as viruses, bacteria, and parasites. Information that will not be available through traditional methods alone. So in many ways, genomics allow us to see infectious disease with a level of precision that was previously impossible when the genomic has not actually evolved. Next slide. The genomic importance of genomic, I try to consider highlighting some values of genomic as we had it during the COVID-19 era. And during the COVID-19 era, the value of genomic in public health. And we know that throughout the pandemic, genomic sequencing play a very critical role in identifying and monitoring new variants of the SARS-CoV-2 virus, just stressing about the importance of genomics, that without it, the level of precision that we have now will have been very, very impossible. And during this COVID-19 era, the genomic help the scientists and public health authority understand how it actually helps scientific and public was evolved. Travel and during the era of COVID-19, and that's just to showcase what genomic can do. And without it, how it would have been very difficult for us to forge ahead in terms of curtailing infectious disease, even in terms of treatment. So therefore, importantly, the pandemic accelerated investment in genomic infrastructure, laboratory network, and workplace training globally, including across Africa. For Nigeria, COVID-19 actually highlighting both the opportunity and the necessity of strengthening genomic surveillance capacity as part of our national security. So the key lesson is that timely genomic information can significantly improve outbreak preparedness and response. So now, let's look at interaction between genomic and infectious diseases. The potential application of genomics in Nigeria extend well beyond COVID-19, as we can see. For tuberculosis, genomic has helped identifying drug-resistant strain and support more effective treatment decisions. And for Lassa fever, genomic surveillance can improve outbreak detection and provide insight into transmission dynamic. Even in cholera outbreak, genomic analysis can help determine the source of infection and track the spread of disease across communities. So genomic also play an increasingly important role in monitoring antimicrobial resistance, which is becoming a major global threat. Furthermore, genomic technology can assist in the detection of emerging pathogens before they become widespread public health emergencies. The overall benefit is very simple. Earlier detection leads to earlier intervention, which can ultimately save lives and reduce healthcare costs. So now, but there are other things that genomics cannot actually do. That is now on slide 11. While genomics offer tremendous opportunities, it is important to avoid viewing it as a standalone solution. It's never a standalone solution. As we understand that genomic technologies require significant investments in laboratory infrastructure, equipment, data system, and highly skilled personnel. So all these have to come together for genomic to actually work and to be placed in the right perspective in terms of evidence-based care. So the cost of establishing and maintaining genomic programs can be substantially enormous, particularly in resource-limited settings like ours. So these are also challenges related to data storage, analysis, interpretation, and sharing. All these very challenges make the genomic not to be able to work alone, except they are well put in place to surmount these challenges. So perhaps most importantly, genomic information has little impact unless it is informed decision and action. So no matter how beautiful genomics is, if there is no translation of the evidence is bring to us to the bedside and to the patient that needed them, it has not been in existence. So identifying a variant or resistant organism is not only useful if healthcare provider, public health officials, and policymakers are able to act on that information. And so we're able to act on it, is just the use of it become virtually nonsense. So therefore, scientific discovery must always be paired with effective implementation. And this is where implementation science became critically important. So now, let us go divert a little bit into talking about introducing us into implemented science, which is one of our core discussion for today's gathering. Implementation science is the scientific study of methods that promote the adoption and integration of evidence-based intervention into our routine practice. It simply terms implementation science. That's in simple terms, implementation science seeks to answer a practical question. That is, how do we ensure that interventions that are proven to work are actually used effectively in the real world setting? And where is this real world setting? In the communities, in the hospital, by the bedside. So the field of implementation focuses on several important concepts. One, this includes adoption, which refers to whether people now. It also has a component of fidelity, which assesses whether the intervention is delivered as intended. Was this intervention delivered as intended? Then it has a concept of acceptability, that is, which examines whether users find it appropriate and useful. Then it also has a component of sustainability, which focuses on long-term continuation. And I must tell you that in middle and low-income countries where resources are limited, sustainability becomes a very big, important stumbling block to whatever we want to actually implement. And if it actually works, if the fidelity is taken care of and is acceptable, then scaling up remains another element of implementing science. That is, scaling up, which involves expanding successful intervention to the larger population in the community. So therefore, implementation science bridges the gap between knowledge generation and the real-world impact by the bedside, by the community and the population at large. Many healthcare interventions fail, actually not because they are ineffective, but because they are poorly implemented. So many of these scientific, so many of the interventions that may support and help us at the bedside actually fail, not because they are not good, but because they are poorly implemented. An intervention may be supported by strong evidence, but yet fail to achieve its intended impact. This may occur because it is not integrated into the existing clinical workflow. And we'll be coming to that later when other scholars will discuss about this. If it's not implemented there, they become very difficult. The healthcare worker may not receive adequate training, and stakeholders may not be engaged in planning and decision making. So monitoring the system may also be weak and making it difficult to identify and address the problem. Then implementation science therefore provides systemic approach for identifying these barriers and developing practical solutions towards them so that the evidence-based care can actually reach the bedside and the population that needed them. So by understanding what facilitates or hinders implementation is in healthcare system, that is, the healthcare system can improve the uptake and suitability of evidence-based practices. So in essence, implementation science helps transform good ideas into measurable outcome. So now let's go into part of the discussion, that is Nigeria reality. In our own context, how can this actually fare well? So now, as clinical leaders and healthcare professionals in Nigeria, we operate with a unique context, and we must understand that when it comes to implementing evidence-based care. Many health facilities face high patient volume and increasing demand for services, which can hinder implementation if there are not enough staff. So healthcare workers often manage multiple responsibilities under significant resource constraint. They are few, and what they are to use is not even available. So competing priority can make it difficult to introduce and sustain new interventions, where the old one we are using is not yet sufficient enough to be implemented. New one is sufficient. So this competing priority can make it very difficult to introduce and sustain new intervention. The infrastructure limitation may affect diagnosis, data system, and service delivery. So in such environment like ours, implementing evidence-based intervention is rarely straightforward. It's not straightforward. So there are a lot of things we have to work around to make it fit into our own context. And the quick question is therefore not simply whether intervention work. Rather, the question is how do we make evidence work under the real world condition where we live in Nigeria? Answering this question requires leadership, innovation, adaptability, and a strong understanding of local reality. So now, bridging discovery and delivery. How do we bridge this? To appreciate, that's the next slide, to appreciate the relationship between genomics and implementation science, it is useful to think of them as a complementary discipline. They are not, we shouldn't treat them in isolation. They complement each other. Where genomics help us to understand what is happening, it provides information about pathogen, transmission pattern, outbreak, and resistance mechanism. Implementation science, on the other hand, help us understand how to respond. It provides strategies for integrating evidence into healthcare system and ensuring that intervention reach the patient at the bedside or the population in the community. Together, this discipline creates a pathway for knowledge to action and ultimate to impact. So genomic on its own generates valuable intelligence. Implementation, on the other hand, ensures that intelligence is translated into meaningful improvement in patient care and population health. So both are necessary if we are to strengthen infectious disease control in Nigeria. So genomics and implementation science work hand in hand and they complement each other. Let's look at an example of this in terms of antimicrobial resistance. Next slide. Antimicrobial resistance provide an excellent example of how genomics and implementation science can work together. Well, genomic technology can identify resistant organisms, detect its resistant genes, and monitor emerging resistant patterns. This information can guide clinicians towards more appropriate treatment choices and inform public health surveillance. However, identifying resistance alone is not enough. Healthcare providers must modify prescribing practices. Hospitals must establish antimicrobial stewardship programs. Clinicians must be disseminated and adopted. That is, clinical guidelines must be disseminated and adopted. And monitoring system must track implementation and outcome. So therefore, implementation science help address each of these challenges by identifying effective strategy for changing behavior and improving systems, therefore complementing the work of genomics. So when genomic and implementation science are combined, the result is improved patient outcome, more rational antimicrobial use, and reduced spread of resistance. So this represents a practical example on how science can be translated into measurable health impact, how genomic and implementation science can help us actually reach the bedside for the patient to benefit from the evidence that we are talking about. So now, let's look at how majority of these challenges can be surmounted. One, strengthening healthcare system. Next slide. Ultimately, successful infectious disease control depends on strength of the health system. So therefore, scientific evidence, genomic technology, and innovative intervention can only achieve their full potential when supported by functional health system. Several fundamental components are therefore very essential. One, functional laboratories are required to timely and accurate diagnosis. Second, reliable supply chain must ensure that continuous availability of medicine, vaccines, laboratory reagents, and essential commodities are available. And thirdly, a skilled and motivated workforce is necessary to delivering quality care. You must have a well-motivated staff to do this for you. And fourth, digital health system can improve surveillance, reporting data analysis, and decision-making. This is area of digital technology. So finally, a culture of quality improvement is needed to promote continuous learning and performance enhancement. So it's a strong system, create the environment in which evidence-based intervention can succeed. In short, strong system enables strong outcome. So for us to surmount majority of these challenges, there will be strengthening of health system. Okay. What is the role of clinical?
Dr. Amos.
Yes, sir.
Thank you very much, sir. We'll need to move on shortly to stay on program. Perhaps a final thought to bring us home, sir.
Okay. So now, the role, let me quickly brush. For the role of clinical leadership, clinical leaders must champion evidence use, they must promote accountability, encourage innovation, support continuous learning, and drive quality improvement. So leadership determines whether evidence become very practicable. So there must be a strong leadership strength. Then building research to practice partnership. There must be a collaboration which is very essential among researchers, clinicians, policymakers, public health agencies, academic institutions, and development partners. So this shared goal accelerates impact. So what is the priority for Nigeria? The key priorities include expand genomic surveillance, strengthen implementation research, improve healthcare data quality, invest in workforce development, scale proven intervention to a large population, and support local innovation. Let the people in the local community be ownership of the program. So what does the success look like? Success means faster outbreak detection in terms of infectious diseases, better treatment outcome, reduced mortality, improved healthcare equity, that is from urban and rural areas, strong healthcare system, sustainable evidence-based practice, ultimately better health for Nigeria if all these are put in place. Call to action. We must move beyond generating evidence. We have enough evidence already. So our focus should be in implementing what works, measuring the impact, learning continuously, and scaling up successful approaches. The future, therefore, belongs to a system that learn and adapt. So please, this is our take-home message, that evidence-based care saves lives. We must know that. We must also know that genomics strengthens disease intelligence, and implementing science bridges evidence and practice by the bedside or the community or to the population we serve. And strong leadership is very essential for coordination, for provision of logistics, and sustainable impact require system thinking. We must keep thinking for the best. So Nigeria has the opportunity to actually lead the Africa. Closing remark. The future of infectious disease in Nigeria will not depend solely on generating more evidence. There are enough evidence on the ground already. So it will actually depend on our collaborative activities to translate evidence into practice, scale what works, sustain effective intervention, ensure equitable access to quality care. So as frontline leaders, our responsibility is very, very clear. So our responsibility is very clear, and this means that we must, in a way, to create a system where evidence is not merely produced, but consistently applied to improve the life of people that we serve. That should be for the front line leaders as ours. So thank you all for your attention and for your commitment to advancing evidence-based healthcare in Nigeria, and I look forward to our robust discussion. Thank you very much.
Thank you, Dr. Amos, for stepping in to share with us these critical insights from the federal clinical leadership and showing us the realities of evidence-based care delivery in Nigeria. It is an honor to present our first keynote speaker, Dr. Shakirat Olorutoyin Ajenifuja, the Director of Genetics, Genomics and Bioinformatics at the National Biotechnology Research and Development Agency in Abuja. She would examine the current state of genomics infrastructure in Nigeria and the policy framework driving its development. You have the floor, Dr. Ajenifuja.
Good morning, everyone. Thank you for organizing this program. I think it's timely because of the current trend and interest in genomics globally. And it's also a platform that is bringing stakeholders together to be able to have discussions and hopefully all working together to ensure that the impact of these discussions are felt by Nigerians in all sectors of the economy. Well, welcome once again to the JBI gLocal Solution Room event. I've been requested to speak on building Nigeria's genomics infrastructure, the national policy perspective. My name is Shakirat Ajenifuja Sholebo. I'm the director of the Genetics, Genomics and Bioinformatics Department of the National Biotechnology Research and Development Agency in Abuja. So this is the general outline of the presentation I'll be making. Introductions, NABDA over 2 decades, governance and programs, partnerships, the way forward, and then giving the closing remarks. So I want to start by saying that the national policy position on genomics and building the infrastructure for genomics is actually broad-based. The mandate of the National Biotechnology Research and Development Agency is broad-based to be able to apply genomics in different aspects, different sectors of the economy, including agriculture, healthcare, environment, industry, and security issues. So we have the mandate to apply biotechnology information, including genomics and bioinformatics, across these sectors to bring about the desired national development, and also to position Nigeria to be part of the growing growing global bioeconomy. So some of the pillars that we have used to date includes building human capacity, whereby over time we've engaged in training researchers, because when the biotechnology development agency or biotechnology issues came to national attention, there was relatively not enough knowledge and human capacity, infrastructural capacity to be able to tap into the technology. So it was essential that we build human capacity and then infrastructural capacity, both for wet lab and in silico research activities. And then based on that mandate as well, and recently in supporting the renewed agenda of our president, we've had to try to position ourselves to ensure that genomics in particular becomes more relevant for innovation in healthcare, agriculture, and environmental stewardship, even industrial development. And one of the key drivers of being able to deliver on these pillars is the public-private partnerships, which is one of the major reasons why I'm able to speak at this event, because it's a key driver to ensure that we're able to deliver on those on the mandates. So I'll still be speaking to issues that will bring this to the fore. So the NABDA's mandate is based on the NABDA Act that was actually legislated in 2022. But NABDA, however, was established by Federal Executive Council order in 2001, in year 2001, and it was based on that we had been carrying out our responsibilities until the final act that came out in 2022. And in that act, the agency was designated as a National Bioinformatics and Biotechnology Data Center. And so we have the authority to coordinate biotechnology, genomics, and bioinformatics research, information, and data across the country. Then we also have the mandate to research biotechnology research generally across the sectors that I had earlier highlighted. And all this is in support for national development, including the current renewed agenda of the president. And then also, one of the major activity that would ensure success is effective coordination And coordination can only be achieved through effective collaboration with of the research and development activities across universities, hospitals, research institutes, and bringing them all together in one national framework. So Nigeria and through the agency is not aware of the current interest, the current global interest in applying genomics. And the areas that we're looking very much to be able to ensure that genomics is able to deliver on are some of these that I've highlighted here, which is precision medicine, where we have genomics being able to assist in diagnosis and treatments, just like we had earlier heard about bringing these the benefits of this information and knowledge to patients, you know. And then the issue of infectious disease and its surveillance. We're looking at being able to do genomic surveillance of the disease, and of course, even the evolving genomics of the disease, of the disease-causing organisms, to ensure that we're able to track the outbreaks. All these would rely heavily on being able to generate genomic information and data. And speaking to this is also the issue of the need to actually generate indigenous genomic data, because globally, the African contribution to genomics data globally is actually less than 2%. And so the need to be able to also contribute to the global information on genomics that can help in addressing disease burden and being able to provide precision medicine is also very important. Though, yes, there's publicly available data that is being used now, but the need to be able to generate our own is very, very important. And then we also want to be able to apply genomics in agriculture and food security, environmental stewardship, industrial development, and all the likes. But I'm sure you'll agree with me that effective genomics application would actually require a robust enabling national infrastructure, and this is based on the effective policy. So, and the agency is very much aware of this and taking necessary steps, which I'll still share a few of what we're doing subsequently as we go on. So in the past 2 decades, we've tried to build foundation in various aspects of biotechnology. Like I told you earlier, the policy position for the nation includes the application of biotechnology in different sectors of the economy. So we're not just only focusing on medical biotechnology, which happens to be the subject of today's program, but I need to put it into perspective and for information based on the diverse stakeholders that are attending this program, to inform you that we have the mandates in different aspects on agri biotech, environmental, food and industry, and all that. And then we have a dedicated department to facilitate the genetics, genomics, and bioinformatics information through training, high performance computing, in the relevant softwares, and then of course collaboration with partners. Also key in our activities is the bioentrepreneurship aspect, whereby we're looking to actually bring in our products and services from the research that is being carried out in different sectors. Also, the agency also is the Secretariat for the National Bioethics Committee, which I'm sure you know that in the field of research, ethics is the key issue, and the agency sits as the Secretariat for the National Bioethics Committee that can provide guidance in any aspects or sector that biotechnology needs to be applied to. And then also the issue of advocacy is one of another major activity that we carry out to ensure that we're able to get our stakeholders on board. Then genomics and bioinformatics at NABDA. Over the years, we've been involved in training and capacity building, where we've hosted introductory bioinformatics training and advanced bioinformatics training in collaboration and partnership with the H3 ABioNet network, where we've facilitated workshops. We've also made contributions to the pharmacy school's curriculum to include genomics and bioinformatics to be able in the design of drugs and medications. And then, so through national and international workshops that has been hosted. To support that, there's an ongoing construction of a core bioinformatics facility that will house the servers. We have servers, softwares that have been acquired, and then of course, internet connectivity is essential to be able to, utilize this information, generate this information. And then of course, the high performance computing equipment that is required is also available, to a certain limit. Of course, also needs to be further advanced. Partnerships is so key because we're talking about generating building a national infrastructure. It means that it's not about the agency that has the mandate for coordination to do everything. We're just there mainly to coordinate, create the enabling environment, create the necessary awareness, and build necessary partnerships so that we can collaborate to build the national infrastructure and make it functional together with the data that we'll be generating in our different institutions and even with partners at the global level. So current challenges are actually sustainability gaps in funding and the need for stronger impact-focused alliances to be able to deliver on to Nigerians across the sectors, and then infrastructure that still needs to be built. So this is the governance structure for the for bioinformatics, genomics and bioinformatics infrastructure and activity in Nigeria. Now, NABDA sits as the national coordinator of the National Bioinformatics Data Center, and under that, it's a national genomics and bioinformatics data generation and repository infrastructure that is being championed now, currently championed now, to ensure that we are able to collaborate and work effectively with researchers and universities, other government institutions, private sector, and the industry, including international partners. The infrastructure is meant to provide a platform, an infrastructure whereby indigenously generated genomic data from the different sectors, areas of biotechnology can be curated, can be accessed, can be utilized for national development to address medical issues as may be necessary. And this repository is not meant for NABDA, it's meant for the nation, and we'll be calling on stakeholders to contribute their information to that infrastructure. This is similar to what we have in NCBI. NCBI, that's the platform that is being hosted by the United States, where the agency is looking at building similar infrastructure to facilitate better collaboration and more effective application and delivery of biotech solutions to Nigeria. So the model is that we are going to be having the NABDA as the collaborator and national coordinator, the repository, which will have an interoperable user interface and to give a good user experience that will be managed by NABDA under robust data governance. We are trying to build a model that is simple, cost-effective, and aligned with the existing mandates of the agency, so that there are no new bureaucratic institutions being established to be able to manage it. And then, of course, the very, very important need for multiple, the contributions from all sectors, all stakeholders, to ensure the effective utilization of the infrastructure. So how do we intend to ensure that this infrastructure would deliver on its objectives? So to ensure the functionality of the infrastructure from the onset, where a Nigeria Biogenomes program or project is also being initiated, whereby deliberate steps are taken to ensure that the genomes of different organisms are going to be selected at the initial stage for sequencing. Human, animal, plants, and microbial genomes are going to be selectively done at the onset, and then we're hoping that there will be more collaboration from different sectors, because I know that we know that there are pockets of research ongoing in different institutions by different scientists and researchers, with no clear national repository to be able to host them, to curate them, and to own them, for even for genomic sovereignty purposes. So that these are things that we are doing here, and we end up going to deposit some of this the sequence data generated to the NCBI. Yes, the NCBI has played its role over the years and has supported our development this far. But as a nation, the government is looking at, creating our own national repository that we can use and access, and something that is going to be our own. So what have we done in recent times? Recently, we just signed partnership agreements and a memorandum of understanding with two key partners, which is Basani Digital Innovations Limited, that are interested in creating genomic-related digital health platform and its deployment. Then with the Indigenous Bio, it's a US company, recently signed a memorandum of understanding with them on launching. They have a platform that is already IP protected for clinical intelligence form that can be used mainly for pharmaceutical drugs development that is tailored to specific genomes, and part of what it's targeted is that in the next 5 years, we want to be able to sequence about 500,000 human genomic samples. And this is where I'm referring to that we need to forge strong operations, because this is not something that NABDA can do on its own without strategic partnerships. But what the indigenous bio is bringing up on board is that infrastructure and the platform that is already existing, and they'll be supporting with some GPUs to enable us host the cloud storage infrastructure nationally in Nigeria. And then the information is going to be, the sequence information is going to be tokenized to ensure that pharmaceutical products are able to come out from there. So these are opportunities for more partnerships within the country, within relevant institutions that can come on board to make this work and deliver to Nigerians. So precisely some of the specific issues which I've spoken to is the issue of the pharmaceutical partnerships for drug discovery. Some of the partnerships helps us to be able to achieve our genomic sovereignty, where we can curate it, access it for national development. And then the digital health platform seeks to merge electronic medical records with genomic information that can provide precision insights to healthcare. Then disease surveillance, I'd also spoken to that earlier. The existing genomic information and the epidemiology and the evolving genomics of the pathogens, so that it can be tracked even at the national level. And then, of course, the issue of precision medicine, where medical digital twin can be created for individuals in Nigeria. So what are we looking at as a way forward? That the repository is one of the key actionable plan that we have to ensure that repository comes on board. Then we are looking at effective coordination of research, strategic partnerships. Of course, all these will be guided with proper data governance, classifying different levels of the privacy of information, sovereignty, and how access can be gained to those networks, the publicly available data, just like it is done in claims. Some publicly available data and some classified data that can only be accessed, based on authorization. And then, of course, the implementation science comes in. What do we know, and what are we actually doing with what we know? How do we close these gaps, especially when it relates for this program, as it relates to patients' outcomes? But like I said, for other sectors of the economy, we are also looking at how to make genomics have impact in improved food security, better environmental stewardship, better industrial breakthroughs, using genomics and precision information to take us through them. So I know that this discussion or solution room is asking all of us to come together to ask what is really stopping us from being able to do all this that we hope to do, we are aiming to do. So, but I want to say that there are existing policies and governance framework And in recent times, we have unprecedented private sector interest in genomics. We've seen that at NABDA, where we've had, number of people coming in, bringing in different innovative ideas to see how we can actually use genomics to support national development and to ensure Nigeria gets involved in the growing economy, global bioeconomy. And then when it Africa really on the map when it comes to genomic and other sectors of application. We find out that we don't have our indigenous crops, we don't have our indigenous microbes, we don't have any of our locally available genetic sequence. We are not aware of the genomic information, and this is something that we want to see how we to do. So what I'm still also asking, what is really stopping us from doing this? We need to collaborate and get even government funding locally. But with the current situation there's a need to leverage on partnerships, which is what we are using. We're starting up with in NABDA to at least start the journey. So funding, forging partnerships, funding that can come from public sector, private sector, or sometimes development partner fund. And then the political will and institutional commitments generally across biotechnology to ensure that we're able to deliver it. Then collaborations across stakeholders and even across the all this will help us to achieve making genomics and bioinformatics data application to actually change patients out. So as I've been hammering on, the need for collaboration cannot be overemphasized in all of this. We need to come out of our various silos and come together on that national genomics and bioinformatics data generation, data generation and repository infrastructure that is coming on board. So, and we're happy here to share that information with this group of stakeholders, and more information is going to be shared over time, but we need that partnership to be able to succeed together as a country and, of course, as a continent. So we have actually barely in Nigeria and Africa, and where it's identified the publicly available genomics data, is a low-hanging fruit that can be harnessed if we apply the implementation science of putting what into action and impact. So, and then the collaborations that are already generating some primary indigenous genome sequence data. You need to have them as in a national repository where they can be accessed and utilized as solutions, national development. So together to build this the genomics ecosystem that will serve us in Nigeria. Thank you. Thank
Thank you, Dr. Ajeni Fuja-Asholevo, for that substantial overview of where Nigeria's genomics infrastructure stands today, and more importantly, where policy needs to take it. There will be a quick poll. Please kindly participate. Thank you all for participating in the poll. We move now from the national policy landscape to the practice of genomics deployment in public health. Allow me to introduce our second keynote speaker, Dr. Olufemi Samuel Amao. He is a research fellow at the Nigerian Institute of Medical Research, a member of the Genomics Society of Nigeria, and a former Peter Piot Fellow at the MRC unit in the Gambia. Dr. Amao will examine what Nigeria has actually deployed and what the honest evidence says about the gap between genomic promise and practice. Dr. Amao, please go ahead.
Oh, thank you very much. So, Dr. Reed, thank you for that brief introduction. Just a little correction. I'm a co-founder for Genomics Society of Nigeria. And I stand on that platform being here with you today. Good morning, everybody. I believe I'm being heard loud and clear. And I must use this moment to congratulate Dr. Davis and the Floret Center team for putting this together. It's a very wonderful platform, bringing in policymakers, students, teachers, academia researchers together for us to brainstorm on the way forward as far as the use of genomic is concerned. It's my pleasure and the greatest one to share with you on the topic, genomic in public health, looking at what promises this is genomic is going to or is having in relation to our public health system, from promise to practice. In the course of the presentation, I will be speaking to of course, genomics and promises that genomics is offering us, and what have been done so far, the challenges that probably we are facing at this point in time, and probably what we need to do to get it right. And then my job also were made easier by the first keynote speaker, Dr. Shakirat Adenifuja. She has actually put me on a bed that has been laid, so I think I'm having a smooth ride at this point in time. And also the speaker from Federal Medical Center, thank you for that. We are here because we know that we identify a problem and we know we want to move beyond that problem. In speaking to us in this, I would like to begin with this scenario, and I want us to just imagine with me. All of us are just, let's picture this story and then see what we are missing and how it's been painful for us to be in this particular situation despite several decades of effort in trying to improve our public health system. So a scenario in which we have a mother that has taken a child to the hospital for repeated fever. The doctor suspected malaria, and the test came out and they were all inconclusive. I'm sure without looking at what I put on the screen, when we have this type of scenario in our public health facilities, there are several questions that comes to mind. One being that, are we going to question the efficacy of that test result? Are we sure there is no error in this? Yes, that will be done. And then it's repeated consequently, and consequently, we know that it's giving the same result, it's inconclusive. So we know there is no error in the testing. We look again, we ask ourselves, why is the drug not working? Why is it that the person is taking, the child is taking the anti-malaria and is coming back with same symptoms and then down with the same illness? Then we start looking at, are our anti-malaria drug that is being given? Are they not potent enough? Are they fake? All those questions come. But when we are doing this, we also we are not putting time into consideration. And we wonder why today Nigeria seems to be at the forefront of child mortality due to fever. And then before we realize, we start looking at an antimicrobial resistance, which is actually always the dumping ground when we come to situation that our drug is not working. But the truth is that conclusion is always putting us into more trouble because we keep changing the drug and then we keep increasing. Hello? Is there any concern? Can that person mute, please? Can you please mute that person? Thank you. So we now start looking at antimicrobial resistance, which is actually the last, and is a very big problem for us because in the attempt to correct that, we start moving from one drug to the other. Some of us will be a witness to this, that before we get to this level of artemisinin combination that we have on malaria drug, we started with chloroquine. And then the always excuse is that we'll get a point that we have resistance to these drugs. But the question we've not been asking is, could it be genetics? Imagine if we have that scenario well put before us and we have a genetic blueprint for that child, even at birth, just has been done in the developed world, the doctor will know ab initio and will be able to decipher, is this an issue of anti-malaria drug resistance, or is it actually because that drug is not designed to actually treat this particular patient? This is the promise that we are discussing today that Genomics is offering us in our public health system, the promise of precision medicine, where we can tailor treatment to the genetic profile of an individual, where we move from the conventional generic drug to start looking at how we have 99% of this drug working for us as a people. Genomics also promises us disease prevention. Today, we know that Nigeria is the epicenter. Let me put it that way. We have a lot of burdens of several diseases that we've been battling, and our health system have been struggling to overcome over the years. But one thing we've not tried is to look at the way of genetics to see what is actually happening at the genetic level of such individual. Why are some people predisposed to a particular situation and some are not predisposed to that particular situation? We know that hypertension, we know then tuberculosis and diabetes today, they coexist, but we have not that in-depth knowledge when it comes to our own data, how these two diseases interwoven with one another genetically. And yet, could this be the reason why we have TB still a bigger problem for us as a people? Because some underlying diseases actually driving this, why we know that it's curable, and yet we keep having the number increasing year in, year out. Genomics also promises us public health surveillance. We all witnessed to the outbreak in 2020 COVID-19, and the impact of genomics has been mentioned by the previous speaker here today. What genomics has been able to help us do on the global platform to address that menace. We at a very short time, we're able to provide vaccine for the first time in the history of humankind that can address a pandemic. That is what genomics is promising. The problems of genomics are diverse, but these three pillars, which I'm trying to stand it on, is actually what I'm presenting to us in my own view, that if we could, in our public health system, find a way to imbibe the culture that is being, because the world is going to leave us behind very soon. We are not talking about AI in genomics at this point in time, but we are even not yet able to actually decipher and use to the maximum level our own advantage what genomic is promising. Let's talk about why Nigeria the promises, how Nigeria has fared as far as this promises, and how Nigeria matters to the world in issue of genomic. I'll begin by putting to us the importance of Africa as a continent. Today, Africa is said and is known to be the continent that is the birthplace of humanity, meaning it has been documented that people from other continents move from Africa. Yet, we are, just as been mentioned earlier, the question Dr. Chakra was asking that we are on the map. Yes, we're on the map, but the question again is, are we seen on that map? Because if we are seen, we won't have less than 3% of genomic data contributing to the global genomic. While we know we have the most diversity in Africa. And Nigeria matters in this space because even nobody wants to agree that we are the giant of Africa, nobody is going to doubt that we are the most populous nation on the continent. And we are not just in number, we also have diverse ethnic groups, which also put us at the forefront of this diversity, that genomic diversity that we are talking about, that Africa is contributing to the global space. Yet, despite all this, for decades, genomic revolution is largely driven by studies from European ancestry populations. Nigeria and Africa has been left behind, and we are very, very underrepresented in that space. And these are some clinical implications also. The implication is that when clinical trials is being considered, disease risk models are being proposed, and then diagnostics are being produced, our data are not included. And such, we wonder why those drugs, those models that were imported are poorly performing. This is just because we are not part of the picture when those things were being produced. And so we have very little chances in benefiting maximally from those practices and systems. And this is why we need to, and I'm happy that we are discussing this today. From sickle cell to hypertension to malaria-resistant HIV drug progression, we need to be visible. We need to make our presence known. We need to also put some effort in place to make our data available on the global space. It wasn't that the data is not just totally available at this point in time. We do have some data, but looking at the population of the world, it becomes inconsequential. We have an effort that has been put in place through the international app maps that have sequenced Nigerian, Yoruba ethnic group, and just 1,000 genome projects. This is focusing on population genetics, not for health purposes. And yet, it can't that be maximized for health outcomes. We also have today new wave of Nigeria-led and Nigeria-anchored genomic initiatives that is decisively moving us away from the population genetics to public health application. But the question is, we are still like just a drop in the ocean, because what is expected for us to have that impact is not there yet. And I'm happy we're discussing this today. And then I will go further to highlight some of these achievements that some people have leveraged on, and then we'll be able to contribute to the global space. The 100,000 genomics targeted from the national, the non-communicable disease genomic and heritage study is a very good one for us, and is a plus, and is one of the 3% that we're talking about that we have on the global space. We also have sometimes ago, I think around 2020, efforts from SG, that's Professor Appi's lab, to sequence, and NIMA also, to sequence COVID-19 for the first time in Africa, in Nigeria. And this is also a plus for us. Effort is there. We have Nigerian-led effort that are trying to make this happen for us in the global space. We also have some other non-NGOs that also contributed into this space on the institutional level, apart from NIMA and the SG that we mentioned, that was mentioned earlier. We have the Nigeria Bioinformatics and Genomic Network that is trying to build capacity and advance bioinformatics and understanding among Nigeria and then in Africa, so to say. Yeah. We also have the effort of NIMA contributing to genomic and malaria genomic project, where a particular resistance has just been discovered and has been submitted into the gene bank. We also have organizations like Gene Society. That is actually why we exist, trying to advocate and then put some effort into adding to what the Nigerian voice in the global space. Where is genomic in Nigeria today, and what needs are these effort meeting in our public health space? We will mention the sickle cell disease because recently a breakthrough has come into that study, and then Nigeria is also participating because as of today, the Sickle Cell Center in Luti Daraba is promising a cure for sickle cell disease, which is a plus for us. So we are not talking about a completely useless situation for us when you talk of the promise of genomics in public health. We're only saying that we are still scratching the surface. We also, as mentioned earlier, the malaria resistance study that has been just recently, I think it's late last year, from NEM, and then the effort of SG in deciphering the drug-resistant Plasmodium falciparum to actually drive the malaria policy change in Nigeria. I also mentioned the non-communicable disease study that has also sequenced and then cataloged over 100,000, about 100,000 people in Nigeria that has been submitted to the global space. And this is, and also we need to mention a lab like GenLab that is also recently promoting and working on a cancer study related to genomic cancer study in Nigeria. We also know that institutions play important role during COVID-19. We can't but keep mentioning it because that was the first breakthrough public one that is so pronounced that Nigeria were able to contribute in the space of genomics. But before then, we also have an AZ that has actually produced a diagnostic kit and is approved that can test for Ebola and Lassa fever within 6 hours. So these are plus and things we need to applaud ourselves for. So we are on the move, as been rightly proposed and rightly said, but are we there? And then what do we need to do to get to the place we intend to be? So several breakthroughs has been mentioned. This is also part of it. I think we need to also mention the lab in University College Hospital Ibadan, that the effort on the NDM1 and OSA23 resistant pathogen that has been against antimicrobial resistance surveillance. That was also a US study, but that lab participated a critical role in that study, and we are well recognized for that. So we've mentioned what the promises are. We'll talk about where we are as a people and as a continent, and then we'll also highlight that it's not a terrible situation because effort is in place, and it is a continual improvement thing. We are working towards getting what the rightful recognition for us to be able to have a voice on the global stage. But we must admit that we have gaps. There are things that we must acknowledge if truly we really need to move from where we are to where we think we are going. So what are these gaps that we need to put into consideration? Yes, it has been mentioned. Funding is always a subject of the matter. Genomics is very not even funded in the country as it is, if I would say that. Most of the effort that has been discussed were either from individual effort, foreign donor, and then it's not enough because again, those donors we need to speak to their own need, not the need that would meet our own and not things that will meet our need. We have the brain drain. Today, Nigeria seems to be exporting more experts than any other country in the world. The question is, what is taking them away? Why our doctors, why our researchers, why our scientists, our bright minds are actually moving out of the country? These are things that we need to look and we need to consider, even on a platform like this that we are discussing. The infrastructure, yes, we have pockets of them, but they are limited. The unfortunate thing is that in some of those places, yeah, the instruments are there, but the capacity to put those instruments to use are not there. Not in terms of training, but in terms of fundings. There is no point having the tools, but not having the accessories to be able to put the tools into use. These are things that have been limiting us, just like what we're asking, what are the challenges that was asked earlier, that what is stopping us from moving ahead? These are the things that is stopping us from moving ahead that I have identified. The policy is not totally absent. At least, thanks to Dr. Chakra, you have been able to push something to us today that policy-wise and governance, there are things that are being put in place. But we need to move forward to implementation, to massive awareness. How do we let people know what are the opportunities and for them if they are going to come into the space? What are the limitations? What are the boundaries that they needed to actually at least watch out for? The most of the gap is the bioinformatics itself. It is not enough to generate the data. It is easier to go through the sequencing and have the data, but the data, if they are not being put to use, they are not being put to right interpretation, we are still not going to achieve our objective. It is high time that part of the policy should be that we start training people that will build career in bioinformatics. Yes, I have been hosting IBT since 2020, just to encourage us to support and to add to the training. But if we have people trained and then there is no platform for them to practice what they have learned, the training still become useless. These are the things that is actually bedeviling, that is making us not achieving the promises that we have in that Genomics is offering us. And the clinical last mile, which is very, very important for us to actually discuss. How do we move from just having the data, from just having the result, to being able to use the result at the bedside? How do we translate our research into products? These are the things that I noticed and I've observed that has been the limiting factor for us in achieving the maximum and benefit and advantages that Genomics offer on the global space. The way forward, the 8 system interventions just have been mentioned. Thanks the NAFDA representatives are here, and I will be glad. Some of the take-home will be that, yes, the national police has been that it is on ground. Let's open up the more. Let's have more collaboration with NGOs, private institutions. Let there be a true handshake between interagency, government agency itself. How do we limit this bottleneck that all of us will know that we're all working together to achieve the same goal? Create domestic funding mechanism. It is not true. We have TED Fund, and I think recently we have this National Research Foundation also that has just been announced, if you don't mistake. So how do we, as a policymaker, as an interest, as a stakeholder in this, at least ensure that a certain, at least, vote is being given to genomic study and genetic and bioinformatics study on its own, so that we are not just we are building infrastructure, we are making infrastructure to be put to use through continuous funding. We need to be competitive, we need to be competitive about it. Our researchers need to live a life that what them staying and then keeping up with what they do, because once a mind of a researcher is not in the research, there is no way we can get the maximum outcome from that person. Again, we need to do this so that we can at least allow our researcher to be less dependent on foreign donors. We need to expand the infrastructure. We need to make sure that through all geopolitical zones, we have at least functioning and then workable sequencer, and then the necessary and talents and then trainings for them to be able to start from scratch to the point of bioinformatics and results coming out. We also need to, as I mentioned earlier, build them. Oh my God. Apology for that. We also need to actually build the platform for research to clinic pipeline. We must build a business around our research. This is also a limitation for us. People should know that it is not enough to say I've published in a journal. No, as a researcher, no. We must, as a researcher, as an academic, we must to the point that what product is this research going to bring out for me? What are the things that I can use? What innovation? What is the end point of this innovation? Is it changing what is on ground? Is it improving what is on ground? Can it scale to a global space such that we can also generate income to sustain the infrastructure that we have in the country? In conclusion, I will need to take us back again to the story of that child that we started with. That if you have a situation that for every disease burden in the country, just as Dr. Chakra has also mentioned, we have curated data, genomic data, that can be available for use to the clinicians, and we have the clinician trained, also well trained, to understand this data in applying to patients' treatment. We see the beauty that is going to come out. I think I'm very sure that for us to overcome some of this disease burden, this is the way forward for us. We need not go through, the child need not go through the stress of repeated testing, repeated treatment and shifting of treatment for that child, and until we now conclude that decision is hopeless because we cannot even see the real picture. So we keep treating a symptom that we do not know the root of that symptom. And this is a take home for all of us. It is time for us to speak to genomic and bioinformatics in the country. It is time for us to make a separate budget to fund this pipeline such that we can also have a voice in the global space. Policy, financing, the workforce, and the equity are key areas for us to look at if we want to actually address what is keeping us behind, what is stopping us, and really want to put Nigeria on the global map where genomic data and then genomic innovations are being discussed. Thank you very much.
Thank you very much, Dr. Amaho, for giving us a clear picture of where Nigeria stands in deploying genomic tools for infectious disease response. Our next speaker is an associate professor and program director for implementation science at the JBI. This would be a recorded note by Professor Craig Lockwood. to give us an overview of the JBI implementation science.
Hello, and thank you for the opportunity to join your gLocal event. I'm Craig Lockwood, I'm the Program Director for Implementation Science, and I'm here today to give you a brief overview of evidence implementation through the lens of science to bedside and policy to improved quality. gLocal is about local problems being addressed with international evidence, and as we'll be talking about in this session, implementation. There is a clear consensus in the scientific literature that models, theories, and frameworks are unifying and fundamental building blocks without which collaboration through common language, methods, and science would not be feasible. And that's actually a first important value proposition from the JBI approach to practice change. Common language and methods, these facilitate better science, better shared knowledge, and better impact. Implementation, as you know, follows from transfer, synthesis, research, and global health in the JBI model. And it's important for all stakeholders in practice change to know that implementation is underpinned by evidence that has been transferred from synthesis, which was informed by primary research responding to global health needs. With FAME at the center to recognize diverse types of evidence, the JBI model is perhaps the single biggest contributor to successful implementation. So we have to think about operationalization and research into this model. It's important. In JBI, we conceptualize implementation as being as inclusive of context analysis, facilitation of change, and evaluation, which might look at actual structures, processes, or outcomes, or all three. So we have a healthy body of science on facilitation and looking at context analysis and evaluation. And these help us answer important questions for implementation that relate to health system sustainability, how to grapple with the evolving body of evidence and its rapid expansion, and how to deal with organizational uncertainty about what evidence for which context. Part of answering the questions about organizational uncertainty involve education and training in methods that help individuals to be prepared, to be confident and capable in practice change. And if they're prepared, capable, and confident, they can use mechanisms of action that are programmatic, that make co-contributions to improvement, to safety and quality, to patient outcomes, by participating in or leading implementation training, building local capacity and capability, and strengthening organizational partnerships. In JBI, we want to start briefly with the science and then move into policy and practice change programs for your gLocal event by moving from conceptual models to phased approaches to action taking. And I think these examples will be things you already know about. But where do they come from and what drives us to think about them on an event like gLocal? Well, I believe it's this quote. Although science exerts a powerful influence on health, and health is the explicit or at least the assumed reasoning behind a substantial part of the body of science, overall the connection between the two cultures is weak. So could we do better? Undoubtedly. And perhaps by collaboration rather than duplication or competition would be our strongest, cheapest, most direct and most practical way to achieve growth in this area. This represents some exciting opportunities and domains for further research for those of you that would be interested in implementation science. JBI programmatically looks at issues around problem identification and solution, context building, moving into solution building by integrating context with problem-solving approaches, and then measurement of impact, looking at structures, processes, and outcome measures. All of these are derived from the JBI model, informed by an implementation science methodology group that is studying a whole range of topics around ethics, sampling, audit criteria, and impact measures in order to increase fidelity, to increase effectiveness, scalability, and sustainability. If you're going to do implementation, you want to know that it's going to have more than a short-term, small-scale impact, right? So that's why we have gLocal to think about these things. So implementation or practice change using an evidence-based approach is not normal yet. We want it to be more culturally normal in healthcare, and it is across the JBIC, I'm very pleased to say. In the JBI approach, we have audit criteria, we have a 7-phased implementation process model for measuring current practice, and these are key strategies for resolving issues of clinical uncertainty and improving patient safety. So organizational factors that we've already talked about that might contribute to clinical uncertainty include variability in practice that we can't readily explain, ad hoc or sporadic, spontaneous, if you like, uptake or adaptation of evidence, and gaps in important things like stakeholder perspectives and priorities. Do we know what matters to the people that we provide services to? So the cumulative effects of uncertainty is to increase risks around incorrect decision-making, resistance to strategic change, or the other end of that spectrum, change fatigue, and increasing variability in practices that decrease patient safety. So we need pragmatic tools to help overcome some of these challenges. And we want to talk briefly about PACEs as part of the solution to that problem. You see, the value proposition of PACEs and GRIP for implementation lies in the structured, evidence-informed, participatory approach to improving healthcare practices. The strength of this approach is based on 6 characteristics of JBI programs, tools, and resources that we use. Validated audit and feedback tools based on best practice criteria. We're supporting organizations to systematically assess whether care aligns with the evidence. We use evidence that considers patient experience, values, and preferences, not just clinical effectiveness. Its criteria often include aspects of communication, respect, shared decision-making, and culturally appropriate care. And these are core elements of person-centeredness. Our approach is about shared ownership of change, involving clinicians, patients, managers, other key stakeholders, both in the audit and the action planning stages. And this increases relevance of interventions and improves uptake of practice change. Action planning that addresses local barriers and enablers aligned with person-centered principles by adopting improvement strategies to the specific needs of organizations. And there's much more in terms of capacity building, demonstrated impact, and organizational credibility that you can add to your organizational value by using PACEs. The PACEs was developed by clinicians for clinicians. It's an always available online tool that supports any sized policy or practice change activity and designed with a robust guided process to manage and control and facilitate change and engagement. With the increasing and complex demands of healthcare today, the rapidly evolving evidence base firmly in mind, JBI provides evidence-based standardized processes and methods for safety and quality improvement for better patient care. So if in your gLocal, you're grappling with how healthcare facilities can tackle quality improvement, auditing, or evidence-based projects, then JBI PACEs is a complete solution that you might want to consider. It can be used for a whole range of different types of projects, and here's a quick example. So looking at improving the quality of medication administration practices using a JBI approach, this is both evidence-based practice, quality improvement, and audit and feedback with evidence implementation. There's a lot going on. So how do you manage it? You have a common framework. And the JBI approach using this 7-phased implementation process model is an ideal way to do that, even with complex topics in large organizations, such as medication safety. And in the results slide, you can see incremental improvements might not look large, but they can be important and cost-effective over time. So it's worth delving deeply. In PACEs, if the specific criteria already available aren't what you're looking for, there are mechanisms by which you can add and customize, so localize to context everything you need. And of course, as you'll have noticed in the new iteration of PACEs, we've rebuilt GRIP. And this is specifically to increase implementation fidelity and improve the ability to build person-centered action plans. So GRIP is used after an audit to develop an action plan that addresses local barriers and enablers. And this aligns with person-centered principles by adopting improvement strategies to the specific needs of the population that you seek to serve. And of course, by involving clinicians, patients, and managers in both the audit and action planning. So PACEs facilitates shared ownership of change, and this inclusive process increases the relevance of interventions and improves the uptake of practice change. So when you've had a successful implementation project, you want to tell people about it. And gLocal is important for telling people about it. So though is publication. So we encourage people to think about publishing with JBI. Publishing can be imposing and it can lack impact beyond academic credit. Impactful publication looks different, and it's a partnership where the editorial office supports authors, promotes their work, and engages with authors to enhance the impact and global audience of their work via active dissemination collaboration. So that's JBI implementation. That's what we seek to bring to the table for you. You can see a little bit more about our journal on these slides, and I hope that you would give real consideration to publishing with us, as many people that have done implementation projects around the world, including from Spain, from Romania, and from Iran and many other countries as well. Very much gLocal is about global evidence and local decisions. It's interactive and collaborative. It's free and accessible worldwide. gLocal is for knowledge sharing and networking. Its focus is for practical solution, and it's you and your story of impact. Thank you very much.
Thank you all for listening. It is a pleasure to introduce our third keynote speaker for today, Professor George Eleje. He would be examining frameworks, enablers, and barriers regarding what makes evidence translate into sustained practice change in Nigerian healthcare setting. Professor Eleje is a professor of obstetrics and gynecology. He's also an evidence-based medicine expert at the Nnamdi Azikiwe University, Awka. Professor Eleje, you have the floor.
Thank you so much for inviting me for this presentation. And the topic is timely in this time of the world and where we are. And also, I want to thank all the organizers for this, inviting me for this presentation. I also want to thank all the previous presenters that have made my work easier. Here, this immediate last presenter who have just introduced the implementation science. So I'll be presenting implementation science, bridging the no-do gap in low resource setting. Okay, let me put it in a slideshow. I have no conflict of interest in making this presentation. These are the learning objectives. One, we're going to learn what it means to define the problem. What is this no-do gap we're talking about in implementation science? Then what is implementation science? What is it all about? And how can we address all the systemic bottlenecks that impede the implementation of scientific breakthroughs in resource-limited environments? These are the three key things we're going to learn in this. I'm also going to share us some of our evidence-based medicine things we have done in Nigeria and how implementation science are working in Nigeria, how evidence we have, and how we are working, especially infectious diseases and infections in Nigeria. I'm going to give some examples of our publications. So what is the no-do gap? The no-do gap is the disconnect between what we know that works from research and what actually gets done in practice. In a low resource setting, this gap is wider. There are a lot of reasons why it is wider. This no-do gap, what we know works from research and what actually gets done in practice. Limited infrastructure, that's one of the major problems. Fewer clinics, unreliable supply of chain and staff shortages. So as earlier mentioned, there are these people moving out of Nigeria, nurses, doctors, and other healthcare workers. So these are making us, we're producing and we're losing. Now we have competing priorities. The basic needs often take precedence over new interventions. So these are another thing. New interventions may be expensive and we may not be able to afford them. So we rely to what we know before. Context mismatch. Evidence from high-income countries may not translate directly because some of the evidence research are done in high-income countries. So, and they will now, if we are translated directly to Nigeria, it may not work. So this is another problem we have. Then funding constraints. The proven interventions stay on the shelf due to cost. to afford those constraints. So I remember when the issue of magnesium sulfate was first introduced for eclampsia and preeclampsia. Because of the funding, people still were using diazepam, despite knowing that magnesium sulfate is better because of funding constraints. So what will be the result of all these problems? An expected 50% proven health interventions never reach to the people who need them. So these are the problem. Why we are talking about no-do gap. Then what is implementation science? It is defined as the scientific study of methods to promote the systematic uptake of research findings into routine practice to improve quality and effectiveness of health services. So the core question is, we know what works, then how do we make it work here with what we have? That's the question. And what is the key distinction? We don't do anything about it. We know what works. How do we make it work with what we have? That is the problem. And that's what we're discussing. Because implementation science has to promote the uptake of that research into routine practice. In my hospital, in our teaching hospital, our unit have been very known for this implementation science. Whatever we do outcome of the research, we try to practice them. But because of time, we're not going to say everything here. And let's also narrow it to infectious diseases, which is the main theme of this workshop. So why are it different? The low-income countries, are they different? We have context-shaped implementation. Low-resource settings face unique barriers. One of them is system-level barriers is a problem. Quick health information system. So many hospitals today still work on hard notes. They don't use electronic. I think it's only teaching hospitals and some private settings use electronic. We have high staff turnover and tax shifting. So stock outs of essential medicine, these are also problems. And out-of-pocket payment models. Many people today pay from out-of-pocket. In short, it is known from a study we did in Anambra State, only less than 5% of Nigerian or patients, pregnant women, use National Health Insurance Scheme, meaning that up to 95% of Nigerian pregnant women are paying from out-of-pocket. This is also a big problem in this implementation science. The another one is community-level barriers. Geographic access and transport costs is a problem. We are talking about Southeast. What about Northeast? What about North Central and other places? What about Southwest? There are some places where one cannot find it difficult even to move in the night. So healthy literacy and cultural beliefs also matters a lot. A lot of cultural beliefs in what sometimes you might discover something. Due to cultural belief, they say they will not use it. There's also stigma around certain conditions. Somebody may have problem, they would not like it to be mentioned. I remember a situation whereby somebody was told to do cesarean section due to one problem. She refused because he said it doesn't run in their family because there's stigma about it. The same thing other vaccination. People, there's stigma about vaccination in some localities, and they will not vaccine for infectious disease, against infectious diseases. Opportunity cost of seeking care is also another problem. The implementation science here will help by adapting what works to fit these realities instead of expecting the setting to adapt to the intervention. So that is where implementation science works coming in overcoming this barrier. Now, what are the core frameworks for this implementation science? That is, I'll use the word REAIM framework. That's the first one. REAIM is an acronym that evaluates the public health impact of the information science. The first R there is reach. Who is the intervention reaching? That's the issue. Who is it reaching? It's only reaching those who are in the urban location. What about those in rural location? Effectiveness. What action does it achieve? These are things the framework we're going to use in implementation science. What action does it achieve? How effective it is? Does it work? The another one is adoption. Which settings, staff will deliver it? If it's meant to be delivered by doctors, are the doctors available? Can we do what we call task shifting, which I mentioned earlier on? Can it be done so that even less cadre of workers who are in the rural area can adopt it? So these are areas we need to work on in implementation science, and not just say do a research, say it works, and just nothing happens. The other one is the implementation itself. How consistently is it delivered? At what cost? Is it really available? Once a person goes to hospital, is it free of charge? Is it consistent? What about maintenance? Like what we call sustainability? That's M. Does this stick over time? This implementation, these things we are doing in the hospital or for the patient, does this stick over time? Or just use it when the funding is there. Once the funding is no longer there or the donor agents are no longer there, we stop it. So these are things we have to consider in this topic. The second one is consolidated framework for implementation research. The first one we talk is the AIM framework. We'll talk about the consolidated framework, CFIR. This looks at 5 domains that influence implementation. One is intervention characteristics. Is it complex? What's the cost? What's our adaptability? For instance, there may be a form of a drug, and that drug should be given by intravenously. Once you can know that not every health worker can give drug intravenously, and even if they're giving it, they might make a mistake. So these are the things that can affect the implementation science, what some of the implementation science. If it's something that is adaptable, something that easily can be given, maybe oral intake or something that can be just be given by the patient herself. For instance, this time we're talking about self-sampling of HPV. The patient herself can do it. You can see that the uptake will be high compared with when it is given by a particular healthcare worker. What about outer setting? Patient needs, policies, and incentives. These are things we're supposed to consider. The inner setting is the clinical culture, the leadership and readiness. Are they ready to implement it? Is it available? Are there leadership in making sure that these things are available? Is it the culture of the clinic, the hospital, to make sure that this research or some of this research are implemented? Then another thing is the individual, the beliefs, self-efficacy of providers. These are also important. Then the process, the planning, engaging, executing, and reflecting on it. These are all the 5 domains that influence implementation science in terms of consolidated framework for all the research we do. So that different dimensions in the core framework of the implementation science. Then we have another third one by WHO, called framework for implementation science by WHO. They call it WHO ExpandNet framework. It was designed for scaling up implementation science in low and middle income countries. And the focus is on those innovation, user organization, resource team, and scaling up strategy. And these things have been in place. And WHO is try to promote this so that low income countries will expand on this implementation framework. Because that is what the intent now. And we're talking about 2030 target. So for us to achieve the 2030 target, the WHO are making a lot of effort in all aspects of infectious diseases and beyond to ensure that both the innovation, the user organization, the resource team, and scaling up strategy are met. So let's talk about the strategies for scaling up science to bridge the gap in low resource setting. The strategy to bridge the gap. One is we have to design for content from day one. We have to co-create the local health workers and community members. That is important. 2 of them together. We should carry everybody along. That must be community engagement. So, for instance, if a research is being done in a community, or there must be community engagement from day one. We should have to let the community know about the research. You know, when it is thorough, that when you now have done the research and you're now bringing it to the community, from day one, when you're starting the study, the community should know about it. Use human-centered design to simplify the intervention. Sometimes what we call patient and public involvement. These are being advocated today, both in meta-analysis, systematic review, and implementation science research. There should be involvement of patient and public so that they also co-create in that process. Then, the next example is changing 12-pill HIV regimen to single-dose combination, which improve adherence in sub-Saharan Africa. The same thing can also be done in malaria treatment today. We found out that before, people formerly had malaria, the person might take the drug for 3 days. Even injections, some injections can be taken to, like I remember, some will take it morning and night for 3 days, sometimes even more than that. But there have been some adaptation that you can also receive like some injections receive once a day for 3 days. The adherence will be better. Or if you're taking the drugs, you just once a day, second time once a day, and so on, depending on the manufacturer, the adherence or the compliance will be better. So these are ways to improve on this, get community involved in this local context so that to bridge the gap. So you have to design for the content from day one, start involving the community members, the public, the patient involvement in the design of the implementation science study. The other one we'll have to talk about is task shifting and task sharing. This is another strategy to bridge the gap in low resource setting. Train community health workers to deliver services nurses and doctors typically do. So in rural areas, doctors may not be there, or even if they're there, they are scarce. Many of them are leaving to the township. Those moving in the township are living abroad, going abroad. So there's evidence that community health workers can effectively manage childhood pneumonia, malaria testing, hypertension screening effectively, even without the guidance of doctors. Recently, there was a tool we are evaluating now, though the study is yet to be published fully, the trial, but I've done some case reports which are available on public. One can Google it and see 2 case reports on MedBrain. This is a digital tool designed to used by community health workers, nurses in the rural area, so they're able to make a diagnosis of childhood illnesses. And from the trial I've done, though we're yet to publish it, it shows a very effective way of doing so, especially being used by junior cadre of healthcare workers. When we publish it, the trial, it will people will now know fully how this MedBrain works, and more things are being done to improve on this the digital tool. So integration into existing systems is also an important strategy to bridge the gap in low resource settings. You bundle new services with antenatal care, immunization days, or chronic disease clinics. These are what is happening today. Like, for instance, the issue of HPV vaccination now, they have been bundled it to routine immunization. So once a young child is 9 years, once he's 9 years, you know that she's due for what? HPV vaccination. So that has been done to integrate into existing system. You understand? So the same thing in antenatal care. Some of the tests, like the issue of triple removal, effectiveness of the elimination of hepatitis B, HIV, and syphilis before 2030. This has also been factored into routine antenatal care management in such a way that once a pregnant woman books in a hospital that implement these services, the patient will do, instead of doing only HIV and hepatitis B, she does as well hepatitis C and syphilis, and these are monitored. It also reduces cost and leverage existing patient flow. This is another way because if you integrate into existing system, it will help as the patient is coming to follow up. It will now integrate it to the time the patient are coming to the hospital, so that it will not add additional costs to the implementation of that project. These are ways to improve on this, strategies to improve on it. The other one, the use of digital tools appropriately. As I mentioned earlier, the use of MedBrain. But apart from MedBrain, you can use SMS reminders for appointments and medication adherence. These have been used in Nigeria by many donor agencies and are very effective in helping reduce infectious diseases. Simple physician support apps that work offline can be used. You have to avoid tech that requires constant electricity or high bandwidth. So you better use the one that ordinary phone can be used. You understand? So that in this case, digital tools can also be used appropriately. Then fifth one is to identify and support local champions. There are some people in the community who we know that they know that they want to advocate change. You have to work with them. You also have reputed clinicians in the community. You have those who are doing information science, you should work with them. Peer-to-peer learning often beats top-down training. So these are what happens. Identify them, bring them on board on time. So that any research we do, they will help make it palatable to the community, because these are opinion makers, opinion leaders. People listen to them. And once they are convinced about it, if it's being done well in society. With this, we can bridge the gap in low resource setting. The other one is rapid cycle testing. Start small and plan to study cycles in 1 to 2 clinics. We have to fix the problem before scaling to district or national level. We have some case example of improving childhood vaccination in rural districts. I've mentioned it earlier on. Then how do you measure success? This and that thing, because if we are working on this strategy, how do we measure success? Beyond, does it work? Let us see how we can measure success. There are about 1, 2, 3, 4, 5, 6, 7 parameters we can use to measure success. One is acceptability. Do providers and patients like it? That's number one. 2 is adoption. How many clinics are using it? These are things we have to measure success. Having done this, maybe we do this study. Maybe say we did the study only in Lagos, and the implementation study found out that it works more than what we used to do before. Now, after 2 years later, this study or drugs you discovered or something, this intervention you discovered, has it been extended beyond Lagos State? I just give you an example. Appropriateness. Is it a good fit for this setting? Is it something that can be applied more in rural area than local than urban area? Is it favorable? Feasibility. Can we actually do it with available resources? Or just because they brought money, donor agency brought money? The limited resources we have in Nigeria, is it possible that we can do it even in the absence of donor agency? Fidelity. Is it delivered as intended? This one is very important in Nigeria because sometimes donor agency can give us something to deliver to the community, but sometimes you see it diverted to a wrong place. You see it's supposed to be free for people, but people are selling it to make money. This is not fidelity. Cost. What does it take a patient served? Very important, because for instance, this issue of HPV vaccine, before it was the donor agencies will have to subsidize it so that it should be like $1 per dollar, like 1 dose per dollar. Today, a dollar is about 1,500 naira. 1,500 naira can be afforded by all Nigerians of Nigerian children, family. This is a question. So this is a way to make it available. Nigeria government made it free, so that everybody can take it. But originally it had to be for $1 per dose. Sustainability. Will it continue after the project funding ends? Very important. Will it sustain sustainability? Even if we are applying for grant, we have to make sure that our grant, to convince the grant body, we have to convince them that this project can be sustained even after the grant have ended. If we were able to demonstrate it, that it is sustainable, that population science research is not sustainable, then the funders can give us the grant. These are things also to assess in assessing the grant. And if we are able to demonstrate that it is feasible, fidelity is there, cost and appropriateness, adoption and acceptability for people and providers. These are ways to measure success. And if we use this parameter to design a score, we can design it ourselves, or we can do a research to find a score that will be better using these parameters so we can measure all implementation studies done in Nigeria. It will be a wonderful intervention if we can do that together. So we have a few case studies I have. Without wasting our time, we'll just summarize them. 1 is on maternal sepsis. 2 is malaria in pregnancy. Another one, integrated prevention models, triple elimination clinics for elimination of HIV, hepatitis B and C, and syphilis during the first antenatal visits. So this is a study we done in Anambra, in Nnewi. Intermittent preventive treatment, malaria, HIV, hepatitis, and pregnancy outcomes in Nigerian women. It was observed that the outcome of the implementation science is that in pregnancy, a pregnant woman should receive the SP, so what does it permetamine, for prevention of malaria. So these are the things we observed, that those patients during this study, we found out that those patients who are receiving IPT, their malaria transmission, that is the placental malaria rate among them is 0%. But those who are not taking the SP, the malaria parasitemia among them is very high. So it's fairly high. So that's what we also observed in this study. This is one of the examples of implementation science in action. that those who are SP adherents tend to reduce the incidence of placenta malaria compared with those who are not adherents to SP. But the SP adherence rate in the hospital is about 73.9%. So the remaining percentage contributed to the malaria prevalence observed in this study. That will tell us that infection science is in action. That if we can buy it, out it, and take it, it will help us. It will reduce, almost put malaria in pregnancy to 0 level, or in affecting the baby, because malaria can attack the woman, but we're talking about baby affectation. The baby placenta malaria rate among SPs are almost 0% in a number from the study we did. For this study we published recently last year. This one is a systematic review we did with it was supported by some bodies in Nigeria. We did a meta-analysis on systematic review on prevalence of and types of healthcare associated infections in Nigeria. We were by Omulere, Adebisi, Eleja, and others. So infections acquired during treatment for what we assessed. And after electronic search, 16 studies were included that involved a 6,772 participants. The results show that the skin and soft tissue infection is 16.43%, surgical site infection 22.17%, urinary tract infection 32.54%, which appears to be very high. And the common organisms you can see are Klebsiella, Proteus, and then Staphylococcus aureus, Klebsiella, and Pseudomonas. So the key risk factors are surgery, HIV infection, pre-antibiotics, and endotracheal infection. So these are there's also a scarcity of data on multi-drug resistance. So we encourage more people to do work on multi-drug resistance and publish it for more systematic review to be done in this matter. The other example of high profile showing that infection science is working today is on issue of triplex infection. This was a study, a grant we got from TETFund NRF in 2019. It was found out that we did a dual and triplex HIV, hepatitis B, and hepatitis C infection among Nigerian prosthetic population, National Multi-Center Prosthetic Cohort Study. It was a 6 tertiary hospitals involving 6 zones of all the zones of Nigeria were involved. We were able to recruit 2,775 pregnant women. I was the prevalent infection in this study. We determined the solo prevalence, solo conversion, transmission rates among pregnant women. We looked at, and it was validated by PCR technology. So these are what we found. Triplex infection was 0.14%, 0.14%, dual infection was 0.47%, dual infections, HIV, HBV 0.22, HIV, HCV 0.14, HBV, HCV 0.11. By the end of the loss infection rate is 0.12%. And the more interesting is the mother-to-child transmission rate was 0%. That will tell you that the infection science is working here. If people take the drugs, they are pregnant, they take either HIV positive, they take heart therapy. Then for those who have hepatitis B, they will take immunoglobulins, or by the time they deliver, they would also give the baby immunoglobulin, joint immunoprophylaxis. When we follow them up till 6 weeks, the mother-to-child transmission rate was 0%. So showing that infection science is working well on this aspect, on this viral infections. This is also another one we did a systematic review and meta-analysis on triplex infection itself. Prior to this one, prior to time we published that, the last study, what was existent in Nigeria then, and we found out that the put prevalence is 0.03 for triplex infection. A woman who is pregnant having both HIV, hepatitis B, and C all together. We know the problem. All the 3 killer viruses are there, and the implication. I think my time is going up. Before then, I have passed my time. So let me summarize. Why inflation lags? I've already mentioned them. Health system fragmentation, data and supply chain fractures, human resources and workload demands, and financing barrier. I've all mentioned them earlier. Why inflation lags real world bottlenecks. So what is the take-home message for all of us here? 1, we should start with the end in mind. If an intervention can't be delivered by existing staff with existing funds, we have to redesign it. And that is why you have to involve the population, the patient, the community, ab initio from day one. But if we do a study and they cannot go to buy it, the idea, it will not work. Why saw the study when the implementation sign that it will not work, the community will not take. So you have to get them involved initially. Context is not noise. It is the remain thing. Document and adapt to it. Involve them earlier. That's what information scientists are doing today. Let the committee know what you are doing in time at the co-design of the study. They should be part of the co-design of that study. If it's different, share their views and readapt it to them. Another one is perfect is the enemy of scale. A 70% effective intervention that reaches 90% of people often beats a 95% intervention that reaches 10%. Do you understand it? So if a 70% effective intervention, but you're able to reach 90% of people in the implementation stage, is better than you have 95% intervention that reaches only 10%. So perfect is the enemy of scale. Implementers are researchers too. So frontline staff inside are data. So build feedback loops. Always see what people are doing. Have a feedback on what you are doing. Very important. In that case, we'll be able to overcome the barriers of information science in Nigeria. Remember, the goal is not just to generate evidence, but the main goal is to generate change, my brothers, my sisters. These are my references. Thank you for listening.
Thank you very much, Professor Eleje, for addressing the systemic bottlenecks on how to bridge the no-do gap in low resource settings and how to build a feedback loop. Our next presenter is Dr. Ekaite Tobin, a public health physician and head of surveillance and data management at the Institute of Viral and Emergent Pathogens Control and Research at the IRUA Specialist Teaching Hospital. She will discuss the intersection of real-time surveillance data, viral pathogens control, and evidence-informed public health response. Dr. Tobin, you have the floor.
Thank you very much. Good morning, everybody. Permit me to share my screen, please. Okay, can you see my screen? Hello?
The screen is still coming up.
Okay. Can you see my screen?
Yes, it is up now.
Okay. Good morning, everybody, and thanks for having me. I'm going to
Sorry,
speak
Doc,
on
you need to put it in sorry, Doc, you need to put it in a slideshow. Yeah, great.
Oh, okay. I thought I'd done that.
Done now.
All right, okay. So I'm going to take us through a brief lecture titled Surveillance, Outbreak Response, and Evidence, Public Health Perspective. My name is Dr. Ekaite Alice Tobin. I'm with the IRUA Specialist Teaching Hospital. I'll start with this quote from Dr. Alexander Langmuir. He lived 1910 to 1993 and retired as a chief epidemiologist in CDC. He gave a lecture in 1962 at the Harvard School of Public Health, and the quote is taken from that lecture. Good surveillance does not necessarily ensure making the right decisions, but it reduces the chances of wrong ones. And on that note, I'm going to walk us through this outline from looking at the new global health reality to take us through why public health surveillance matters, the concepts and types, the attributes of an effective surveillance system, right down to case studies, the epidemic landscape in Nigeria, and leave us with the way forward and key messages. So in recent decades, outbreaks of emerging and re-emerging infectious diseases have plagued the landscape globally. We've had SARS, H1N1 influenza, we've had Mpox, Zika, Ebola hit the West African sub-region strongly. We have had COVID. We repeatedly have Lassa fever outbreaks, and now we're talking about hantavirus. Tomorrow it may be disease X. And these are driven by population growth, migration, trade and travel, climate change, and all the ways humans interfere with the ecosystem, as well as conflict. WHO tells us that 75% of emerging infectious diseases are zoonotic in origin. And gradually we're moving from a stage where we talk of national health security to where we are talking of global health security, because the two are gradually becoming inseparable. Now, public health primarily aims to protect populations from disease, disability, and death. And surveillance provides the groundwork for that to happen, enables early warning systems that lead to development of interventions to curb disease outbreaks. Without surveillance, outbreaks would be detected very late, responses would be delayed, economic disruptions and social instabilities will all follow. So it leads us to the question, what is public health surveillance? It is the continuous systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of public health practice, closely integrated with timely dissemination of this data to those who need to know, those who are responsible for prevention and control of disease in human populations. So public health surveillance tells us what disease is occurring, where is it occurring, who is affected by defining vulnerable populations, how fast is it spreading by measuring transmission rates, and what interventions are needed, where we talk about evidence-based public health actions. Now, we can say that there are 4 core components of surveillance. So from data collection, where we collect data on different indicators and variables, from case notes, from vital registration systems, from the animal and the environmental health sectors, we gather and organize and systematically analyze this data so that we have it we characterize the persons involved, the place and the time, the trends, and then interpret them, converting this data into actionable public health decisions that would impact in reducing deaths and loss of lives and property. As well as then the final component is dissemination. So these findings are now communicated to decision makers, policy makers, stakeholders, clinicians, and the public. And an effective surveillance system should be sensitive in that it should be able to pick disease threats when they are there in the environment. It should be timely. We should provide this data early enough for appropriate actions to be taken to reduce mortality and morbidity. It should be flexible, adapting to changing information needs, operating conditions. So when we had COVID-19, monkeypox, we didn't have them in our IDSR, but we're able to include them. That's flexibility. It should be acceptable to the users. The people who are collecting these data should not find it difficult should be willing and ready and able to collect that data. It should be such that the data collected is of high quality. We all know the phrase, garbage in, garbage out. The data must be of high quality so it can be used. And it must be representative in that it actually accurately reflects the distribution of disease by person, place, and time. Now we talk about the surveillance cycle, where we start with identifying a threat, a report in the community, a cluster of cases, a rumor, whatever it is. We gather this report, these notes that we've made systematically, enter them into formats that can be analyzed. We interpret them, know what the threats are, characterize them by time, place, person, then develop an action plan, respond. When we finish responding, we communicate this, we evaluate our measures, we sit back and look at what worked, what did not work, and then prepare for the next threat, because threats will always arise, threats will always be there. So that's the surveillance cycle. Now, public health surveillance data, apart from being important in detecting outbreaks and emerging public health threats, it helps us track changes in health behavior, informs public health planning and decision-making, It supports the effective allocation of health resources because we now know where the threats are. We now know who is being affected. We now know the geographical distribution. So we're able to allocate resources effectively. And then we're able to, with surveillance data, we're able to evaluate our prevention and control interventions. Are they working? What needs to change? Still speaking on surveillance, we have two main types. You have the active surveillance, which is the ongoing search for cases in the community or health facility. The health professionals physically go to collect that data, or they make telephone calls, but there's an active participation on the part of the health worker to gather information, to gather data on health and health-related events happening in the environment. The other one is the passive one, where facilities just routinely report to the higher level what is going on in their locality. There's no active search for cases. But when it comes to looking at channels of signal generation, we have two main types, the indicator-based surveillance and the event-based surveillance. Now, indicator-based surveillance collects structured data from well-identified, mostly health-based formal sources. So these ones are structured data. We know what were the indicators, the variables we are collecting. We know the timeliness. We know the timings for this data collection. We know where we are collecting them from. So we have the different types. You have the facility-based surveillance where health data is reported to the next level from health facilities. Laboratory-based surveillance where laboratories report routinely confirmed cases, looking out for cases that are diagnosis, laboratory test results that are unusual. We have disease-specific surveillance, which could be like your HIV. These are vertical surveillance systems that only focus on one disease, very specific to the disease. Then we have case-based surveillance, where we look at all those diseases that are tracked for elimination or control, eradication, where we collect, when we see a case, we complete a case investigation form. And during outbreaks, like outbreaks we have of Lassa fever, of monkeypox, we complete case investigation forms. Then we have the sentinel surveillance. Dedicated sites are identified and given these tools, surveillance tools, to collect this data. We have the influencers, for example, we have the influencer sentinel sites that collect information on respiratory systems and send them to a dedicated platform. They have a stream for that. You also have syndromic surveillance which are based on symptom patterns and track diseases based on symptoms that people present with. You have the community-based surveillance where community informants identify unusual events in populations that they serve. And environmental surveillance that monitors pathogens in the environment, either in wastewater, in air. These are all forms of the indicator-based surveillance system. The other approach, as I said, is the event-based surveillance. Now, this one collects unstructured ad hoc information about unusual events or rumors. So you collect this from media reports, social media reports, people calling, telephone hotlines where people call in to report observations. These are features of an event-based surveillance system. Now, but modern public health has moved from that. So we're moving from traditional surveillance system that focuses on humans. We're now talking about integrated data systems where you use the One Health approach to connect health facilities, human facilities in the human health sector with environmental data from environmental monitoring, and all feed into, we use the word one pot. And how does this happen? We use digital technologies to convert this surveillance data into outbreak intelligence. So you have your GIS mapping that looks at disease surveillance data, plotting them into hotspots and maps that display location. We have artificial intelligence and machine learning that use large data to pick out what is subtle changes in health that are in disease prevalence that may not be missed by humans. So they predict spread. We can use them to predict spread, to forecast, detect unusual patterns. You have genomic sequencing. All these are new digital tools that are being put into the modern public health surveillance to make it interoperable and integrated. Genomic surveillance, we used to identify viral pathogens. We used to track their changes. We used to track their spread. We used to trace them as they mutate and proliferate in environmental like wastewater, environmental sources. Then you have the real-time dashboards that are used to give pictorials, real-time displays of how diseases are evolving, infectious disease outbreaks are evolving. These are all digital tools that help us integrate and our data so that we use the One Health approach and we can see data arising from different sources at the same time, track outbreaks. These digital technologies also use digital surveillance platforms like the SOMAS. You have the Surveillance Outbreak Response Management and Analysis System. You have the District Health Information System. You have the Epidemic Intelligence for Open Sources. You have health maps. These surveillance platforms use these digital tools to give us real-time epidemic monitoring. How does this help us? It enhances surveillance, epidemic intelligence, and outbreak response. This is where modern public health has gone, and in fact is even improving by the day. So what are outbreaks? An outbreak is the occurrence of disease cases in excess of what would normally be expected in a defined community, geographical area, or period of time. The public health implication of outbreaks is that uncontrolled mobility and mortality will increase, particularly among vulnerable populations. There will be economic disruption and social instability. We saw this greatly during the COVID-19 pandemic. There'll be a lot of pressure on health systems because healthcare worker needs, consumable needs will not have been planned for. So there'll be overflows in people requiring healthcare. Health systems will be saturated. Healthcare workers will be burnt out. And then fear, stigma, and misinformation will follow, just as we saw again with COVID-19. So the basic steps in outbreak response are, first of all, to confirm and verify. So you confirm the existence of the outbreak and verify the diagnosis through laboratory or clinical means, laboratory testing. Then you define and identify. You establish a case definition and go on active case search to find cases across the affected population. You do your analysis, you characterize the outbreak by person, time, and place. You develop your epidemic curve and spot maps to better define your other actions that you're going to take so that your actions are targeted and meet the effective in stopping the outbreak. You generate and test your hypothesis through analytical studies or case control studies so that you refine your action. Then you decide on the control measure you're going to use to stop the outbreak. You implement it, communicate your findings, and then you monitor outbreak, the effectiveness of your response. These are the basic steps in outbreak response. Then the activities include your case investigation, contact tracing, where we look for people who have been contacts to the cases and we follow them up for defined periods, isolation and quarantine as the case may be, if it's a disease that requires isolation or quarantining, laboratory diagnosis, infection prevention and control, vaccination and therapeutics, as well as risk communication and community engagement. These are all activities that are carried out during an outbreak response. And what we're moving to now is what we call the 717 concept, where countries aim to detect outbreaks within 7 days, notify public health authorities within 1 day, and initiate effective response within 7 days. So we're emphasizing timeliness, we're emphasizing accountability, we're emphasizing a coordinated preparedness. And this promotes, but if we go by this, we would have rapid detection of outbreaks, rapid responses, and reduced untoward effect from the outbreak. Now, we also know there's this outbreak management cycle that starts with detection, response, recovery, and preparedness. And this, we're going to speak so much on the detection and response, which links surveillance with public health action. Now, surveillance is only valuable when data are transformed into evidence and used to drive public health action. So when we have this data, we collect the data from case reports, from community alerts, from laboratory results, from infectious disease modeling, using all the digital tools I've spoken about, as well as past data from after action reviews. We have all this information. We have an outbreak in our hands. We're able to map out and develop trends, epidemic curves. We've done the analysis, we've done an analytic studies, and we know the risk factors, transmission patterns. What next? That is where evidence, that is where surveillance now needs to ensure that this data that is collected is suitable to, is sufficient to answer the question, what works and what should be prioritized. That is where evidence comes in. That is where our next level comes in. And we'll see that very shortly. Now, so we're talking of from public health, as I had said, data collection, surveillance, and all that, now to evidence. Now, decision-making, public health decision-making does not only arise from surveillance data alone. At this point now, we're drawing in public health resources, we're drawing in research findings, we're drawing in views of the community, we're drawing in policies and the political contexts in our environment to take effective, informed public health decisions. So when we have done all this, we have the information we need for action. We have the information we need to define the next step that we're going to take. That is what we mean by evidence-informed decision-making in public health. You combine evidence, you combine information from various sources to take, looking at not just surveillance data, but all the sources to put together some action that answers what works and what should be prioritized. Now, evidence-informed decision must be translated into actions that deliver tangible public health impact. So it's not just enough to use this information at our disposal to take decisions. We now need to figure out what actions do we need. And very importantly, these actions must be impactful. So actions include ensuring that we make appropriate vaccination policies, bearing in mind that the culture of the community, the culture in place, the social norms and belief systems, the cold chain systems we have in place, the number of healthcare workers we have to deploy vaccines. Action includes determining which non-pharmacological intervention is needed. Just as we saw in COVID-19, we talked of social distancing, we talked of face masking. All those were actions that were born out of informed decisions that were taken by our health planners and health managers. Travel advisories also is a form of action that is taken after we've made decisions, drawing from the evidences we've got from data. These are all examples, policy decisions, IPC measures. That is how we came to know that we must do our hand hygiene, we must respect cough etiquette and the rest. All these are actions. And what does that lead to? The impact, very importantly, would be to control the outbreak, reduce mortality, ensure that resources we have are used effectively, used efficiently. And at the end of the day, we have stronger health systems coming out and healthier communities. Well-informed communities, in communities that are able to take care of their health, communities that are responsive. So we're going to take very few case studies. We're going to look at COVID-19 pandemic to see how surveillance fits into evidence, and evidence drives public health decision-making and action and impact. So COVID-19 is one of the greatest global public health crises in modern history. From December 2019, when a pneumonia cluster was detected in Wuhan district through clinical surveillance, genomic surveillance by 2020 that identified SARS-CoV. PCR testing was scaled up globally by between 2020 and 2021. And genomic surveillance was able to track the variants of SARS-CoV. That is where we started talking of Delta and the Omicron. After 2022 and beyond, wastewater monitoring became the community level indicator that we needed to know if there were silent transmissions, maintained within communities. And by April 2024, over 700 million cases have been detected with over 7 million deaths globally. So looking at the lessons learned for surveillance, rapid genome sequencing enabled fast variant tracking. Real-time dashboards transformed public communication. Wastewater surveillance provided early warning systems even when everything appeared quiet. Global data sharing accelerated the response, and syndromic surveillance enabled early detection of new waves of transmission because they just saw clusters of people. When we saw clusters of people with respiratory symptoms, we knew that a new wave was going on. Rapid vaccine development was driven by surveillance data and genomic sequencing. So the key lesson for us in COVID-19, surveillance provides the evidence needed for the development and evaluation of public health interventions. But there were a lot of challenges even at that, and there are still these include fragmented, non-interoperable surveillance architecture, supply chain failures, health systems overload, economic disruptions, travel and border policy fragmentation. Some people allowed people enter, some countries allowed people enter, some did not. International coordination gaps. There were countries were slow to respond. They were not IHR compliant. Infection prevention and control there were so many gaps across health facilities, misinformation and infodemics, vaccine inequity, public distrust and vaccine hesitancy. We saw that all during COVID-19. Now let's quickly look at Ebola. 2014 to 2016 saw the largest Ebola epidemic in history with over 28,000 deaths, 10 countries affected, and a whopping 21 months before containment. But what are the surveillance lessons we can learn? Community engagement and local health worker networks proved essential for case finding. Contact tracing was a backbone of outbreak response. At the time, during the peak of the outbreak, there were 25,000 contacts monitored daily. Vaccination strategy demonstrated the evidence to action pipeline in real time. So we saw it being used during the Ebola outbreak, and it's still being used today. Public health emergency operation centers became the nerve centers. So they were where the decisions were taken, where logistics were planned, disseminated, and there was this coordination. An outbreak investigation was seen to follow the systematic steps I had earlier discussed. Star action reviews were refined and improved interventions. Again, just as in COVID-19, Ebola also had its gaps. Weak surveillance and delayed detection escalated the outbreak. Laboratory capacity was very poor. Again, IPC systems were very weak. Healthcare worker falls required, and such capacity required health workers to be brought in to support in-country health workers. There was a lot of lapses with coordination, community mistrust, logistics, supply chain failures, and international response was slow to start. Let's quickly look at Lassa fever. Annual outbreaks, it's spread by the Mastomys staphylococcus rodent. Annual outbreaks occur in Nigeria, underscoring the need for lab confirmation by PCR, rodent control and community hygiene education, as well as healthcare worker infection training, not just on case management, but also on infection prevention and control. The challenges to surveillance with Lassa fever are non-specific symptoms, delayed presentation, because people, first of all, think it's malaria and go around in circles before they decide to come to health facilities. Weak referral systems, community misconceptions, including stigma, fear, and all the local beliefs that follow our traditional systems. Limited laboratory access, particularly for confirmation, and particularly from rural areas that are hard to reach from central locations where laboratory capacity is. However, some strategies have been found to be effective. Community-based surveillance, sample collection and diagnosis can be prompt because that capacity has been built in country. Isolation and case management, including all the policies and guidelines and SOPs that are needed. Contact tracing strategy is on track in the country and has been built up, although there are gaps again. Risk communication, healthcare worker trainings have occurred, and we have gradually refined rodent control mechanisms. Also look at dengue surveillance. It's transmitted by Aedes aegypti, 100 to 400 million infections annually, endemic in Asia, West Pacific, Latin America, and Caribbean. And outbreaks are seasonal and occur as a result of heavy rainfall and poor environmental sanitation. Entomological surveillance, epidemiological surveillance, laboratory surveillance, genomic surveillance have all been involved in the prevention and control of dengue. And what we're talking about now is integrated vector management, case management, and community engagement. Now, beyond surveillance and response, there are some human and factor systems that determine success. So you have community engagement, risk communication, sustainable financing mechanisms, vaccines, therapeutics, and public trust. I'll discuss them very quickly. The communities are our first point of outbreak detection. They are critical partners in prevention because they help with countering misinfection, promoting healthy behaviors, support contact tracing, and are essential for building trust. So whatever we're doing in surveillance, decision-making, and outbreak response, we must empower the communities, involve the communities. Once we have their buy-in, acceptance of preventive measures, behaviors, health-promoting behaviors become easier. Then we have risk communication. Poor communication worsens outbreaks. Effective communication should be timely, accurate, culturally appropriate, and consistent. And if we can ensure that we have effective risk communication, we would have improved public trust, we have reduced panic, and people will comply with public health measures, actions that are born out of the evidence-based decisions that we take. So what's the take home for this? Provide timely, accurate, transparent public health information, monitor and address misinformation and rumors, use trusted community voices to deliver key messages, promote two-way communication and community feedback. Now, the last one is sustainable financing, not the last, second to last, sustainable financing for health emergencies. Epidemics always take a lot of money. And you can see from 54 billion in SARS between 2004 and 2009 to 9.5 million to control measles in Kenya. Epidemics, pandemics, whatever they are, they always cost a lot of money. And yet investments in pandemic preparedness is inadequate. Peter Sand said this. Now, so what do we need? We need we cannot take sustainable financing in silos. So it must be a combination of domestic investment, emergency financing systems, development partner involvement, and public and private partnerships. So we have that there. Government must allocate adequate resources to epidemic preparedness, which build on global and regional emergency funds, develop tap into development and multi-partner support systems, tap into innovative financing mechanisms, encourage public partnerships, as well as the mandatory WHO member state contributions. Then vaccines and therapeutics have transformed the way outbreaks run. However, unequal vaccine access, vaccine nationalism, as we saw in COVID-19, weak health systems and vaccine hesitancy continue to undermine all the efforts. Now, Nigeria's current epidemic landscape is plagued with Lassa fever, cholera, monkeypox, measles, diphtheria, meningitis, and the rest. However, there's been some progress in our surveillance system. NCDC is the coordinating center. Emergency operation centers are in all the states. Surveillance has improved and is now getting interoperable. One Health collaboration is ongoing. Molecular lab capacity is in all the states. Genomic surveillance is now on board and expanding by the day. Treatment and isolation capacity are in all the states, at least most of the states. We now make use of digital reporting platforms and dashboards. There's always one form of healthcare worker training or the other, and risk communication and community engagement has improved over the years. However, we still have the same challenges: poor funding at national and subnational levels, health manpower shortages, uneven surveillance quality across states, poor wash infrastructure, insecurity, weak cross-border surveillance and point of entry. What is the way forward? For preparedness, it should be a continuous investment, not a temporary one-stop activity that comes on during outbreaks and goes off after that. We should strengthen community-based surveillance system, integrate digital technologies into surveillance systems, strengthen laboratory capacity and genomic surveillance, increase funding for preparedness and research, strengthen One Health partnerships, build community trust, very important, and engagement, invest in our health workforce, encourage cross-border collaboration, build on regional and international partnerships. Key message then, if we do all this, surveillance, key message is surveillance, rapid outbreak response, and evidence-based interventions remain the pillar of global health security. Public health must move from reactive outbreak response to proactive preparedness. Rapid response prevents outbreaks from becoming global, and evidence must guide policy and intervention. Community engagement risk communication, sustainable financing, and promoting vaccine and therapeutics are also important for successful outbreak control. No country is fully safe until the global health security systems are strengthened. Thank you very much, and these are my references. I hope I have finished right on time. Thank you.
Yes, Ma. Thank you very much, Dr. Tobin, for walking us through why public health surveillance matters and what makes it effective to drive public health action. We welcome back Dr. Abubakar Usman, the Medical Director at the Federal Medical Center, BIDA. He is to be represented by Dr. Amos, who would share real-world experiences that implement evidence-based protocol at the Federal Medical Center and explore what worked and what required adaptation. Dr. Amos, you have the floor.
Thank you very much once again for having me back. And good afternoon, everyone, for the time well spent from morning up to this moment. Let me see if you can share my slide. If I have problem doing that, you have to help me from the other side. Sorry, I think you can do that for me from the other side. I'm having problem doing that on my own gadget here. Please, can you help me share my slide from the other side?
Yes, it will come up.
Okay, thank you. Thank you for that. Okay, thank you very much. In the next 20 to 25 minutes, we'll be taking us through clinical evidence in practice, infectious disease at tertiary level. That is the real-world experience, implementing evidence-based protocol at Federal Medical Center, BIDA. This is just a practical example of how in Federal Medical Center, BIDA, we are able to move from evidence-based care on paper to implement most of the protocol that help our patients, both in the ward and even at community level, through our community arms of the hospital. Don't forget, for every tertiary institution, there are arms of research, training, and clinical practice. So FMC is involved in all. We have our own local data for evidence of what works within our community, and we have that from the nation that we also implement vis-a-vis even at international level. So let me just tell you that, as I said earlier in my first presentation, that healthcare evidence is only valuable when it improves patient outcome, both at bedside or at community level or at population level during outbreak of diseases. So at tertiary facility, the challenge is not barely knowing what works. We actually know what works. We have evidences from our research, both at local, national, and international level. But the problem lies in implementing what works consistently, sustainably, and effectively. So this presentation shares practical lessons from our experience at Federal Medical Center, BIDA. Just a brief introduction of the institution. Federal Medical Center, BIDA is one of the tertiary health institutions in North Central, in Niger State, and we have a large catchment population ranging from the BIDA and BIDA metropolis, MENA. Sometimes we receive referral from Ilorin, from Nasarawa, from National Hospital, even from the Northwest and Northeast region. So we actually have a variety of referral from that. So we have no any option that to standardize our care and to make sure that the evidence on ground are translated into impact by the bedside. So we receive referral from urban and rural communities. And for majority of what we engage in terms of clinical treatment, infectious disease stand out of all of them. And this is not limited to malaria, tuberculosis, HIV-related illnesses, sepsis, acute respiratory infections, and gastrointestinal system. So now, why evidence-based protocol matters to us at Federal Medical Center BIDA? As we all know, and from all what have been said by the scholars from the beginning of this section up to now, please slides, can you help me change the slide here? The evidence-based protocol helps us to standardize our care so that it is comparable to other neighboring institutions, even at other tertiary institutions not close to us, and even at international level to some extent. Then to reduce clinical variation, that within our own clinical setting here, treatment should not differ. You know, in clinical setting, you have various specialties, you have various units headed by consultants. So if there are no protocols from evidence-based care that work, that has been proven from research, it therefore means every unit will be doing things on their own. So we found evidence-based protocol to matter to our care to reduce clinical variation and also to improve in treatment outcomes. When you have a protocol that everyone follow, the end will usually be the same. So it also enhances patient safety. When you adhere to what works, what research has proven to be right, the end result is that there is patient safety, even within the same department, outside the department, and even outside the hospital setting. So it also improves resource utilization. When you have the same protocol, infrastructure and equipment that help you to implement those protocols are usually on ground. It's when you started having different variation that you will need more extra instruments or infrastructure or even staff. So it helps improve resource utilization, and it also strengthens accountability. So we should know that consistent care leads to predictable outcome. Once both of you are on the same level, the essence is that you have a predictable outcome. Next slide. So I want to take us through our implementation journey. And the key question is, how do we move from guideline on paper to improve patient outcome in our own setting here? As I said earlier, we have a lot of evidence. We are into research, both at local level within the hospital setting, in different arms of the department, be it obstetrical gynecology, pediatrics, surgery, and so on. So now, how do we now move this guideline on paper to improve the patient outcome? That is where our implementation journey starts. And we have gone so far in various aspects of disease condition, both infectious and other aspects of, mostly both on infectious, that is our core discussion for today. And our approach is to focus on protocol adoption. That for the evidence we have in ground, either in malaria treatment, either in diagnostic for various infectious diseases, we have to adopt a protocol for which all the departments concerned we adhere to. Then we reach out to the staff engagement. Any protocol that is adopted or that has not been adopted, your staff must be informed. So we engage our staff at different units to let them know about the protocol, to let them know about the research funding, the evidence here that work, and the one either at national level and those ones that we adapted from international level. So there was a staff engagement. And now we also move from that to capacity building. This capacity building in terms of human resources, in terms of structure, laboratory, and other adjuvant side that can help us to implement and adopt this protocol. So there was capacity building, both in human resources at different cadres, be it nurses, be it doctors, pharmacists, and other allied health workers. And of course, when you put a protocol on ground, you have informed your staff, you have capacity building on ground, then monitoring of the compliance become another thing. We set up a team that work around with a mandate and vision at site to monitor compliance of this evidence-based drafted protocol at different departments as it concerns. And each of these very monitoring teams have a specialist, a concern about that very condition at various departments. And we have continuous improvement on what the monitoring team come up with that we should improve on to make our protocol well adopted. Next slide. Then our priority areas. You know, we have a lot of evidence on ground in different departments, but we are focusing today on infectious disease. And among infectious disease, we look at malaria management protocol, antimicrobial stewardship, infection prevention control, sepsis recognition and management, tuberculosis screening pathway, and laboratory-supported diagnosis. I may not be able to go through all this, but I will pick some as an example because all of them have the same template, only they are the different at different arms. Next slide. Then, for every protocol or for every change that is needed, there's usually a barrier because people are used to some certain processes, to some certain treatment protocol, and they will find it very difficult to change to a new one. So we have this in mind, and we look at what are the barriers that we can face so that we can address this barrier to make the protocol work very well. And one of the barriers is that that prompt us to develop this protocol is that there are variability in clinical practice. Yes, you work in the same department, you work in the same specialty, but different healthcare leadership have their own different approach to management. And this ought not to be so, since we have an evidence available with us that we can work with that are proven from research to have worked better. So this variability we know causes trouble for us within the hospital. Inconsistent protocol adherence, limited diagnosis resources, documentation gap, workforce pressure, and supply chain interruption. So this reality actually influenced implementation decision by the Federal Medical Center leader of our leadership. So one of the strategies that we employ in coming about enacting the evidence-based care as a protocol to all our patients or the community that we serve and the population at large is leadership engagement. Change begins with leadership. So leadership support was critical action that was included. As the leadership, there were clear institutional commitment. Our medical director buy into all this. He is also a clinician, a researcher, and he bought into the institutional. He bought into this very aim that we have in improving, adapting, proving evidence-based care to our patient by bedside. There was also departmental ownership. All departments were summoned by the head of the hospital to let them know about certain protocols that we want to develop that will help in implementation. If you have a protocol, people that will use the protocol should know about it. They should own this very protocol. They should own this evidence-based practice that they want to put into protocol to impact their patient care within the ward. So this also makes us to create a clinical governance meetings headed by experts to make us walk through the protocol, what is needed, both in human resources, infrastructure, and what we need to have, and what we need to improve on, even monitoring and evaluation of those. Then performance monitoring was also saddled with, was given into a care of a team that will be looking at it from time to time, quarterly basis, to know whether this protocol is performing in terms of monitoring and evaluation. And there were also consistent, continuous feedback mechanisms. So one of the strategies that worked for us is that there was leadership engagement at various levels. Next slide. So another level is staff capacity building. And we have said earlier that all what we have mentioned, as beautiful as they are, if you don't have staff or staff or human resources that will help you unfold this very protocol, that will help you unfold the evidence-based care that you are trying to adopt, then it will become very difficult. So now, the staff capacity building involves clinical training sections. We have to train majority of the staff where this is the evidence-based protocol is to be implemented, for them to know about this, to know their own role, to know where they have where they have to pass the ball to the leaders in that very unit. There were also guideline dissemination to each of the departments, out of the department, down to the staff that are engaged in this very mission. And there were also case-based discussion. At every quarterly, there is even a ground one round for the that is organized by the hospital, where we discuss on certain cases, where we discuss on protocols and how we examine that protocol if it needs a new adaptation based on the community or the locality where we work. And there were mentorship. So each of the units have a senior member who is versed in terms of research, in terms of implementation science, to guide us through how the protocol will stay, and we can drive the best out of that very protocol. And there were continuous medical education, both at institutional level, both at the state level, and sometimes we are also linked with some international continuous medical education. And the objective of this is that to build confidence and competence in protocol use by our staff in the department. Next slide. The third strategy is strengthening the diagnostic. We have been talking about genomics, we have been talking about what works, and we see that without a constrained direction, either by genomics, by creating a molecular laboratory, majority of what we are saying, this protocol may not actually work because they actually give us a very straight line, a very pinhole to a certain disease entity that one is considering. So there was strengthening of diagnostic. So, and the evidence-based care require evidence that focus in area of laboratory quality improvement, improve diagnostic turnaround time, better clinician, that is laboratory communication, and increased use of diagnosis confirmation. So we have made it mandatory in most of the infectious disease that before you treat, there must be a diagnosis. Since we know that we are strengthening our lab, this diagnosis must be relied upon. It must guide our treatment so that we know what is obtainable, down to the antibiotic sensitivity pattern or any form of treatment that can be subjected to sensitivity MCS. Next slide. So let's look at example of malaria management, how our protocol was able to work for us. The aim of the protocol we enacted for malaria treatment or management is to improve the diagnosis and treatment accuracy. Once you get the diagnosis and the treatment is accurate, of course, the management in time or at the clinical side becomes very, very easy and it becomes well targeted. So we look at increased testing before treatment. It is mandatory that before you prescribe or before you treat any malaria case in Federal Medical Center, there must be diagnosis. So there must be testing before treatment. And there must be documentation. This type of document from the lab, it will be passed to the department. The individual saddled with treatment or management of that very case must have gotten this very result before they talk of treatment. And there is reinforcement of treatment guidelines. We adhere to the National Malaria Treatment Guideline, the current one, and that is what we work with. It's part of the protocol that we imbibe into the practice. Then there is monitoring and compliance, down to the prescription at the pharmaceutical level, down to the lab, because of recent, our institution is moving into electronic medical record, and many times, majority of these are documented in the data. So before you treat, or all you just need by the bedside is to click into the name of the patient you are treating. The result is there, it is certain it's for that very patient, and you go on with your treatment. So it was part of what made the protocol to be much efficient for us. So now, the another example is antimicrobial stewardship, because we know that the present threat we have now is antibiotic resistance. So the problem is that there are increased concern regarding inappropriate antibiotic use within the hospital setting. So the management deemed it fit to enact a protocol by intervening in looking at the guideline reinforcement. There are guidelines already on ground. There are protocols that have been enacted for this. So what the management just do is to look at the guideline reinforcement in that very area. And there are teams saddled with this very function. Then we look at prescription review of antibiotic of every department. We do that every month. Every department, we go to the particular level, we go to our data, we look at the diagnosis, we look at the treatment pattern, and we look at the MS, that is the microbiology sensitivity pattern for that very disease condition. Then there's clinician education. That is, we look at any area we find any problem, we call to the attention of the clinician, and there are re-education in terms of the protocol that they have to adhere to. Then there's also laboratory support in terms of supported prescription. Our microbiology lab is saddled with that very function. And our goal here is to promote responsible antibiotic use. Next slide. We look at the case, for example, of infection prevention and control. The management at the hospital setting have a team of infection and prevention control, and they go through all the departments to look at how the waste are being disposed, how the staff therein observe most of the preventive measures they have to take when taking sample from patients and when disposing waste. So, and our priority measure lies in hand hygiene promotion, which our community harm help us to look into, and from time to time, they teach, educate staff in hand hygiene promotion and how to be done correctly. Then environmental cleaning, which the team, infection prevention team, actually take care of, and they give report to the management on monthly basis. Waste management too, in that then isolation procedure were also applicable in this very area, and staff awareness campaign go on every quarterly. So an outcome of this is improved infection prevention culture within the hospital setting. Next slide. What worked well? Our success factor include strong leadership support, staff participation, regular monitoring, practical training, departmental champions, and data-driven feedback, just as I've said earlier. So we should know that people support what they help create. Next slide. What requires adaptation? You know that in a resource limited setting like ours, we have no any liberty. The resources are not too much for us. The money, the finances is there. The competitive priorities are there. So we have to look into adapting into some of those very protocols to see how it adapts into our own local content. So due to resource limitations, staff reality, just as one of the speakers did mention, we know what is going on now about Japa syndrome, and this affected all harm of the specialty down to the departmental level. So we try to adapt because patient load, and so we have a way of looking at how more staff can be coerced into the institution, either by incentive or otherwise, so that to make our protocol work and to make it more friendly to us because of the patient volume, infrastructural constraint, local epidemiology pattern actually force us to adapt majority of this protocol to suit our own safety. So adaptation was necessary without compromising quality. Lesson on implementation. Having taken us this far, for the few of the example that we're able to create protocol for, and many more that I will not be able to touch. We have learned that success requires continuous engagement. You have to keep engaging your staff. You have to keep engaging people that are there for you to impact this evidence-based protocol into the bedside for the patient to gain. There was ongoing supervision for every success to be maintained. There must be ongoing supervision. There must be local ownership, and there must be incremental improvement. Of course, for every quarterly review, you must see improvement in what you are doing, and you must see area where you are lagging, where you have to improve on, depending on what's available to you within your locality. Then content-sensitive solutions. We look at those that are culturally, some of the protocol where it is not culturally friendly or socially friendly, we try to adapt it to the locality where we work. The key issue lesson here is that implementation is not a one-time event, it's a continuous event. Then we look at the role of data. I told us the other time that the data management in our hospital is now improving because we are moving from electronic medical record from the paper to electronic medical record. So majority of our records are intact. It enables us to monitor and evaluate those protocols and to see how they are working. So as we use data to monitor compliance, identify gaps, evaluate outcomes, inform decisions, and drive accountability. As we all know, data transform discussion from opinion to evidence that everyone can see. And what the data show in our own setting here for what we have implemented is that we observe trends to include improved protocol adherence. There was actually protocol adherence. There were better documentation practices. There were increased diagnostic utilization. When people know that there's protocol on ground, when they know that you are being monitored, they adhere to those very protocols. And there is enhanced staff awareness. In fact, when you're having a new staff, the whole one will tell you that this is the protocol on ground and you are being monitored for what you do. So there were more consistent clinical decision making where appropriate. So small improvements accumulated into meaningful change that we observe in Federal Medical Center Abuja. However, there are still remaining challenges. Challenges still exist even for how far we have gone. And this include resource constraint, workforce shortages, which I know is not peculiar to us alone, all over the nation. Equipment maintenance is one problem we also have. Many of the equipment that are light dependent, many of them you have to keep repairing them from time to time because of the NEPA. So we are gradually moving into the solar panel, and the medical director just informed me at the point of this presentation that the management is looking into buying into federal government budget of creating like a solar village that can power the hospital without NEPA. So data quality limitation is still there. We are just moving to electronic medical records. So we still have some issues here and there, but we hope that as we go on, this will be fixed. Issue of sustaining behavioral change. To change a behavior is very, very difficult. However, we are looking into it and we keep changing until when every staff change and adhere to the protocol on ground. So continuous improvement remain necessary. So implication for tertiary health institution facility. We want other tertiary health institution facilities to know that success depends on leadership. Leadership must be interested. They must show commitment. The system strengthening, in terms of infrastructure and all what is needed to make the protocol work, to make us translating evidence-based care into impact by the patient side. Then workforce development in terms of human resources. Then measurement in terms of monitoring and evaluation and continuous adaptation. Adaptation has to keep going depending as the challenges keep surfacing, and it has to be married to the local context. So the key message here is that evidence-based care is achievable even in resource-constrained settings. Then what are our recommendations for other institutions and for the stakeholder at this very scientific discussion forum? Moving forward, healthcare institutions should, one, strengthen implementation capacity. They should invest in workforce training. They should improve diagnosis system, promote antimicrobial stewardship, strengthen data system, foster a culture of quality improvement. These are my references, and thank you for listening. Thank you for listening.
Thank you, Dr. Amos. A key take-home is that evidence-based care is achievable and continuous improvements remains necessary. Next, we have Dr. Olalekan Yusuf from the Department of Clinical Pharmacology and Therapeutics at the Federal University of Health Sciences, Azari. He will address disease patterns, resource constraints, and evidence-based intervention opportunities in the Nigerian context. Dr. Yusuf, you are on.
Good afternoon. Thank you, JBI Global Solution, for this opportunity to speak in this occasion. On this occasion, please, can you share my slide, or should I go ahead and share it from my side?
You can go ahead to share.
All right. Well, okay. Hello, can you see my slide?
Yes.
All right. So thank you once again. I will speak on the epidemiology of infectious disease in Nigeria, evidence gaps and opportunity. Once again, I am Olalekan Yusuf from the Department of Clinical Pharmacology and Therapeutics, Federal University of Health Sciences, Azari, Bauchi State. So this is going to be my outline. I will do brief introduction, discuss the infectious disease body in Nigeria, the epidemiology landscape. I will talk about the critical evidence gaps, and then I will conclude. So, infectious disease remain an issue of public health concern. they pose severe threat to the health and economic well-being of affected individuals because of their high rate of morbidity and mortality. But it is very important to know that these diseases affect all countries across the globe, nations like Nigeria, because population, such as limited resources and some other dynamics that make the infectious disease to have a severe impact in Nigeria. So Nigeria is the most populous Africa country with about 200 million people. Some data, though this data is not very viable because the last census we had has been over 10 more than decades ago that we had the last census of our country. But it is estimated that Nigeria is way above 200 million people, and we are faced with challenges in the surveillance and control of infectious disease. And this is exacerbated by enormous population, regional diversity. There's a lot of cultural differences. We are we are one nation with different diversity, with diverse people. And the disparity in access to healthcare service between urban and rural areas. Those are the things that exacerbate these challenges of monitoring the control of infectious disease in Nigeria. So, what the infectious disease burden in Nigeria? The data from World Health Organization 2022 puts the global burden in Nigeria to be number one, 27% of all cases of malaria globally, and then the global incidence of tuberculosis in Nigeria. Nigeria is the third globally, and there are 467,000 new cases per year, followed by the HIV, that is human immunodeficiency virus AIDS. Nigeria accounts for the second largest burden in Africa, as approximately 4 million people are living with HIV AIDS in Nigeria. I hope I'm audible. Am I audible?
Yes, you are.
All right, thank you very much. Then the childhood state, childhood death due to preventable disease account for 80%, which is one of the largest or highest burden globally. So most of these figures are model estimates, and because surveillance underreporting is severe in the rural local government area. So most of these data are just model; they are not true estimates of this prevalence. The current epidemiological landscape of disease pattern in Nigeria, aside from this emerging and re-emerging infectious disease, this table shows this landscape. Now, malaria top is one of the highest, is number one, and the burden is endemic across the regions, different regions of the country. You know that Nigeria has 6 geopolitical regions: the northwest, the northeast, the north central, the southeast, and the southwest and the south south. So for malaria, it is endemic, and the major and is still account for major cause of morbidity in Nigeria, and the spread this burden is nationwide. The Lassa fever is another one, usually seasonal outbreaking increasing. Most of the is seasonal, but the outbreak is increasing over the years. And the region that is largely affected are Ondo, Edo, and Bauchi State. Cholera. Recently, there is a recent cholera or ongoing cholera outbreak in Northeast Maiduguri or Borno State precisely. So cholera has been a recurrent outbreak in Nigeria and is one of these burden of infectious disease that we encounter occasionally. Most of the northern states has this highest burden of this disease in Nigeria. Tuberculosis is another infectious disease that is high in Nigeria. The incidents are high and is underdiagnosed. It affects both the urban and rural region of the country. Mpox is another one. It has been persistent since 2017, and it affects multiple states. Likewise, the HIV/AIDS, which is still a significant public health burden, and it is spread across all the regions in the country. So the current surveillance architectures and their weakness in Nigeria. Nigeria operates independent, integrated disease surveillance, integrated disease surveillance response that is usually coordinated or that usually originate for the 3 tiers of government in Nigeria, which are the 3 tiers of government in Nigeria: the local government area, the states, which are usually the state health ministry, and then the federal Ministry of Health and the NCDC, which is the apex or is the highest level of this surveillance structure in Nigeria. So the IDSR is what we use as a strategy to monitor the outbreak or the spread of infectious disease in Nigeria. And the fourth line, the fourth line tiers of government in this is the local government area. These diseases are reported from the health facility in the local government area, the community. Most of the major challenges with this level of surveillance is a major data dropout point. Many are not reported, maybe because of difficulty in reaching the facility. Some of these health workers are not well trained. And most of the time, the data arising for this, there's a lot of data dropout from this level of surveillance. Then going to the State Ministry of Health, the people that usually coordinate the monitor disease, infectious disease in this level, at the state levels, are usually the state epidemiologists or sometimes the state surveillance officers. And most of the time, the data gotten for this place are usually often are not reliable because of inconsistent capacity building among the people that are supposed to collect these data. And lastly, the federal Ministry of Health and then the NCDC, that is the National Center for Disease Control, are the one that bring out the policy. They are the one that interpret the data that are collected from the community up to the level of the state ministry, and then to the national, which are the coordinate outbreak response and the like. So what are the system weaknesses that is associated with this architectural structure of surveillance, infectious disease surveillance in Nigeria? The IDSR reporting completeness is less than 60% nationally, even though there is an attempt to digitalize these processes to improve the completeness of data that arise from these tiers of government with the use of the electronic IDSR. But it is still low. The uptake is still low. About 22 to 36 states, 32 of 36 states in Nigeria have already key into this electronic IDSR digital uptake, which still responsible for the unreliability of the data arising from this surveillance. And then there is also some parallel vertical programs that are not integrated into the national surveillance, like that of the Global Fund for AIDS, Tuberculosis, and Malaria. They are just running in parallel. There is no concerted effort to integrate data for this to become a national survey structure. Then most often the private sector data are largely excluded. Most of the private hospitals are not even engaged in collecting these survey data. And that is one of the reasons why we have poor, we cannot, reliable, we cannot, well, that is one of the reasons why data are not reliable for this process. So laboratory confirmation too are often absent. We know that in surveillance, there are also some diagnostic components in the infectious disease surveillance. We have to confirm the diagnosis and be sure that what they are reporting is actually the disease. So most often, especially at the at the primary or the rural level. Most of these infectious diseases are no laboratory confirmation. So what are the critical evidence gaps? These evidence gaps are the missing links between the data collected and the action needed to prevent these infectious disease. And that is one of the challenges that is facing that contribute to the high burden of this infectious disease in Nigeria. One of these critical evidence gap is the geographical data board. Even though Nigeria as a country, like I said earlier, we have different zones or different geopolitical zones in the country. Most of these data some regions are doing well in this, while some are not doing well in this surveillance. For instance, northern Nigeria, especially Borno State, because of this insecurity and some other peculiarity in this region, there is near absence of active surveillance due to insecurity and weak health infrastructure. The laboratory capacity gaps. There is only 6 national reference labs that serve 36 states, including the Federal Capital Territory of the country. Pathogen sequences, antimicrobial resistance, profiling, and viral genotyping remain in their nascent stages. So this is also one of the reasons why we have gaps in the data that is collected for this infectious disease. The civil registration failure, so less than 30% of deaths are formally registered in Nigeria. Verbal autopsy is underused, and the cause of death attribution is largely guesswork in rural settings. So with these two, there is a lot of information that is lost due to this failure in civil registration. Also, antimicrobial resistance surveillance. There is no national AMR action plan with systematic sentinel surveillance and unregulated antibiotic use in livestock and humans, fuel resistance with no tracking. This is another gap that we need to look at and then to improve the data that are coming from these areas. The comorbidity data, like in a case of HIV, tuberculosis, malaria, malnutrition, and chronic disease interaction are poorly characterized. Integrated case management is based on fragmented evidence. So just like I said in the previous slide, there is a lot of disparity from different regions of this country. And there are geospatial disparity and equity in evidence are there. If you look at this table very well, you will see that the Northeast, for the prevalence of malaria, the report is very high. Then the TB notification rate is low. Then the research output from the Northeast is negligible. And if you look at the Southwest, for malaria, the prevalence is moderate. For the tuberculosis is high, and the research output from the Southwest is high. So you can see that the output of evidence coming from this geopolitical zone of the countries, there is a lot of disparity, and this one too could affect the implementation of whatever finding nationally from these different regions. So the geospatial disparity, the research concentration bias, there's this research concentration bias that over 70% of Nigerian infectious disease publications originated from from Southwest, Abuja-based institution, and leaving the highest burden northern states with a scientifically infeasible. There is bias because most of these research are coming from where we even have lesser burden of this infectious disease. Then the digital health coverage gap is also there, and it varies from different regions of the country. About approximately 80% of primary healthcare centers in Northeast Nigeria have functional health management information system terminals, mobile network coverage for mobile air surveillance remain patchy, especially in those areas of the Northeast that have a huge security challenge. And the data from community level event goes, most often the data from the community level goes unrecorded. So with all these gaps in the evidence, epidemiology evidence for infectious disease in Nigeria, what are the opportunities that is open? The opportunity of building the evidence base, for instance, the population-based cohort studies, longitudinal cohort in high-burden local government area to accurately measure incidence, attack rate, and risk beyond facility-based data. So in this case now, because we know that most of our data are missing at this level, we can have a longitudinal cohort in a high-burden local government, and this will be able to accurately measure the incidence and attack rate and risk beyond the one that we gotten from the facility-based data. Another opportunity to bridge this gap, this evidence gap, is the genomic surveillance scale-up. We should leverage on the existing SARS-CoV-2 sequencing infrastructure for Lassa fever, the monkeypox vaccine virus, and the antimicrobial resistance. We know that in 2019, Nigeria is one of the first to sequence COVID-19 genome. We can leverage on this existing sequencing infrastructure for all other infectious disease that we have, like the Lassa fever, even for the antimicrobial resistance pathogen. And a Nigeria Pathogen Genomic Consortium could also fill this critical gap. Then another opportunity to improve on our evidence in infectious disease is One Health integration. And this is another area that we have to do much because now we know that infectious disease are integrated. There must be host, the environment, there must be the what we now call the One Health integration. So the systematic livestock human environment surveillance leakage, especially in zoonotic hotspots like Niger Delta, Lake Chad, and so have to be integrated to improve the burden of infectious disease in the country. The community health worker data systems too have to be digitized. 60,000 plus community health workers reported through simple smartphone too can also increase or bridge this gap. We can use tools like the Kobo Tools box and the ComCare. I think one of the speakers earlier mentioned about Medcare tool. All these digital tools can also be embraced to improve the burden of infectious disease in the country. The death registration and the verbal autopsy has to be expanded, and we have to also automate this civic registration and vital statistic. This one too will enhance data that we are gotten from the. So the NOSA research equity too, how there is a way there is opportunity in that by ring-fence funding for northern-based researchers and institution capacity building. These two will increase the output of research in infectious disease, and then this bias or this disparity between the south and the north can be bridged in terms of research output. So what is the path forward? The evidence-driven infectious disease control in Nigeria demands sustained investment in national surveillance infrastructure beyond the donor project cycle. So there must be a political will to invest in the national surveillance that is beyond the donor project cycle. The academic government community partnership with locally led research agenda too must be a priority if we want to improve on our evidence for this infectious disease control. The data governance framework, we will have to ensure the linkage and integration of the health information, health management integration system, and some other do not, and we have to find a way to integrate it so that we can have a robust and evidence-driven infectious disease control. The political way to address insecurity as a root cause of epidemiological blindspot. So this one too is a valid point. There must be a concerted and political effort to address the insecurity, especially at our rural community. And because this is one of for instance, now in a rural community that is facing insecurity, if you want to go there to vaccinate or to collate data, it will be very difficult to penetrate such a community. So there must be a concerted effort and political will to address insecurity. There must be a continuous training and retention of epidemiologists in all 36 states and the federal capital territories. So doing this, we enhance the evidence gotten for these tiers of government, and then we'll be able to have evidence-driven infectious disease control in Nigeria. So I will conclude with this. Infectious disease pose significant public health challenges, particularly in low and middle income countries like Nigeria, where systemic infectious hinders effective surveillance and response effort. Thus, it is important to exploit this evidence gap to improve overall public health outcomes. So I will leave out with this quote: "You cannot fight what you cannot see. Surveillance is not a lottery. It is the foundation of epidemic justice." Thank you for listening, and thank you, JBI Global, for this opportunity to speak today. Thank you.
Thank you very much, Dr. Yusuf, for this insightful presentation. Our final morning presenter is Dr. Mayowa Daniel Kwemi, the head of hospital services at the Family Medicine Practice Center, Federal Medical Center, BIDA. He will explore how family medicine practitioners function as critical implementation nodes for evidence-based infectious disease management in underserved settings. Dr. Mayowa, you have the floor.
Okay. Good afternoon, everyone. I'd like to recognize the organizers of this meeting, the JBI Global, the Floret Center. Thank you for having me. Please, can you hear me now?
Yes, loud and clear.
Am I audible? Okay, so permission to share the slides. Can you see my slide now?
Yes, it is.
Okay, thank you. Thank you. So I'm Kwemi Daniel, and I work at the Family Medicine Practice Center. Family Medicine Practice Center is a rural outpost of the Federal Medical Center, BIDA. So we work directly in the rural community. And I will be talking about family medicine and infectious disease. Evidence at the community interface. What is the role, or what role, and what is the peculiarity of family physician in implementing evidence-based medicine? What are we seeing at the community level as implementation nodes? This is me here at the Family Medicine Practice Center, Gawu Babangida, an outpost of the Family Medicine Department, Federal Medical Center, BIDA. It's an outpost accredited for training in family medicine and also accredited for training rural exposure for obstetrics, gynecologists, and surgeons. So it's like a comprehensive healthcare center where integrated healthcare delivery is operationalized. Learning objectives. Sorry.
Yes, no, it's nice.
Okay, can you hear me, please?
Yes. Yes,
Am I
sir.
okay? Now, we just look at the burden of infectious disease in Nigeria. A lot have been said about that. We can see that Nigeria is home to more than 25% global burden of malaria. And of course, it's a cause of mortality to most under 5 and maternal mortality. So it's a big threat. And this is more so in the rural community where there are resource challenge, where poor housing situation, where insecticide bed nets are not being used, they carry a heavier burden of this. Again, more than 50% of neglected tropical disease is in sub-Saharan Africa, and Nigeria carry the highest burden of this. Nigeria, of course, has the second largest HIV epidemics in Africa, only second to South Africa. So it's a huge challenge of infectious disease that we have here. We're also prone to periodic cholera and Lassa fever outbreaks. Episode of outbreaks, Lassa fever in different parts of the country, cholera. This is also as a result of poor water supply. Many of our people do not have access to potable water, to clean water. And of course, rodent-infested environments, which makes them prone to outbreaks of this. Again, more than 10% prevalence of hepatitis B virus is also a challenge. And we have the highest tuberculosis burden in Africa. So you can see that the burden of infectious disease is still much with us. And now we're talking about double burden of disease because the non-communicable disease incidence is also rising by the day to catch up with the burden of communicable infectious disease. Implementation node in healthcare. All clinicians, frontline healthcare workers, and family physicians who are the gatekeepers are strategically positioned in the healthcare, where evidence-based interventions are translated into routine clinical practice. So we are directly in touch with patients and with the rural community. And this is where evidence matters. We have to translate evidence into routine clinical practice in the midst of resource constraints, where diagnostic facilities are not really very much available, where medications are not easy to come by, and all kinds of infrastructural decay and deficits are staring at us. So we have to bend heads backwards and yet translate evidence into routine clinical practice. I move on. Why is family physician? Why do we serve as implementation? Why are we critical in this? We provide first contact care. Usually, we're the first to be contacted by patients since we live very close with them. We also coordinate multidisciplinary services, like where I practice here is an integrated care system. We have the immunization, the family planning, we do the basic surgical care, basic obstetrics and gynecological care, basic child care, all within a community. So multidisciplinary, we work with the physiotherapists, we work with the nurses, we work with the community health extension workers, and all cadre of healthcare workers. We interface with them on a regular basis. And so we integrate public health and clinical medicine. and we adapt guidelines to local contexts. Guidelines are given, and we need to work with them to standardize care. But again, we need to be in touch with our local context based on the availability of resources, investigative and diagnostic equipments available. We also facilitate community engagement and behavioral change, engage with the leaders of the community, the menguas, the health committee within the community. We go for health sensitization. We go for community campaign on health issues. We engage with them directly. We also generate feedback that informs policy and practice. We generate data here, which regularly, routinely, weekly, we send to different agencies and bodies and to our headquarters. These data are collated, and I believe they form part of the national data pool. Thus, family physicians function as the operational link between research evidence and population health outcomes. And now, just to reiterate, accessibility, we're accessible to them. We provide comprehensive healthcare. We build trust and relationship with them over the years. I've been in this community for more than 15 years now. So I've literally know the nook and cranny of the community, and even the chief imam came to see me yesterday on head ground. So we build trust and relationship, and so they are able to open up to us. Family physicians have cultural competency because we have mentioned something about implementation science. For evidence to be accepted, adopted, it must fit into their cultural context. They must be able to make a sense out of it. So family physician, having lived in the community, understood the peculiar cultural setting and is able to adapt all these evidence guidelines into the local context. We treat patients with empathy, with compassion. Patient is the king. We have shifted away from the paternalistic view of medical care, where doctor is the king. We treat all our patients as someone very important, and that helps them to build trust and to come around whenever they have health issues. Okay, key roles of family medicine. As a first point of contact, we're able to detect disease early at the early symptoms. We're able to conduct risk assessments. We're able to initiate appropriate investigation or refer several times. We take sample here, sent to WHO and other reference labs since we lack capacity. When we have suspected Lassa fever or some other viral diseases that we lack competence in diagnosing here, we initiate appropriate referral and investigation. And of course, we easily recognize a typical presentation, and complicated cases are referred appropriately. Translation of clinical guidelines to practice. We have evidence-based guidelines, usually from WHO, CDC, and National Ministries of Health. We, as frontline doctors, gatekeeper, we translate this in the reality of resource limitations, utilizing available diagnostics facility, prioritizing cost-effective interventions. Since people are resource limited, cost effectiveness is very important. And we modify plans according to patient circumstances. We also provide prevention and health promotion. Every opportunity with patients, we try to educate. We try to promote good health behavior. We try to counsel them on need for immunization and communicate behavioral change with them. Community-based preventive interventions are usually delivered through primary care, can significantly reduce infectious disease and healthcare costs. As family physician also, we recognize cluster of illness. When there are outbreak, for instance, if we are seeing one case of a particular typhoid fever or typhoid perforation, And in another week, you see 5, 7, or 10. It's a cause for alarm. At that, we recognize this kind of cluster and we notify immediately so that we can identify the source of that outbreak, and such can be investigated and nip at the bud. We also do contact tracing. We monitor treatment outcomes, TB treatment, HIV treatment, and other treatment for chronic infections. We do the monitoring, hepatitis B monitoring. Even at the community level, we do epidemiological assessments when there's cholera outbreak, Lassa fever outbreak, Ebola outbreak, on other outbreak of infectious disease like meningitis. We also talk about antimicrobial stewardship by adhering and advocating for evidence-based prescribing. We want sternly against irrational drug prescription, and we avoid unnecessary antibiotics. And this we do by educating the community health workers. We do residence training here. Resident doctors come here, and in training, we emphasize on the importance of evidence-based prescribing. We also educate our patients on drug adherence, monitoring treatment response, and the likes. Now, continuity of care is one of our cardinal attributes, in the sense that many of these infectious diseases require long-term management. And we as family physicians will provide what we call longitudinal follow-up, even to the family level, where we do home-based care and home visits. We do family conferencing to ensure that families are involved in the care of the patient. We also monitor for complications, and we provide psychosocial, emotional support. And of course, counsel patients about the need for family support. So our care is family-centered, not individual, so that patient can have all the support needed to adhere to medication. And evidence have shown that outcome is usually better when family are involved. We also coordinate care with other specialists. We refer to pediatrician when need be, to radiologists when needs be, to different specialists, and we coordinate the care. Our community-oriented primary care is what we also provide. Community diagnosis, identifying disease pattern, and mapping vulnerable population, engaging community and their leadership, and of course, targeted interventions when needed, immunization campaign, the mop-up campaign, and the routine, tuberculosis screening program, malaria prevention initiatives. We also address social determinants of infectious disease. Underserved populations are often faced with poverty. Multidimensional poverty is here with us. More than 130 million of Nigerians are poor, living in poor housing states, and children often malnourished, having limited access to clean water, and usually low literacy level. And of course, when you have this triad of tragedy, low literacy, poverty, you have sickness with it, and most often infectious disease. So family physicians address these determinants via advocacy, linking patients to social services, and promoting community development initiatives. Where I work here, we don't have gene experts. So most time, we have to take our samples to nearby community like Suleja, or take it to the headquarters, FMC Bida. So limited diagnostic infrastructure is a huge challenge. Inadequate workforce. Now we have the Japa syndrome. Many people have migrated. Worse still is the maldistribution of health force. More people do not work in a rural community where social amenities are not available. So we have inadequate workforce retention, of course, drug shortages, and inability to maintain proper storage of drug because of poor power supply in the rural community. There's poor referral system. You just see people with complications from the community health extension worker or from somewhere. They are not referred. They just came verbally making their complaints. They've been somewhere several days in labor. They come with complications, obstructed labor and the likes. So poor referral system. And we have weak surveillance mechanisms. These are some of the challenges confronting us as family physicians who are directly in contact with the patients. Now, again, funding constraints, which is a major issue, emerging and re-emerging infectious disease. And of course, this is where the issue of genomics comes to play, where you can make a precise, diagnosis and you can identify the virus or the pathogens that are involved in some of these strange diseases. The challenge of vaccine hesitancy, even when COVID vaccine was around, human papillomavirus vaccine was around, a lot of hesitancy due to religious and cultural biases. Then, of course, misinformation. A lot of people are misinformed. They will tell you, okay, the white people, they want to reduce our population, and different theories that people propound based on misinformation is a huge challenge. Despite these challenges, family physicians continue to serve as agents, crucial agents for translating evidence into action in real-day practice. So challenges, we have mentioned all these challenges. How do we strengthen family physicians' role or frontline doctors, healthcare workers who are directly involved with patient care in research-constrained environments, more so in the rural community? We need to expand family medicine programs so that we have more trained family physicians who are willing to be frontline doctors and work in resource-deprived, constrained environments like rural environment. We need to improve access to diagnostics and essential medicine. We need to strengthen disease surveillance system. We must promote digital health and telemedicine. I'm here in the rural community. Telemedicine will help us to be able to connect with people in Lagos, different parts of the world, in other countries, whereby we can assess their expertise and there could be a transfer of knowledge. Patient can be treated here by somebody who is far away in another clime. Then we must support antimicrobial stewardship initiative, because drug-resistant, antimicrobial resistant is a huge challenge confronting us, even as frontline doctors. We must strengthen this initiative. We must enhance community participation and ownership, invest in primary healthcare infrastructure. Evidence have shown that countries where primary healthcare is appropriately and properly handled, countries like Australia, Switzerland, the Caribbean, they have a more robust health outcomes and better, health statistics. We should encourage implementation of research in primary care setting. Research work should not just end in the lockers on the computers. The implementation gap must be bridged. And that is why family physicians are very strategic in this matter. Okay, in conclusion, practice in resource-constrained setting poses peculiar challenges of resource limitation, diagnostic facilities, power supply, and several other issues. And infectious disease contribute the major percentage of disease burdens in these settings. So, and that is where the issue of genomics, implementation science comes in, so that this burden can be reduced. So family practitioners with their unique skill set are able to see and adjust as required without compromising effectiveness. They're able to provide necessary health intervention based on guidelines without compromising quality. And they give this healthcare that are culturally compliant and acceptable to the community where they served. So thank you for your time. These are my references. I welcome questions. Thank you. Hello, I'm done with the presentation.
Okay, thank you.
I hope you can hear me.
Yes,
yeah.
Thank you, Dr. Kwemi. I think we can take questions later during the panel discussions.
All right, that's all right.
Okay, so we would take a break now for 50 minutes. Please return by 2:20 p.m. prompt. Also remember to drop your questions in the chat. So we're on a break now till 2:20 p.m. Good afternoon and welcome back, everyone. As we resume, we shift our focus from foundational evidence and local implementation strategies discussed this morning towards broader national and global perspectives. To open our afternoon session, it is my privilege to introduce Associate Professor Eduardo Aromataris, the Director of Synthesis Science at the JBI. This would be a prerogative note to give an overview of synthesis science.
My name is Eduardo Aromataris, and I'm the Director of Synthesis Science here in JBI. Thank you for the opportunity today to briefly introduce to you about our program of evidence synthesis in JBI, which will include a bit about our methodological development program, our software to support the conduct of systematic reviews, and also finishing up with a bit about our journal. When we talk about evidence synthesis in JBI, we really are a pragmatic organisation, and the whole ethos behind the conduct of systematic reviews within our society is to inform clinical practice and to ensure that effective and meaningful interventions are used to improve health outcomes. So as many of you will know, and when we talk about evidence synthesis, we do mean the evaluation or analysis and collation of research evidence and opinion on a specific topic to aid in decision making in healthcare. And that indeed does drive many of the systematic reviews that are conducted using our methodologies and methods, and that we publish for our society members and beyond, that they really have a practical endpoint, which I'm sure will be important for many of you in the room, and for those of you that have indeed gone on to conduct some research, and ideally a systematic review of your own potentially, what has driven that conduct, whether one intervention, for example, of those available works better than some of the others, and to compare their effectiveness. You'll see here in our model also in the green wedge is the world of research publication and research evidence that our program relies on, evidence synthesis relies on, and those questions, as I said, that many people like you develop, to ask questions of that research. And the model also acknowledges that, yes, we can talk about systematic reviews to inform practice, but there are also evidence summaries that are important for clinicians to get to the information very, very quickly, and of course clinical guidelines that also bring together and collate that evidence to inform practice. Now, beyond members of our society, clinicians, clinician-led questions of these types of projects and ultimately publications in our field, here in JBI and amongst our society, we also invest a great deal in methodological development across our program. And that is, so now I'm going to speak very briefly about how we go about developing these methods. Many of you, I hope you have, we have our wonderful online manual, JBI Manual for Evidence Synthesis. And there on the left of this screen, you'll see in the table of contents, individual chapters for different types of reviews that match the different types of questions that people like you, clinicians, researchers, students might wish to ask. Essentially, we have our JBI methodology groups, and they are responsible for developing the best practice guidelines or guidance for the conduct of this type of research. And one of the key features of our organisation and our program of synthesis is indeed our pluralistic view of research. And just perusing the table of contents, you will see that it covers the guidance that we provide, that our program and experts from around the world invest in under the name of JBI include syntheses, qualitative evidence syntheses, which often focus on meaningfulness or appropriateness of an intervention that might be used in healthcare. Yes, of course, the effectiveness of different interventions in healthcare. But when we speak about effectiveness and considering that pluralistic view of evidence, the best available evidence here is not just the best, the low risk of bias randomized controlled trials, but rather to see what evidence is available, and indeed may only be non-randomized studies or observational research, to still bring that together to inform decision making. And the types of reviews and types of questions extend well beyond that towards details of costs and economics, around prevalence, for example, reviews of association and causal factors, and then higher level methods or slightly different methods of synthesis, of course, umbrella reviews, and indeed those more focused on evidence-based research as opposed to practice, scoping reviews. So this is really the face to the world of the methodological program, and people who come with their questions apply these methods to the conduct of their work So how do we do this as an organisation in JBI? Well, you'll see here in the middle on the right-hand side, we have our methodology groups, and each of those methodology groups are indeed responsible for developing that guidance, which appears in our online manual. And they're an international group of experts, and they do all sorts of research and actual research to inform best practice conduct. Some of that involves looking back to see how things have been done before. Sometimes it is around consensus moving forward about the best ways to move forward. Everything that they develop and put on paper then moves to the JBI Scientific Committee, which is another panel of international from around our society experts and where required beyond, including the editors-in-chief of our journals. And that is debated, discussed with the methodology groups, and ultimately, once ratified, appears in our manual for evidence synthesis. Next to that, you'll see the synthesis, and those methodologies also respond to the best practice workings of other international groups. And in this case, there's the GRADE working group, and we are lucky enough, for those of us here in Adelaide, to have an Adelaide GRADE Centre right next door, which many of our reviews will apply those best practice methods to assessing, for example, in this case, the certainty of their findings. Alongside the methodology groups, you'll also see that we have what we call our working groups. Now, the working groups don't tackle a particular type of question, which may focus on a particular type of evidence, but rather work on cross-cutting issues across all types of syntheses. A wonderful example is our working group of information scientists who look to keep us informed and all review authors informed on best practices for searching and locating the evidence that will then inform and answer their question. Now, beyond the workings of the methodology groups and the working groups to create that guidance. A very big part of our program, and then also facilitating the conduct of this type of research, is indeed our systematic review software. JBI Summary, the system for the unified management, assessment and review of information. And it is a system, like I said, JBI has a very pluralistic view of systematic reviews and evidence, indeed, that informs those systematic reviews. This system is tailored to help authors deal with any type of those reviews that they might tackle. In some instances, it's more sophisticated for particular types of reviews than others, but it does have the beginnings and is well placed to direct or guide authors through the conduct of their review, particularly novice authors, whether it be a qualitative review or a systematic review of intervention effectiveness. And you can see that here, just as an example, across the top of this screen, it steps the user through it works the user through each of the individual steps, from creating the a priori protocol, applying those principles of searching and screening through the results of their search, moving through the risk of bias and appraisal assessment, extraction, synthesis, and so on and so forth. So it's a wonderful project management system. And again, you can see here, we're in the screening section. It really is presented in a way across the board to help review authors through multiple different types of reviews, and these sometimes unique but consistent steps across those types. So in short, it's a wonderful tool to manage review projects. It has embedded within them our entire suite of JBI critical appraisal tools, which are tailored to various study designs, including qualitative research and assessment of expertise in a review of textual evidence, for example, beyond those that you'd expect for randomized controlled trials or a quasi-experimental study or a comparable cohort study, for example. Embedded within the system are also the basics for the conduct of multiple different types of statistical analyses, including analyses of comparative effectiveness or proportions. If you have, for example, a question related to cumulative incidence or the prevalence of a condition. And of course, it's all set up to help a reviewer through the conduct and presentation of a meta-aggregative synthesis. And within there also are the multiple templates to produce the to get on paper the a priori protocol for authors, and then it compiles all of those results as well as presenting you your results, as well as presenting you an interface to complete your report and export it, almost ready for publication. That will need tailoring for any particular journal that you may wish to publish within. Now, speaking of publishing, another large part of our program of synthesis here in JBI and across our society is indeed our journal, JBI Evidence Synthesis. Our journal was launched in-house about 12 or 15 years ago, way back at the beginning of 2013, and it has grown substantially since then. We're now a multidisciplinary journal that publishes high-quality research, always focused on evidence synthesis, best available evidence to inform policy and practice. And I do hope that those of you who are looking to the evidence to inform your clinical decision-making have actually come across some pertinent topics that you're interested in and that are pertinent to your practice, and found some helpful and useful evidence to further the way to potentially change the way you go about doing things for the better. We don't just publish systematic reviews, though. We also publish protocols for systematic reviews. As I mentioned, it's not just systematic reviews, also evidence synthesis. So we publish a lot of scoping reviews, which give us the lay of the land and often inform the next steps in research, including other systematic reviews. And we also very much, as an organisation, as I mentioned, we invest in the conduct of systematic reviews and producing guidance for the conduct of systematic reviews. So any type of methodological work that is pertinent to the conduct of evidence synthesis is also within scope of our journal. It's now a very highly ranked journal with a Q1 rankings across all of the major citation indices, and we have an impact factor currently in 2024 2025 impact factor I beg your pardon, of 4.5, which is set to increase in 2025. It has evolved into the premier outlet for reviews that move beyond effectiveness, intervention effectiveness, and we do receive and publish many submissions pertinent to all those different methodologies across our entire program of methodological guidance. We do within the journal, also very proud of the special collections that we put together to help users navigate the content. And we do also believe that through our editorial processes, which are second to none across international standards for journals, our editors and our peer reviewers all work together to support and promote, along with our authors, the scientific rigor and transparency in what it is that we publish. Just some wonderful examples of the types of systematic reviews that can inform practice that we do publish on a regular basis throughout the 12 issues in the volume. You can see here some of the titles which may indeed resonate with you and the type of research. And I'll just finish on this point to acknowledge the work and the practitioner-led questions that directly move to inform practice. Over the last 2 years, we've been really proud to be able to support a JBI Evidence Synthesis Impact Award, which is speaking to our model of evidence-based healthcare and what our wonderful society is all about, using evidence to inform practice, where our editors, an independent panel of editors, assess the piece of work that we've published in the previous year that has the greatest potential to really make change and improve lives. And I'll hold it there. Thank you very much for your attention, and do enjoy the rest of your program. Thank you.
Thank you all for listening. Our program continues with an international perspective from Dr. Babak Benham, a visiting professor of human genetics at the Flores Center and co-founder of Avicenna Biotech Research in Maryland. He will provide a comparative international lens on genomic surveillance and response models with a focus on how Nigeria can adopt and adapt these frameworks. Dr. Benham, you have the floor.
Hello, thank you very much. And I hope everything is fine with you and you had a very good day. I know it is at the end of the day, and it's my honor to present today for you, and it's my honor to be educated about the more depth about the status of genomics in Nigeria. Let me share. I'm going to talk today about the global genomic frameworks, what Nigeria can adopt and adapt as a comparative international lens on genomic surveillance and response models, with focus on how Nigeria can position itself as a contributor to, not merely a recipient of, global genomic knowledge. Anyway, I am Babak Behnam. I am, as you mentioned, I am a senior collaborator of global health and burden of disease, international the National Institute of Health Metric and Evaluation, and also with 20 years of academia and molecular and clinical research. Talking about the, as an introduction, I would like to, slide number 3, introduction. Nigeria stands as a pivotal moment in global genomics. By strategically adopting and adapting international frameworks, the country can move beyond being a consumer of genomic knowledge and become a contributor, convener, and regional architect of genomic surveillance, outbreak response, and also public health innovation. This opportunity is particularly important now because genomic surveillance is no longer a niche laboratory activity. It is increasingly treated as core public health infrastructure that links surveillance, epidemiology, laboratory system, and even policy actions on kind of that. Furthermore, Nigeria's potential extends beyond infectious diseases. The integration of genetics and genomic medicine into routine healthcare, addressing both rare and undiagnosed genetic disorders and common complex diseases, will be essential for improving population health and also for positioning Nigeria as a contributor to global genomic research. Slide number 4, I'm talking about the global genomic architecture. At the global level, that is the topic of my main topic of and main context of my presentation. The WHO pandemic agreement adopted by WHO Assembly on 20th of May 2025 last year provides a legal and political framework for stronger pandemic prevention and also for preparedness and response. It is a very good model, as a key component of the agreement is the ongoing work on the pathogen access and benefit sharing, PAPS Annex, which is intended to support the rapid and timely sharing of pathogen materials and sequence information. Also, we can say it's advancing equitable access to resulting countermeasures. In parallel, WHO's global genomic surveillance strategy for pathogens with pandemic and epidemic potential 2022-2032, this 10-year frame genomic surveillance as an integrated public health capability rather than a research kind adding. Its emphasis is on timely sequencing, data use, and importantly, the most important one is interoperability and actionability across the full surveillance cycle. On the African continent, Africa CDC's Africa PGI 2.0 is building and strengthening a resilient and integrated, proactive, and also sustainable molecular diagnostics, genomic surveillance, and epidemiology ecosystem. The strategic direction is clear. It is very clear and concise. We need to have sequencing capacity. We need to have bioinformatics. We need to have public health interpretation. And all of these must be connected, routine, and continentally linked together, I mean. Next slide is the number 5. If we want to have a kind of comparative international lens and talk about what strong models have in common, I summarize some examples that were with the key features and the lessons that we may have for Nigeria. First, several international models show how genomic surveillance becomes useful as a scale when sequencing is connected to public health decision making, and also as a clear standard and rapid data exchange. In South Africa, for example, a key feature is an early leadership, which is in variant detection, including Beta and Omicron, if you remember that, demonstrated the power of research-led surveillance connected to public health immediately. The lesson that we can have for Nigeria is African laboratories can lead global detection when sequencing is linked to rapid interpretation and policy action. In Brazil, another one, Revigid and Gemibra, these two platforms are kind of kind of consortium in Brazil. Both of them illustrate a federated surveillance approach that links decentralized genomic analysis to a national data systems. As a lesson, we can mimic that in Nigeria, as regional laboratories can retain local ownership while feeding a national intelligence platform. So it is important also. In Rwanda, a key feature is an integrated malaria genomics platform which connects community-level surveillance with centralized genomic analysis. A good lesson would be community intelligence and genomic data, which could be combined for precision public health and near real-time response. Probably slide number 6. In United Kingdom, COG UK, that is actually again COVID. Listen, the COVID gave us a lot of lessons and educated us, and we can take advantage of that. In COVID-19 Genomics UK, COG UK consortium, the key feature showed how large-scale whole genome sequencing can be rapidly mobilized during crisis. The lesson would be public-private academia consortia can accelerate response when they share standards and decision pathways. In United States, spheres, actually, again from COVID, it is SARS-CoV-2 sequencing for public health, emergency response, epidemiology, and surveillance spheres, coordinate sequencing across public health, academia, clinical, and private sector partners, all together with explicit attention to standard and data sharing. A national consortium can bridge this kind of package of laboratory science and public health action across multiple locations. It is a lesson that we can have, and we can see there is a core between all of these consortia in different locations and different countries. In India, similarly, there in SACOG, which is Indian, actually COVID consortium, genomic consortium, is demonstrate how a multi-laboratory national network can monitor pathogen variation at a scale. The lesson again could be a consortium model is effective when laboratories are networked under a shared governance structure. Finally, PAHO, Pan American Health Organization region, that I would like to emphasize a little bit in my today talk presentation, and I will talk later a little bit more about that. The key feature is a key feature is a regional sequencing collaboration, which allows stronger countries and labs to support weaker ones through shared analysis and laboratory capacity. And the lesson for Nigeria should be thinking regionally and position itself as both a beneficiary and also as a provider of technical support. Next slide number 7. Why PAHO? Because let's focus on the critical dual role of PAHO. Unique in terms of serving by organization with dual and identity. It has two identity, but one establishment, one institution. It was founded in 1902 and later integrated into UN system in 1949. However, now it serves two masters simultaneously, and it makes it distinct from any other WHO regional office. So why we don't take advantage of the lesson from PAHO? Probably we may. What are the two masters that PAHO is serving now? Number one is PAHO is serving as the WHO regional office for Americans. PAHO implements the WHO global health that mandates on a regional level anyway, tailoring them to specific needs to the Americas, all America continent. Second, as a specific agency of the inter-American system. Why? Because as a heritage, PAHO predates WHO and operates independently under the legal framework of the Organization of American States, OAS. Anyway, you consider this dual status grants PAHO a significant autonomy and a unique capacity to foster technical cooperation. And it is unique among other states. If you have a look on the structure of the PAHO in slide number 8, it allowing it effectively address health challenges that respect no margin or no border. I mean, it shows different countries joined in different levels, and it is still PAHO, and it is serving in as a dual function. Okay, slide number 9. If we want to talk about the key strategic priorities in the region, okay, let's assume, and given the profound health and economic challenges of the region, such as being the world's most unequal and the second most disaster-prone area, we are talking about the PAHO's strategic work, is focused on several critical areas, including strengthening health system and fighting both communicable and non-communicable diseases, and also responding to health emergencies. You know, the PAHO is covering the countries with, first, they are most unequal, and the second most disaster prone. Anyway, a prime example of this cooperation is the role of African Center of Excellence for Genomics of Infectious Disease, ALCIGID, Please correct me if I'm not right in pronunciation or something, because it was the thing that I educated about that, and it was great. It was very exciting, and I believe I learned that Aussigid is based in Nigeria, could play in supporting the PAHO region. Given PAHO's priorities in fighting diseases like cholera, dengue, and HIV, and its focus on emerging pathogens, PAHO could leverage Nigeria's advanced genomic surveillance expertise. By utilizing technical cooperation mechanisms for like PAHO Evidence Informed Policy Network, EVIPNet, which is one of the main topic of the conference today, such a partnership would help member states detect and respond to outbreak more effectively. And it turns the PAHO region from a recipient of global health aid into a connected node in a global genomic surveillance network. So you can see PAHO is now, in this example, a recipient of the genomic surveillance and genomic services. But if we define such a collaboration, PAHO will be, also as a provider. Anyway, in the next slide 10, Nigeria's current genomic landscape. Let's focus on Nigeria now. Get back to Nigeria. Nigeria is already more advanced than a passive recipient role. The country has developed a national genomic strategy, and NCDC's 2023-2027, the Nigeria Center for Disease Control and Prevention, their strategy and implementation plan for NCDC include establishing a national genomic center of excellence, expanding sequencing for priority disease, and developing a national genomic surveillance strategy. You know much better than me. NACA has also confirmed that Nigeria has a national genomic strategy and has sought a costing and implementation plan to support delivery. In addition, WHO has reported the Aussigid serves as one of the regional repository and bioinformatics centers used by WHO and Africa CDC for sequencing and for data analysis and for technical support to neighboring countries. The other one is NABDA, the National Biotechnology Development Agency, which is another critical institutional asset. NABDA has a mandate to promote, coordinate, and regulate biotechnology research and development in Nigeria. Its genomic and bioinformatics programs, particularly those focused on agricultural, environmental, and medical biotechnology, can implement the infectious disease focus of Aussigid and the policy coordination of NCDC. In slide 11, next slide, importantly, NABDA should actively collaborate with specialized genomic centers such as the Florett Center for Advanced Genomics and Bioinformatics Research that we have. The Florett Center is a not-for-profit institute dedicated to advancing genomics and computational life science in Africa through innovation, training, and also kind of collaboration, partnerships such as we have with JBI. And a key example of Nigeria's successful international collaboration is exactly Florett Center role as the host institution of the JBI Nigerian Evidence-Based Healthcare and Genomics Center. Everybody is welcome, if not yet, to have a look on the website of JBI Nigeria in Florence Center. It is a collaborating entity of JBI. Formerly, I believe I also was educated about the name of JBI, formerly the Joanna Briggs Institute, which is an institute of the University of Adelaide in Australia. This collaboration with JBI as a global organization promoting evidence-based healthcare decisions aims to advance evidence-informed practice by integrating genomics and implementation science. We were honored today. Actually, it was very helpful and interesting that Professor Aromataris presented from JBI, and we have him today. Thank you very much for the presentation. It was great. Through this partnership, the center focuses on capacity building, systematic reviews, and the translation of evidence into policy and clinical practice, empowering health system in Nigeria and other low-resource settings globally. Anyway, by connecting computational biology with rigorous evidence-based methodology, this initiative represents a powerful model for how Nigeria can move beyond being a recipient of global knowledge to becoming an active contributor and provider to the global evidence ecosystem. It is the whole concept that I'm trying to say. And in the next slide, therefore, a formal partnership between NAPDA and Florence Center, building on the later established JBI collaboration, could do a couple of things. For example, to establish shared bioinformatics pipelines and data storage standards, to train a critical mass of Nigerian genomic scientists, to support the development of locally relevant reference genomes, to facilitate technology transfer to regional universities and hospitals, and to embed evidence-based frameworks into Nigeria's national genomics strategy. Next slide, 13. At the same time, important gaps remain. We need to fill these gaps. For example, Nigeria still needs a fully sovereign, centralized genomic data repository to serve as and to function as a global and international collaborator and provider. And also, Nigeria still needs stronger interoperability across disease programs. And also, it needs a clear bridge between laboratory outputs, epidemiologic intelligence, and also the public health action. These three, at least, should work together: laboratory, epidemiologic and biostatistician, and also, the health policymakers, and also public health action. Slide number 14, the state of genetics and genomic medicine in Nigeria. Let's talk about the status of genomics medicine in Nigeria. Currently, it represents both a major gap and a substantial opportunity. As a medical geneticist, I would like to pinpoint to a rare and undiagnosed genetic diseases. The name is rare, but in reality, it's actually not rare because thousands of Nigerian families are affected by conditions such as sickle cell disease, congenital anomalies, inherited metabolic disorders, neuromuscular disease, and any undiagnosed developmental syndromes. Without access to clinical exome and sequencing and genome sequencing, most of these conditions are never molecularly characterized. It is a must that we need to have whole sequencing. leading to diagnostic odyssey. I mean, if we are confused, if we don't have any sequencing, we definitely lead to diagnostic problems and confusion, inappropriate management, missed opportunities for genetic counseling, and family planning, anything. Rather than rare genetic disease, let's focus on common complex disease. For non-communicable disease, such as cancer or cardiovascular, anything, they are also rising rapidly in Nigeria. Cancers, psychiatric disorder, schizophrenia, and bipolar, cardiovascular disease such as hypertension, cardiomyopathies, metabolic diseases such as diabetes, obesity, and neurologic disease such as epilepsy, Parkinson, dementia, Alzheimer, all have significant genetic and genomic components at the moment. However, nearly all existing polygenic risk scores and pharmacogenomics guidelines are derived from European or Asian population. It doesn't work because Nigerian specific genomic data are almost entirely absent, meaning that risk prediction, drug dosing, and treatment selection in Nigerian patients are often suboptimal or extrapolated from non-African cohorts.
Dr. Benham,
Yes.
your time is fast spent.
Okay, I am finished in 3 minutes. Okay, let me have the final comments. Nigeria's contribution to international health and research community in this area could be transformative. To fill a major gap in global genomic database, to discover novel disease-associated variants, some of which may be unique to West African population, to help refine the functional interpretation of the human genome, and to contribute to global efforts in precision medicine. I do not have time to mention about the H3 Africa and Global Alliance, you know much better than me, but these are good platforms to collaborate. What Nigeria can and must adopt and adopt. It is the last slide and last slide number 17 and 18. It is the conclusion that I have, the main topic of my talk today. Number one, establish a national secure genomic data repository with clear rules for access, metadata, retention, and cross-border sharing. Number two, build a federated surveillance network with regional sequencing hubs linked to a national coordinating center so that local laboratories contribute to shared national laboratories. Number three, integrate genomics into routine integrated disease surveillance and response, such as IDSR, the One Health Administrative Resistance Surveillance. Number four, invest in workforce development, especially bioinformatics, molecular epidemiology, data governance, and laboratory quality system. And put ethical and legal safeguards in place, which is very important. Use genomics to strengthen AMR surveillance and to position Nigeria as a West and Central African hub for training. And next slide, last slide. Stimulate local innovation and public-private partnerships so that sequencing, reagent, analytical, diagnostic tools, everything in the country. Leverage NAPDA and the fluorescent collaboration is sincere and highly recommended. And also develop a national genomic medicine roadmap. It is very important and very low-hanging fruit. To have a pilot newborn genomic screening for treatable rare disease. To establish a molecular tumor boards for cancer genomics. To integrate a pharmacogenomic testing into prescribing for cardiovascular, stroke, psychiatry, something like that, and infectious disease. And finally, creating a national registry of undiagnosed genetic disorder, which is now spreading around the globe. I do not have more time, and it is almost finished. Thank you very much for everybody. And Dr. Davies, thank you very much. Thank for the conference and the opportunity. I will provide you with the references that I have probably in my presentation I sent to you. They are missed. I have 19 references here. Thanks, everybody. I appreciate, and good luck. Thank you.
Thank you, Dr. Benham, for sharing practical steps on how Nigeria can position herself as a contributor. Moving forward, we have the Director of Transfer Science at the JBI, Dr. Kylie Porritt. This would be a prerecorded note that gives an overview of transfer science.
Hello, everyone. My name is Dr. Kylie Porritt, and I'm the Director of Transfer Science at JBI. It's a pleasure to be speaking with you today and to share an introduction to the work of the Transfer Science Division. Our work is centred around supporting evidence-based healthcare by enabling healthcare professionals to access, understand, and apply the best available evidence in their day-to-day practice. Today, I'll focus in particular on the JBI Evidence-Based Practice Database, what it is and how it supports clinical decision-making around the world. So what do we mean by evidence transfer? At its core, evidence transfer is about ensuring the right information reaches the right people, those who shape health policy and deliver health care. It's a critical step in improving healthcare delivery and achieving better health outcomes. By bridging this gap between evidence and practice, we empower decision makers with timely, relevant, and actionable knowledge. JBI's definition of evidence transfer is that it's a coactive, participatory process to advance access to and uptake of evidence in local contexts. It's a causal phenomenon consisting of factors that enable, facilitate, and support evidence implementation, and that it's more than just a single interaction. This definition highlights that evidence transfer is not simply about disseminating information. It's about ensuring that evidence is used meaningfully in the right context, by the right people, and at the right time. At JBI, our focus is on supporting healthcare professionals and policymakers to access high-quality, relevant evidence and apply it into their everyday practice. Central to our approach are three key mechanisms: active dissemination, which focuses on tailored strategies and using different formats to spread evidence effectively across diverse channels and audiences. Systems integration, which involves embedding evidence within policies, guidelines, and operational workflows that guide healthcare delivery. And education, which focuses on enhancing knowledge and capability through both formal and informal learning, equipping professionals to make informed evidence-based decisions. Ultimately, evidence transfer is about ensuring that the best available evidence reaches and supports those making decisions that shape health outcomes, whether it's in policy, education, or direct clinical care. Supporting this work is the JBI Evidence-Based Practice Database. It's our primary vehicle for evidence transfer. The database is designed to provide clinicians, educators, and decision makers with access to actionable evidence-informed guidance that they can apply in their real-world practice. Whether it's a nurse on the ward, an educator in a classroom, or a policy advisor writing clinical protocols, the database offers a trusted, easy-to-use source of information that supports safe and more consistent care. The JBI Evidence-Based Practice Database is accessed by over 4,500 healthcare facilities in 61 countries, reflecting its global value and impact. The database includes more than 5,000 high-quality, up-to-date evidence-based resources, and they're organised into three key types. Evidence summaries, where we have over 4,000 evidence summaries that synthesise and appraise the best available evidence on a wide range of clinical topics. We have over 900 recommended practices that offer clear and practical guidance based on evidence, and around 70 best practice information sheets that provide concise, easy to digest summaries of a systematic review aimed at busy healthcare professionals. These resources are designed to support consistent, safe and effective care. Let's just look at an evidence summary in a little more detail. A JBI evidence summary is a concise, structured synthesis of the best available evidence on a specific healthcare intervention or practice. Each summary draws on high-quality sources, typically systematic reviews and evidence-based guidelines, and where relevant, other forms of credible evidence. The key findings are distilled into clear, practical messages, along with recommendations for practice. The purpose of an ES, or an evidence summary, is to present complex evidence in a clear and user-friendly format, to highlight implications for clinical practice and decision-making, and provide actionable recommendations that can be applied into local contexts. A JBI recommended practice builds on the findings of an evidence summary and translates them into clear, actionable guidance that healthcare professionals can use. These resources are designed to answer a practical question such as, what should I do and how should I do it? Each recommended practice includes a clearly stated purpose that defines the focus and intent of the practice, a step-by-step guidance on how to carry out the task linked directly to the supporting evidence, and this guidance may include procedures or sequence of actions or specific considerations to ensure that an intervention is implemented safely, effectively, and consistently. Recommended practices are especially valuable at the point of care, where they support informed clinical decision-making and help standardise practice, promoting consistency across teams and settings. JBI Best Practice Information Sheets, or BPISs as they're commonly referred to, are designed to make complex evidence more accessible, particularly at the point of care. Extracting key information from large or complex systematic reviews can be time-consuming and often requires a solid understanding of review methodology. That's not always feasible for busy clinicians or students, and so BPISs address this challenge by reframing the essential findings of a systematic review into a concise, easy-to-read format. They're written with the end user in mind, enabling quick access to key evidence, clear recommendations for practice, and provide a visual summary to help guide clinical decision-making. The JBI Evidence-Based Practice Database is managed by a dedicated research team in JBI Adelaide. This team is responsible for overseeing the development, quality, and ongoing maintenance of the resources that sit within the database. Our work spans over 33 specialty fields, each focused on a specific area of practice. Our resource development is a collaborative effort. We couldn't do this all alone, and we are supported by expert reference groups who ensure that each resource is both scientifically sound and clinically relevant, field collaborators who work alongside our field leads to co-develop and refine content, scientific writers who keep resources up to date through regular review and revision, and this work is interdisciplinary, involving professionals from nursing, medicine, allied health, academia, and consumer communities. All of our efforts are guided by the Evidence at Point of Care methodology group, which ensures every resource that we developed is rigorous, transparent, and using the best methods we can to deliver a trustworthy resource. JBI evidence summaries are developed through a rigorous and standardised process to ensure quality and reliability. Each evidence summary starts with a clearly defined clinical question, and then a systematic search is conducted in databases to identify the best available evidence. All evidence is assessed for methodological quality, and then the studies are summarised into a concise 2 to 4 page document where we will then derive from the evidence best practice recommendations. All of the resources undergo a 2-stage peer review, both internally by JBI research team and externally by expert reviewers. This is before the resource is then published to the JBI EPP database. All of our resources undergo a constant and frequent update, so as new evidence is identified, the resource is updated to reflect that change. I would like now to take the opportunity just to share some examples of the resources in the JBI evidence-based database being used in practice. This first example comes from Nazarbayev University in Kazakhstan, where Dr. Paulo Colette integrated JBI evidence summaries into a foundation nursing practice course. Students were encouraged to explore summaries as part of their learning, helping them to connect theory with evidence-based practice. Dr. Colette described the summaries as a powerful tool to reinforce the idea that good practice should be guided by evidence, a message that strongly resonated with both the students and the staff. Student feedback highlighted that the summaries made it easier to understand and remember, due to the clarity and the structure of the information that was provided. The second example I'd like to share is from the Johns Hopkins Nursing Health System, where the nurse residency program had previously struggled with inconsistency in evidence-based projects. The team turned to JBI evidence summaries, and they found that these summaries provided ready-to-use, high-quality evidence that supported robust, realistic, and actionable projects. This not only improved the quality of their residency projects, but also enhanced the residents' ability to critically engage with the literature and apply it in their clinical setting. These stories and more like these are available to read on our website. So to close, the transfer science team and the resources within the JBI evidence-based practice database play a key role in bridging the gap between evidence and practice, supporting clinicians, educators, and policymakers with trusted, actionable resources developed through rigorous methods and global collaboration. Whether you're using it to inform care, enhance your teaching, or support policy, it's a resource designed to deliver evidence where it matters most, at the heart of clinical decision-making. So thank you for your time today. I'm always happy to receive questions or discuss further how these resources can support your work, so please do not hesitate to email me. Thank you.
Thank you all for listening. Over the past hour, our experts have shared critical perspectives on synthesis science, global genomic models, and transfer science. They have raised several thought-provoking points. The insights we just heard regarding global frameworks and evidence transfer provide the perfect context for our next segment. We encourage you to submit your questions for the upcoming panel session via the Zoom chat. We will take a brief poll. Please do well to participate actively. Okay, we turn now to the heart of today's event, the panel discussion. Our panelists bring us the full disciplinary range we need to walk through these questions with rigor: implementation science, genomics, public health surveillance, clinical pharmacology, and frontline medicine. They have spent the day listening to one another's presentation. They know where they agree on and where they may not. For this panel discussion, Dr. Andre Gilbert Ekman would be moderating. Dr. Ekman, over to you.
Good afternoon, and thank you for this wonderful program today. I invite the panelists for part one, Professor George Aleje, Dr. Oleakan Yusuf, Dr. Mayowa Daniel Pemi, and Dr. Olufemi Samuel Amu to turn on your cameras if you are able so that we can have a much more engaged and lively discussion. If not, it will be wonderful to hear from you. Right.
Thank you.
Right. So at this time, I also invite people to put more questions in the chat that we may ask of our esteemed panelists as they've taken their time to speak more about the current landscape and further solutions. So we have spent this morning and the early afternoon hearing strong evidence presentations from a lot of these distinguished guests. And so the question before the panel at this part of the panel discussion is not whether genomics and implementation science matter. The evidence that they can is clear. But the question is, in Nigeria, what has already been delivered and what structural factors are determining whether more is possible? And so I would like to start off with a direct question. Is Nigeria a country where the implementation science knowledge base is strong enough to guide national infectious disease strategy? Or is there also a knowledge production problem as well as a knowledge translation problem? So I will start with Professor Aleje.
Okay. Yeah, information science have come to stay in Nigeria. Although we observe that it's not widely known to some extent because most of us who are clinicians, for instance, are more interested in research and randomized control trials. We are interested in researching, doing ordinary research, doing clinical trials, but the implementation issue is left behind. We found out that it is left behind. We do the research. For instance, some of us in the university, what the pressure is to publish and get professor. And so you are published, got professorship. What next? There was a statement made last time recently regarding professors in university that it's not the number of publications that we make that become that matters, but it has to do with how many of those outputs are being used today. So these are the issue. So many people are publishing. Someone is saying that the first speaker today mentioned a lot of evidence. Yes, but the issue is the implementation. So the information science is gradually making moves in Nigeria, and we hope that we need to extend more. I'm among those who believe in this information science. You do a randomized control trial, do schematic review, you get something at the conclusion, but people do not tend to practice it. But in our setting, in our units, we tend to practice them one by one in our BGY department. So that is where we are now. So that's what I can talk for now, that it is still evolving in Nigeria. This information science is still evolving. The research aspect have far higher than implementation. They'll have more research, more RCT, more systematic reviews, more basic study, cohort studies, case control studies, case reports. We have them already very ubiquitous in Nigeria. But the implementation is what is lagging behind, which that's the essence of this workshop, to bring it up, to be at par with our research, which will be carried out in the universities and hospitals. Thank you.
Thank you. And to the other panelists, do you share this perspective and do you have anything you would like to add, especially when addressing certain research gaps or addressing any sort of, yes, Dr. Yusuf.
Okay, thank you very much. I agree with Professor Leje to largest extent. The implementation, or let me say translation, of our research outputs into the clinical practice is still evolving. If you look at the genomics, I'm coming from the background of clinical pharmacology. If you look at the precision medicine, in which pharmacogenomic is the foundation, is very central to clinical precision medicine. Currently in Nigeria, there is not even a policy guideline in implementing some of these findings in the lab at the clinical end. So there's still a wide gap between the bench and the bedside. So I think the genomics, the implementation or translation of research are still emerging in Nigeria. There's a lot to do to achieve this. Thank you.
Thank you. Anything else from the panelists to add to this topic?
Okay, I also want to make a comment, additional comment. It's also observed that in some universities, this issue of implementation research is not part of the curriculum. That's what I also observed. So what is the curriculum is normal basic research, all that I described earlier on. So these are also areas where we can now discuss with the policymakers, like we have the Nigerian University Commission, to introduce implementation research into our medical practice or even non-medical practice to be part of the curriculum, so that as clinicians, as doctors, as fellows, medical students, nursing students, laboratory students, even to be able to know how the a course called implementation science, the course, so that they'll be aware of it at the beginning, at the grassroots, so that by the time they grow, after they're doing research, they always remember that yes, this aspect of implementation should be carried along. I think that should also be promoted among the policymakers. Thank you.
Thank you. And related to an earlier point you had, Dr. Ledje, I received a comment in the chat. They also say that the research publications are incentivized because they help you advance in your career, but they may not contribute to the public health infrastructure in the country. Do any of the panelists have any ideas on how to change the career advancement structure or incentive structure to ensure that there is more implementation is able to be rewarded and encouraged for career advancement and for greater development of these systems?
I think maybe can you come again with that question?
Um, so both a commenter in the chat and Professor Ledje mentioned that clinical research and papers generated from clinical research are very useful for career advancement. So people will generate a lot of clinical research studies and case studies for their career advancement, but they are not easily implementable because they're not cohort studies, they're individual studies. So do you have any ideas as to how the research and education and even medical community could help people advance their careers through greater implementation science research?
Okay.
Yeah.
If we let okay, all right. Hello? Hello? Okay,
Yes,
maybe I
hello.
should just say something on this. All right, so I know in academics, there is a lot of emphasis in the publication, and at the end of the day, some of these study will not even lead to solving any problem, or might not even contribute to the existing knowledge per se, because it's a form of reward, not the impact of that study that is evaluated. Because most of in the university and some research institute, you have to publish before you can even progress in your career, and that literally affects the psyche of researchers. They just want to put something out to get advancement career, not looking at the impact. So I think what we can do is that maybe we should start with our postgraduate training, that we have to link impact with award of a postgraduate degree. Maybe we should try to emphasize on the impact rather than just getting something to do during the training. And with that, I think there could be a kind of a connection between research and then the impact that we eventually look at. Thank you.
Thank you. Anything to add from Dr. Amu or Dr. Pimi? Okay, well, to move along the panel, this particular part one of the Q&A panel is focused on what can be built on to expand the implementation of genomics and health research in Nigeria. The Dr. Solomon, who was presenting on behalf of Dr. Usman, had several successful models, and during the COVID-19 pandemic, molecular lab hubs were expanded. What lessons learned from these molecular lab expansions could be better applied to further expand the lab hubs so that they can better serve all 36 Nigerian states?
Okay. Can I say something to that?
Yes.
Hello, can I say something? All right.
Yes,
Well,
thank you.
I think I do not want to say we missed that opportunity in the country. The momentum that the COVID-19 brought, I think along the line we missed that momentum. We should have escalate and build on those structures that we have. But it's never too late. At least all this molecular laboratory, we should have been able to use it to advance the emerging and re-emerging infectious disease that is that affect the country. Like Lassa fever is coming a lot of time. We have not actually used the momentum to
Dr. Yusuf? Okay. Dr. Yusuf, could you perhaps make that point again? I lost your connection. I may have lost Dr. Yusuf for a bit, but do any of the other panelists have any comments?
Okay, thank you. Okay, is Dr. Yusuf back?
Moderator,
Can I just
don't
make
from
a
my head, I
comment?
can't hear.
Let's see, I can hear Dr. Yusuf, but let's see, I'll let Dr. Pemi speak for a bit, and then you can also sort of respond back to him and make your point again as well.
Yeah, I think Dr.
Hello.
That was gathered during.
Right, I'll turn it over to Dr. Pemi.
Thank you for having me. Sorry, I've been having some network glitches here. Okay, if I understand your question very well, we had some gains during the COVID-19 and we got some molecular laboratory. A lot of investment was put into that. But unfortunately, after the pandemic went down, nothing much was done to maintain the lab, to strengthen capacity, to sustain the momentum. I would have thought that we will have built on that gains by strengthening capacity, by having more of those laboratories, at least, if not in every state of the Federation, at least every region should have such lab so that cases of emerging and re-emerging diseases like Lassa fever that we've been having sporadic outbreak, Ebola that is in a very close West African country, MPOS, and several other stuff, we could use that lab to track outbreaks, to determine the genomics of those different strains, variants, and of course, antimicrobial resistance. We could have strengthened our capacity in that and build on that gains, but unfortunately, that was not done. So my suggestion and the way forward will be that our government, NGOs, policymakers will focus on this, build capacity, strengthen what we have currently, and let's, of course, use it to do further research and for the gains for clinical work and scale it down into implementation. Thank you.
Thank you. Anything else to add, Dr. Yusuf? Dr. Pemi did echo your comments about the loss of momentum after the pandemic had wound down.
Yes, I think echo it better, and I think we lost that, but I believe too late for us to do something and at least.
And anything else to add from Professor Leje or Professor Dr. Amo? I'm sorry. Let's see. Right. Let's see. And please continue to add more comments or questions to the chat as well. Let's see. Another successful program mentioned in Dr. Solomon's presentation on behalf of Dr. Usman was the National Immunization Program against polio. And in this age with our heavily social media influenced age, what do you foresee as being the use of implementation science and especially the role of clinicians in combating misinformation that may present a new barrier to vaccine uptake, especially for novel vaccines to diseases that currently do not have one?
Well, in Nigeria, there is a lot of obstacles to vaccine uptake. Among it, I think one of the speaker mentioned earlier in the day that cultural belief and some attitude, even insecurity too, are one of those things that hinder the uptake of immunization. But he mentioned one of their study that they try to bundle a program into an existing program. Is a way of implementing what we have learned from research in the clinic, that we know that there's issue with the uptake of a vaccine. We can integrate some of these. We know in Nigeria we have this routine vaccination that we do, but to increase the uptake, we can bundle it to an existing program in the hospital, like during the antenatal visit that we know that our pregnant women that are participating. We can bundle some of our scheduled routine immunization into that existing program. So it's one of those studies that people have done and that they have tried to implement in the clinical practice to increase the uptake of immunization among our population. Thank you.
Thank you. And anything to add from the other panelists?
Yes, I agree with Dr. Yusuf on his statement. You know, a part of my presentation actually, what we have done in our institution is to try to integrate it into what we're already doing. And then the patient follow-up will be in alignment with normal clinic visits. So there will be no logistic problem, even in terms of finance of coming to check up. Some may come from a different, but since they're coming for normal routine, then for that immunization thing, more people will now comply. And more so, the issue, people have a lot of myths about this issue of immunization, vaccination. People will also say that it can cause a problem, but with the pharmacovigilance, which is the role of the pharmacist in this implementation effort, it has been able to showcase that those myths are not true. So you have been able to bundle that information they have, thinking that immunization will lead to problems. The person will have immunization and the person will be paralyzed. His limb or her limb will be paralyzed. The person will not undergo growth and development. But all these things are not true, because the studies before these things are done, they're usually approvers, both NAFDAC, FDA approvers. So with those approvers, it undergo a lot of evidence showing that this is effective, these are safe for human consumption. I'll give an example. During the COVID, one person said that within 2 years, all of us who received vaccine will die. But today, we are almost 7 years post-COVID, and none of us have died from the vaccine we took. So all these are fear stigma or known fears people have been wondering. But with the pharmacovigilance, with documentation, with evidence, it will now promote this information science to thrive. So that's what I think is what is happening in Nigeria now. So it's really evolving. Many people are believing that what we are saying is correct, and those fears are not there. Thank you.
Thank you. And any additional comments?
Again, just to add that aside from bundling the vaccines and other new stuff into what already exists, is a multi-dimensional approach that we need to involve key figures in the community that they respect their voice. If we can, if they can buy into this, like the religious leaders, the traditional leaders that are well respected, whose voice are well respected within the community, it's important to get key stakeholders' involvement, engagement in all this. Then, of course, we need to engage the media to the extent that they need to speak to them in their own local dialect, people from their own cultural setting, religious setting, who has bought into this. If they speak to them, they are likely to buy into these new innovations. So it is a multi-dimensional approach, not just one-sided approach. Aside from adding it or bundling it into what already exists, like antenatal routine immunization, we also need to engage the media. We need to engage the traditional rulers. We need to do continuous campaign reorientation before we can actually get significant adoption of some of these innovations. Thank you.
Thank you. And so I'll ask this question in the context of Lassa fever. What do you think are what do you believe is the most important area of progress in combating Lassa fever, and what do you think is the key gap that is preventing the control and reduction in the incidence of Lassa fever in Nigeria?
Well, Lassa fever has been that has been emerging and re-emerging in this country. And I think there's a lot of factors that contribute to that. The part of the people, the scholars or the scientists involved in this infectious disease, Lassa fever, I mean, the clinicians, the researchers that are involved. Then there's other parts that contribute to this continuous heartbreak in the community. One of it, poverty, ignorance. What I mean by ignorance is a lack of education about the transmission of this disease and even the cleaning, personal hygiene, and stuff like that. Again, in the another thing is the government too, the policy of government in curbing this Lassa fever too. I don't think it's consistent because most of it are on paper. The fund is not even there for researchers to assess and like that. So I think what has been contributing to it is lack of funding to research, the people too, the social cultural behavior of the people, and then there is a lack of facilities, diagnosis. But I know there are several tertiary facilities in this country cannot even make diagnosis of Lassa fever. They have to transfer it to Irua and some other places before we can even make a diagnosis. So there's a lot of factors that contribute to this burden of Lassa fever in Nigeria. Thank you.
Thank you. Anything else to add from the other members of the panel?
He has actually mentioned something very significant, the sociocultural practice of people who live very close to rodents, because we know multi-mammary gland, rodent is the one that transmits this. We still have some people spreading their farm produce, gari, and all those kind of stuff on the main road, where rodent will come and perch and pass urine and waste. Foods are not well covered and several other stuff. That is the primary source. But aside from that, even among healthcare workers, and which many of them have fallen victim, lack of personal protective wares and universal precautions are not being observed. And so then, of course, the challenge of diagnosis, the challenge of medication, like where I am now, if I have a suspicion of Lassa fever, we have to take the sample to somewhere else, and you have to wait for days before you can get confirmatory diagnosis. Drugs are not even available here at the moment. So those are part of the challenges. PPE, which should be readily available for every clinician, hospital workers to use so that you can be well protected, is not available. It's not readily available. I think ongoing research and funding in this area should be sustained. It seems once there's an outbreak, there's this fire brigade approach to it, and once it goes down, everybody seems to forget until another outbreak. So challenge of logistics, infrastructure, and several other stuff are part of it. But I think there should be ongoing education, sensitization of the locals, people in the rural community, people that live very close, where bush are, where rodents are, since we cannot practically eliminate rodents, but within their household, they should cover their food materials. They should not spread things on the roads. This has been something that has been happening from ancient, but it's still ongoing. You see, as you travel in the local areas, you see there are goose on the road. Again, some still hunt for some of these animals. So poverty is endemic. Ignorance is part of it. And so to curb this, there must be ongoing education, sensitization, funding, more research. I think that will go a long way to curb this menace. Thank you.
Thank you. Anything else to add from Professor Eleje or Dr. Amo? All right, so for my final question for this section of the panel, I would like to ask each of the panelists if they could identify one area of either genomics or implementation science that they think would be the best opportunity for Nigeria to build on to strengthen their public health system. And if he's able to connect, I'd like to start with Dr. Amo. What area of genomics or implementation science would present the best opportunity for Nigeria to build on to strengthen their public health system?
Well, my background is actually not public health per se. I'm a clinical pharmacologist. So if I want to talk about genomics, I will say genomics. So genomic surveillance, I think, is going to help us a lot if we can build the structures and facility. At least we know how these pathogens change and mutate and the like. So if we can have a very strong genomic surveillance structures, it's actually going to help us a lot. And I will still go back to my which is pharmacology. We still want to see the use of pharmacogenomic testing. How safe our drug is. You can how we can individualize the treatment and optimize the management and care of those that eventually come down with some of these infectious diseases. Thank you.
Thank you. And perspectives from the other panelists?
A lot have been said. One of the huge challenges we're facing now is antimicrobial resistance. And the culture and sensitivity not very reliable. I think genomics can also help in this area in terms of precision, individualized care, whereby you can know what will work for different individual, which I believe genomics can help. Like in the rural area here, you may just start a broad spectrum antibiotics and you're not sure. You wait for 48 hours, you're not getting response, you shift to something else. But if genomics is readily available, you can be very specific in what you are doing. Then it also has been mentioned, even in other areas like non-communicable disease, which we know they have genetic predisposition also, the link of hypertension, diabetes, cancer, genomics can actually help in picking some of these stuff and know drugs that individual is susceptible to. Then area of surveillance, I think it will really go a long way to help in curbing disease spread and identify variants and all the likes. I think genomics is the way to go, and implementation, of course, is also very essential. It's not just the research output, but implementation, which means ongoing sensitization, education, and tracking is very important. Pharmacovigilance, all these things will further help to strengthen the healthcare system. Thank you.
Thank you. And any other perspectives? One final question before we close out the first part of this panel. In the chat, we have a very good question. How do we distinguish between an implementation problem and a system problem?
How do we
distinguish
differentiate
between an implementation problem and a system problem with regards to public health, infectious diseases, and genomic related investigations?
Okay, so if I understand the question well, I don't know, but system, at least there's a program on ground, and we identify problems associated with the system. But with implementation, maybe there is not even a structure on ground. We just have information, some report and idea that we want to implement. So for the implementation, there must be a system that is going to stand up for it to run. So I think it's not something we can just separate like that. There must be a system, and then there must be something to implement with that system. So I think they go hand in hand. And for implementation for problem implementation to be solved, then we must have a system that is effective and is going to carry that the system that we want to implement. Thank you.
Thank you.
Yeah, if I will add my voice, a system problem will be a bottleneck to implementation. So they are tightly interwoven. A system problem. For instance, you have a malaria vaccine. It's been discovered that a vaccine will help to eradicate malaria. You understand? Now, do people accept? Do they agree? Are they ready to adopt? That is a system issue. That is an implementation issue. Adoption, okay? Because there are different personality and adoption rates. There are people that will just catch on it. There are people that will take years. They want to see evidence to be sure there's no adverse effect, it's not counterproductive, they may wait up to 1 year, 2 years before they even accept and believe what you are bringing to them. Those are cardinal implementation challenge. But now when you have a system that the people that should do it are not there, there's logistic problem, funding is not there, it's not strictly an implementation challenge, but it's a system challenge. But it will, in a way, affect implementation. So they are interwoven in a way. And that's why systems must be strengthened if implementation will have a way forward. If we're going to succeed in implementation, we must have a strong system on ground that will be able to carry and implement what we have to do. Thank you.
Thank you. And any other final perspectives from the other members of the panel?
Yes, I just wanted to add to what they have said. The problem I just had mentioned, one of the problems, the prevention problems are intertwined with the implementation science, and we cannot remove both of them. You cannot, and but if they are balanced, then you see that things will work. But if one is higher than the other, for instance, if the prevention problem is outweigh the science itself, it will not affect that implementation in the hospital, in the clinic, or in this environment that needs it. So that is the problem. So you have to strike a balance. So even if there's going to be a problem, the problem should be solvable. It should be a solvable problem, something that you can solve, and the implementation will continue. And that is why we have to engage the community, engage the patient, engage the public, and not just only the researchers doing the work without carrying them along. So there must be community engagement. Thank you.
Thank you very much. And so, again, another thank you, an expression of gratitude to the members of our first part of the panel. And we will be taking a brief break before we move on to part 2 of the panel. So if you have questions, the second part of the panel will follow this theme. The title is What Must Change? Charting an Evidence-Informed Roadmap for Nigeria. So please submit your questions about implementation priorities, any policy gaps, and any sort of strong action steps that you would like the panelists to discuss, and any questions that you would like them to answer. We have, for the second part of the panel, Dr. Ekate Tobin, Dr. Shakirat Oluwatorian Afanuja Solebo, Dr. Amos Solomon, substituting for Dr. Abubakar Usman, and Dr. Babak Benim as well, and then Professor George Aleje. You will actually be participating in both parts of the panel. So let's see, we have a break on schedule until 4:20 p.m. And so please submit your questions at that time and we will reconvene at that time. Right, so it is 4:20 p.m. West Africa time. If people have questions for the panelists for part 2 of the panel, I invite you to submit them now to the chat. And so we have Dr. Tobin, Dr. Afanuja Solebo, Dr. Solomon, Professor Aleje, and Dr. Benham for this second part of the panel, where we will be we'll be discussing charting an evidence-informed roadmap for Nigeria. And so I will start with Dr. Benham. In the chat, you said, I believe that Nigeria should create a network of sequencing laboratories with at least one hub. And so how do you envision Nigeria expanding from their existing 4-node COVID-19 example? And what do you think are the most promising areas in that example?
Okay, thank you very much. Hi, thanks for coordinating the panels and moderating it. Anyway, yeah, for having a roadmap to be truly evidence-informed, kind of driven by Nigeria's reality, rather than being imported aspirations, fundamental changes, I believe, are required. I try to be educated in this regard. You are local and you know much better. but I believe based on the information that I've received and I was educated about them, some fundamental changes are required across 6 or 5, 6 interconnected fronts that I mentioned in my presentation about them. I can summarize them at least in 5 to 6 items. The evidence points to critical gaps, but also the building blocks and political will to address them. You know that it is also important. But anyway, if I want, I am pretty sure in some part I am blind, but the first step is the willing. This today conference and seminar is kind of showing the willingness to do that and the intention and determination of doing that. But I can imagine a 5-year or 6-year plan to do that. And in the first step, in the first year, I do some foundational. I mean, some activity to activate and to enact a comprehensive national genomic data governance framework. It is very important. And for this purpose, I would launch a pilot genomic data repository in the first year, just focusing on that. And because it takes time. And then after doing that, I would do some infrastructure, and I would do some operational, federated, the national federated surveillance network, and to establish regional sequencing hubs that I mentioned in the chat room with training programs. But yeah, it is a must to have a regional sequencing hub with training program, because every day it is improved. But also before that, upstream foundation is important to have. Immediately, yes, to establish a regional sequencing hub with continuous training program. And then for the third step, I believe it is necessary to launch an accredited bioinformatics fellowship program and to secure funding, and also to have funding, to have some secure funding for at least 100 new master and PhD positions, because human resource in this is a must to supply laboratories that we discuss. I can mention more, but I prefer to hear first from other panelists. And thank you very much.
Thank you. Any comments from our other panelists?
Thank you.
Thank you, Dr. Saliba.
Yeah, thank you. So I I tend to agree with Benham on the issue of the infrastructure. That's for example, the genome sequencing hub. So the fundamental challenge is still funding. So if we have more sequencing facilities, we would be able to generate the required genomic data information for any of to be applied, in any of the sectors or areas of concern. And also the capacity building too is what I'd also penciled out. as something that is very, very fundamental. And the inclusion of youth in the space. I was recently at a program organized by some youths in Nigeria, and you'll be amazed at the fantastic efforts that they are making in genomics, within the country, where they were able to actually organize, some kind of hackathon, on genomics, where you see young people bringing up solutions, precision solutions on some on rare diseases, some on, different areas, diabetes, different diseases, trying to integrate genomic application into real life practice of medical practice. So that's also one of the major things that we're also promoting at NABDA, trying to ensure that there's inclusivity. And of course, we also need to have a central repository for all of this with the appropriate governance structure to ensure that the information is curated properly, and everyone that needs to have access has access. For example, we've identified that there are pockets of activities going on genomic data generation across the country, whereby the people that would require or that have the ability to use them do not even know they exist, and so will not have access to it. So we should also improve that kind of cooperation and exchange of information on genomic data that is currently available. I think that will also help us. Another aspect, one last thing, is the need to also bring up issues of commercialization of some of these developments into products or services, that can become accessible to Nigerians. Thank you.
Thank you. Any other comments from either Dr. Tobin, Dr. Solomon, or Professor Ledger?
Thank you very much. Well, I think all have been said by the other discussants, but I'm just looking at a way in which issue of genomic is very important, especially for the other non-communicable diseases in terms of the rare genetic issues. I remember some time ago, about 6 months ago, I happened to be at the clinical side, and a child of 12 weeks was rushed into the department, presenting with signs and symptoms correlating with severe bronchopneumonia. However, when we did other bedside investigation, we noticed that the urine has ketonuria, it had glucose. And when we did the RBC, it was highly high. And for that very age to develop diabetes at that very age in time is very rare. So, but we also know that there is an entity of neonatal diabetes in pediatrics. So we went ahead, we stabilized the child, but to have access to genetic mapping, that, okay, if this is neonatal diabetes, which of the variants and how do we go about treatment was very difficult. So the only thing we could do after stabilizing the child is to look at evidence that are available in the literatures, in the journals. And we found out that other people in other West African countries, other places have reported such a case. But in Nigeria, I looked throughout the literature, we couldn't see anybody that reported that. So we have to do what we call sulfonylureas trial test, and that is medication, to play the child and say that the child will do well. And lo and behold, the child did very well. He's now 2 years old, he's growing well, but up till now, we have not been able in any way to be able to detect what variant of neonatal diabetes did the child have. One lesson is taught us is that even in a resource-limited setting, there are other genetic problems that are actually presenting in form of sepsis that we are not be able to actually even tailor down at the bedside. So I don't know how this, up till now, we made a call to some centers to say that we can have this done, though they are from very poor family. And up till now, we have not been able to do that. The child is growing well. The response to the anti-diabetic medication actually showed that there is neonatal diabetes, but we do not know the variant. We are even about publishing the case in the Nigerian Journal of Pediatrics just to raise awareness for other colleagues in different centers that it's not all that present like sepsis that's actually sepsis. So we're having a barrage range of rare genetic disorders among the setting. But issue of genomics, if it's widely spread, if it can be affordable, if it's reachable, it will go a long way to help us to also generate data and put forward as Nigerian from our own part.
Thank you, Dr. Solomon. Any other comments?
Yeah, I have a comment, just a little comment in addition to what has been said on this genomics. In Nigeria, we have come and stay. We really need this genomics knowledge in managing, identifying the rare diseases and the ones that are common in our environment. Even apart from infectious disease, in cases of cancers, genomics are also very important to be able to identify it on time and do what we call prophylaxis or risk-reducing surgeries, so as to prevent the cancers, those genetic cancers from those developing from people who have genetic disposition. So that if it's identified on time, that can be done. Thank you.
Thank you. So in Dr. Solomon's presentation, he had mentioned some successful models. He had mentioned digital health innovations have helped research translate research evidence into policy. Are there any successful examples that any of the panelists have worked with, or are there any promising opportunities where digital models could help promote public health through implementation science? Excuse me.
Well, what I did mention is that the introduction of the electronic medical record, which is also pioneered by the Federal Medical, that's the Federal Ministry of Health, that all tertiary institutions, they give a timeline that should migrate from just paper to the electronic medical record in terms of data safety, in terms of data generation, in terms of building a template that other institutions can actually hang on. Because if there is no data, actually, with what we are saying about all these rare diseases, about infectious disease, would be very rich, would be very difficult to go by. So in our own center, it has actually helped in terms of giving us a kind of template for monitoring majority of the policy or evidence-based care policy that we're actually adopting. So it's helping so well, and also help a lot of young researchers to go into some disease condition in which they want to see either we can generate a local protocol for their management. So we are still at infant stage, as I can say, but at least we are moving forward.
Thank you. And any other comments from the panelists, especially regarding electronic medical records, which are considered to be a very positive impact for digital systems in public health?
Yeah, the issue of electronic medical records have come to stay. Also, is something that is evolving in most of the public hospitals in Nigeria. We now have it done. In our hospitals, we use electronic medical records, and that have helped a lot in monitoring patient response to infection. Can be able to track back for what is track infectious diseases and other non-infectious diseases in terms of care given, the response to therapy and follow-up. That has been interesting.
Thank you. Any other comments from the panelists?
Let me add to that. I think the gradual adoption of the electronic medical records can also help to achieve the use of genomics now. because will provide a platform where genomic information could be attached to the medical records and would assist in better diagnosis. So I think that's a plus for Nigeria that is already ongoing in so many of the medical hospitals and medical institutions. So that's something that can be leveraged on, because one of the partnerships we have is actually looking on how to merge or synchronize genomic information that will be generated on specific diseases, individuals over time to help in providing better and more precision-based treatments. Thank you.
Thank you.
Dr. Gilbert, thank you very much. I also totally agree with this one. As I mentioned, even before infrastructure, I believe foundational, I mentioned about the foundational, and the first immediate step is to launch a pilot genomic data repository. For having the repository and data repository, we need to have yes, the digital electronic thing. And also I was trying to learn the status of that in Nigeria, and I found that in particular about the public private partnership, which is very strategic. I learned that there is a recent agreement or some agreements, such as the Basani Digital Innovation Partnership with NBRDA, which seems to be very good and promising model for building centralized. It is necessary to be centralized, and every single piece of data is coming in one place and merging together, and it is very helpful for expanding digital health innovation.
Thank you. And let's see, I'll be speaking on, the next question is related to something from, I believe it was Dr. Tobin's presentation. There was the 717 framework discussed, and so this was a rapid response target metric. So to remind the audience, it was 7 days to detect an emerging outbreak within onset, 1 day to notify public health authorities, and then 7 days to initiate effective control measures from the notification. And so I wanted to see what the panelists' thoughts were on how to incorporate this framework into expanding education in the workforce. Would this framework be a good way to sort of start master's and other tertiary degree students in getting both hands-on experience and research experience? So what are the panelists' thoughts on that?
And it is very important to have some kind of, I want to add the importance and impact of, I mean, the contribution and the policy making by the federal thing. Dr. Shakirat's contribution and the intention is very, very important and pivotal. And also not only INB, NAPDA, I mean, but also other. I mean, I have no clear idea exactly, but I assume apart from NAPDA and Dr. Shakirat that mentioned, there are some other federal Ministry of Health, so probably. Most of the time there are different people, different focal points, and it is necessary to have kind of synergistic effect rather than the focal. I mean, I also learned about the NBRDA, and I have no idea what is exactly between the NAPDA and NBRDA. If they are really impactful, they need to be, I mean, to be consistent with Dr. Shakirat and NAPDA. It is very important because it is very hard to manage with different management with different centers. I mean, it should be very. It is very important to be centralized. I mean, it is very important. So.
Thank you, Dr. Benham. Any other comments from the panelists regarding how the 717 framework could potentially increase the workforce by providing training and career development opportunities?
I think the 717 model is a good system to be put in place for a rapid response and monitoring. And for me, I think it's more on at the implementation side. Of course, it can be incorporated into training, but it's more it's very so much valid at the field and real life level in order to be able to control disease outbreaks and ensure that the medical practitioners are actually aware of what needs to be done. That is trying to put a standard in place for emergency response for on-field practitioners. But if that becomes the practice or accepted model across the country, of course, it would find its way into the curriculum to ensure that the graduates that will be producing, from medical institutions, whichever of the specializations, also have this at the back of their mind, and it helps to build a good workforce. At the end of the day, it becomes like a national movement, So, but for immediate, I think it helps in the implementation side, and then we gradually build it into the curriculum. So before I stop there, I also want to speak to the issue of the need for strong collaboration, because some of the challenges we have in the country is the issue of people, trying to create and carve their own niches in terms of information being generated, but it should be, approached holistically to ensure that these pockets of information, like I earlier said, are aggregated at a particular point at a national repository that will be accessible, over time. Yes, some of these, the existing data can provide immediate solutions, for troubleshooting and everything. But we're talking about long-term development. And so also, taking advantage of this platform to speak with some of the participants on this call, on this meeting, this solution room, because when we start reaching out from NAPDA, we want them to be aware that this is for national benefits, and so we should all come on board. It's clear to us that it's not something that we can do alone, but we have the mandate for coordination, and would really appreciate that all the relevant stakeholders come on board to help us aggregate this information at the national level and make it available and accessible to Nigerians. Yeah. Thank you.
Thank you. Thank you, Doctor. Any other comments from Professor Lenje or Dr. Solomon?
Well, mine is not a comment, but I want to use the opportunity of being part of the discussion to ask specifically Dr. Adenifuja for this good opportunity I have in actually even seeing her on this very forum. Like the case I raised of the neonatal diabetes, I have another one of familial hyperlipidemia. Is there anywhere in the country presently that these genomic variants can be actually analyzed so that because all those very cases we are written up, we are to publish at international journal, but because of the lack of the genomic identification of what variant it is, it was rejected. However, we pick it up and we are thinking of publishing at local level so that we can best inform clinicians that rare genetic diseases actually occur in children so that we can better have an evidence that we can work within our locality. But is there anywhere in the country? Because I tried to contact during that very period some other area in Nigeria, and it was very difficult for me to get that.
Thank you, Prof. I want to identify with them. There's a Kano Independent Research Center Trust in Kano.
Okay.
Yes, we have we have a relationship with them. We have
Okay.
a memorandum of understanding, and they are actually focused on health-related research, and they have the capacity to actually do sequencing. So we could, take this engagement on the specific issues you have raised further and try to bring them into the picture because they are partners. And what we do, like I said, is to try to bring everybody together. So what you have, what they have, what can we do to bring everyone on board to solve our national problem? That's the one thing that came to my mind immediately. Because the infrastructure that we're trying to establish in NABDA is going to be, is going to be built around collaboration, basically. Yes, even though we will eventually have a central infrastructure, but to make it work, we need all the collaboration, and it's based on the gesture to collaborate with NABDA that I'm on this platform. The Floret Center had reached out to us, and my Director General had told me, giving me the mandate to engage with them to see what we can do together, because I saw in this presentation from Benham a lot of issues that needed to be done, to be addressed at the national level for collaboration with relevant partners. We are very much aware of this and trying to be alive to that responsibility. So we are working with as many organizations that we can leverage with to ensure that this technology is fully integrated into the Nigerian genomics ecosystem. And as well as, like I told you, the youth that are also engaging, that are active in this sector are also being considered for, whatever that is going on in this area is what we'll try to put together to ensure that we harness the opportunities within the genomics ecosystem. Thank you.
Sorry, man, just a follow-up. Is it possible to have contacts?
With the Kano Independent Research
Center Trust.
Yes, that's why I said we can let's engage after this this meeting so that we can actually draw up actionable plans. Specific action plan in trying to solve that problem, which I believe they might be interested to work with. Yeah.
Okay, that's great.
Yes.
Thank you.
So let's talk further, Thank you.
Sorry, ma, I don't know how to get your contact, or I should send my own online.
Oh, okay. You want me to put my contact? Okay. I think
I'm very sorry for that.
Dr. Flora, unless I could put my phone number on the chat box.
Okay, ma. Thank you very much.
Yes, I've also been trying to get into the Nigerian bioinformatics network. I put it in the chat box. Okay. So,
Thank you very much. Thank you, ma'am.
yeah.
Thank you
So
both.
I just became the director of the department. My predecessor has been doing a lot on capacity building, like I said earlier. Thank you.
Right. So we just got another question in the chat from Gershom Olajire. The main focus of the session has been on infectious diseases, but he would like to know if the same opportunities are available for non-communicable diseases like cancer. This is open to all of the panelists.
I'm not the right person because it is asking about the status.
Okay. So like I said, any issue, any matter that is of national importance is what we are looking at. I said that we have a broad mandate, even for agriculture, microbes. These are national assets, so to speak, that we need to be able to unravel. We need to decode for you. So if you are talking about cancer, yes, why not? That's even a medical issue. So yes, the opportunities are available for anything that is of interest and of economic importance, socio-economic importance to Nigerians.
Thank you, Dr. Salebo. Any other comments?
Yes, I agree with Jenny Fuja. The thing is opportune for non-infectious diseases, cancers, even in cases of preeclampsia, HIV/AIDS. Presently, we are doing a work now involving Kano, Anambra, and Namdaziko Teaching Hospital and Chukwemeka University. The study is on metabolomics of pregnant women who have been on dolutegravir containing regimen as heart. So the thing has to do with that. Dolutegravir can increase the weight gain in pregnancy. But again, what effect does it have on the baby? So we're looking at the metagenomics and the genomics aspect of it. So currently we have that challenge. We have made an arrangement that our samples will be sent to US for analysis. But thank God that you mentioned that it can be done here in Nigeria. So that will also help us a lot in making things easier. So it can also be extended to non-infectious diseases, cancers, preeclampsia, HIV/AIDS, even diabetes mellitus, and other diseases can also leverage on this genomics. Thank you.
Thank you. Any other final comments? Well, as we approach the 5 o'clock hour, I have one final question. What partnership between public health agencies, and this could be at the federal level, federal level to state level, or federal level to local, or local, state, local, do you think would be most effective short term, so within maybe the next 2 years or less than 5 years, would be most beneficial or most effective for addressing policy gaps?
Um, um, sorry to start, and thank you. I mentioned about that in my presentation. Yes, it is necessary. But before that, I want to add one more about the previous question, which is linked to this one also, about the collaboration that Dr. Solibo mentioned about that. Yes, collaboration is also very important and not only recommended, but also it is essential and must. And because because of the shortage of financial resource, we need to define for all developing countries. It is about 4 or 5 years that I have been serving as a senior collaborator with Institute of Health Metrics and Evaluation, and I contributed to global burden disease. That is why I am a little bit educated about different countries, in particular developing ones. And all the developing countries cannot build a sustainable evidence-informed genomic roadmap in isolation. The evidence from successful program, there are some. For example, in Africa, the genomic surveillance network of Pasteur Institute in Senegal is a successful one, and it is globally best practices and shows that strategic collaboration helps and accelerates capacity and reduces the cost and prevents the duplication and lots of things. However, collaboration must be very structured, I believe, and equitable, and also aligned with Nigeria's sovereignty and long-term interests. You see, collaboration with big bodies, independency. For example, Illumina. Illumina is a big company and we need in the first step for genomics, regardless of it is microbial or it is cancer, we need to have sequencing infrastructure. It is the first step. And we need to have financial support for that. If Nigeria can have a single voice, national one, and collaborate with Illumina, I am pretty sure in some degree Illumina is also interested in terms of having Africa's data, because I mentioned in my presentation, just less than 2% of the global genomic data is from Africa. And globally, they are looking for that. They are thirsty for that. And it is mutual help and mutual benefit and interest, because for Nigerian people and African people, local people, it is very helpful to know exactly which genotype, for example, in terms of pharmacogenetics, the dosage of warfarin there is different from the warfarin dosage in North America, definitely. And it is a mutual collaboration, and they inject big money. Not only money, they provide infrastructure, and this kind of the thing that I believe, and I believe that it should be in a sequential of order. The multiple pilot projects should be done. Sorry if
Thank
I
you,
took.
Dr. Venom. Uh, any other comments from the panelists before we close? And the question was, what partnerships between different public health agencies in Nigeria would lead to the most effective, what partnerships between public health agencies in Nigeria would be most effective short term for addressing some of the policy or implementation gaps?
Let me just speak to that quickly. I think one of the partnerships within medical institutions that would lead to, short-term to achieve more within the short term should be actually across at the federal level, I think, because the federal medical centers are strategic, and they are like the tertiary healthcare institutions that are advanced and readily accessible to Nigerians, patients, and then after that, and then if we're able to actually integrate the records that, as we're saying, then there will be the availability of that data across board, interoperability. And then, of course, if we can also now have within the federal medical institutions, as well as the state government institutions within the state, because they have higher capacity to handle this, maybe some more complicated issues. Because at the local government level, you usually have primary healthcare centers there that, when serious issues that may require this level of precision would still refer the patients to the state hospitals. And then when state hospitals are unable to handle it, they take them to the federal medical centers. And then there are some other more advanced hospitals as well, than the federal medical centers. So I think that's my thoughts on that. Thank you.
Thank you very much, Dr. Saliba. Any other comments from our panelists? Right. Well, I invite all of our guests to deliver a virtual round of applause to our panelists for this very informative session. And then before we move to the close, I ask if everyone could turn their cameras on so that we could take a group photo. Great. I'd like to turn it over to the host. For those of you who would like to turn your cameras on, I invite you to turn them on for the photo. Right. Let's see. Right, so I would like to turn it back over to the host so that we may move on to the close. Thank you again to all of our panelists.
Thank you very much. I want to thank everybody, you in particular, and Dr. Flora Davies for coordinating and management. Have a wonderful day.
Yes, thank you to Dr. Flora as well. I only joined in for the later portion of this program, but this was a very excellent program.
So we have reached the end of a full and substantive day. Our speakers have brilliantly mapped the realities of our infectious disease response, identifying both the systematic constraints we face and the clear pathways for actionable change. What you have witnessed today is not a catalogue of problems, though we have named the problems honestly. It is the beginning of a structured collective response. The evidence is here, the expertise is here. What the solution role model asks of all of us is that we carry today's insights back to our institutions and act on them. Dr. Olatoboso Agumbiade will now offer the synthesis and key takeaways to close this scientific program. Dr. Agumbiade, over to you.
Thank you, Marianne. Distinguished clinicians, researchers, participants, and policymakers, we have reached the conclusion of a profoundly vital dialogue. Today, under the auspice of the JBI Nigerian Evidence-Based Healthcare and Genomics Center and the Floret Center for Advanced Genomics and Bioinformatics Research, we tackled a definitive question. What can genomics and implementation science really change in Nigerians' response to infectious and chronic diseases? The insights shared by our esteemed keynote speakers and panel members have provided us with an honest, unvarnished diagnostic of our current health system alongside a clear sovereign blueprint for the future. Here is the comprehensive summary and declaration from today's sessions. The first one is the reality of our burden and frontline context. To understand the absolute urgency of our task, we must look plainly at the numbers and the environmental realities. As Dr. Mayowa Daniel Pemi and Dr. Olalekan Yusuf reminded us, Nigeria sits squarely at the global epicenter of infectious disease weight, First off, we carry more than 25% of the entire global malaria burden and hold the highest tuberculosis burden in Africa. We host more than 50 of all neglected tropical diseases in sub-Saharan Africa, alongside world's second largest HIV epidemic. Over 10% of our population faces a burden of hepatitis V virus. Furthermore, over 130 million Nigerians live in multidimensional poverty, meaning social determinants like malnutrition and low literacy continuously accelerate disease spread. As Dr. Amos Solomon, representing Dr. Abubakar Osman, pointed out, we actually know what works in medicine. The tragedy is that ordinary scientific discovery research does not save life unless it is effectively translated into true actions like routine clinical practices. Vast amount of guidelines on paper sit fallow in journal articles and archive while preventable illnesses and deaths continue. Our family physicians serve as the critical frontline implementation nodes. The operation link between research evidence and population health outcomes. Yet, their care is limited by inadequate workforce, chronic drug shortages, poor power supplies, weak referrals architectures, and deep-seated vaccine hesitancy, driven by cultural and religious biases. Secondly is the critical gaps with surveillance, data voids, and lost momentum. Our defenses rely entirely on what we can see, yet our integrated disease surveillance and responses reporting completeness stands at less than 60% nationally, characterized by massive geographic data voids, particularly across northern Nigeria. We have a severe laboratory deficit, where only 6 national reference laboratories serve all 36 states and the Federal Capital Territory. Widespread civil registration failures mean comorbidity data remain completely uncharacterized. Dr. Ekaite Tobin provided a masterclass on public health surveillance, noting that good surveillance minimizes the chances of making wrong decisions. She advanced the Global 717 framework, detecting an emerging outbreak within 7 days of onset, notifying the public health authorities in 1 day, and initiating effective control measures within 7 days. However, our panel issued an urgent warning regarding post-pandemic operational continuity. Dr. Yusuf explicitly stated, "I do not want to say we missed the opportunity. We missed the momentum. We should have escalated and built on the structures." Dr. Pemi reinforced this, noting that despite heavy investment during COVID-19 to expand molecular lab ops, nothing much was done to maintain them after the pandemic. We must act now to maintain this regional capacity to track outbreaks and map the genomics of emerging variants before they cross borders. Thirdly is the genomic frontier and data sovereignty. We spent significant time discussing genomics, not as a distant luxury, but as a core public health infrastructure. Dr. Shakirat Oloruntoyin Ajenifuja, Dr. Olufemi Samuel Amo, and Dr. Babak Benham highlighted a stark global disparity. Nigeria currently contributes less than 2% to the global genomic data. Because modern genomics is overwhelmingly derived from European population, our risk assessment and treatment protocols for chronic conditions, including cancer, diabetes, epilepsy, Parkinson's, psychiatric conditions like schizophrenia, remain completely suboptimal for our population. To bridge this gap, NAFDA has set a target under the Nigerian Biogenomes Program to sequence 500,000 human genomic samples between 2026 to 2031, supported by GPU infrastructures and strategic agreements with partners like Basani Digital Innovations and Ingenious Bio Inc. But as Dr. Ajenifuja Asholebo powerfully stated, we cannot rely on foreign database. We need our own repository. The government is looking at creating our own national repository. We must establish full genomic data sovereignty through a centralized national genomic repository to protect indigenous genetic sites and data. Number 4 is bridging the no-do gap through implementation science. The finest bench discovery means nothing if it stays on the shelf. Professor George Eleje reminded us that of the no-do gap, the chasm between what we know from research and what actually happens at the bedside. In low resource settings, An estimated 50% of our proven intervention fails to reach the patients. Professor Eleje shared a vital operational maxim for our health systems. Perfect is the enemy of skill. A 70% effective intervention that reaches 90% of the population will always beat a 95% effective intervention that only reaches 10% of the people. We saw what implementation science can do in action through the clinical data presented today. A trial for a dual triplet HIV, HBV, and HCV vaccine successfully recruited 2,775 pregnant women, achieving a stunning zero level of mother-to-child transmission rates at 6 weeks. There was also research on maternal sepsis and malaria proved that systemically implementing IPTSP reduces fetal malaria rates by 73%. We can close the gap using low-cost strategies like task shifting to community health workers using digital diagnostic tools like the MedBrain trial, simplifying complex drug regimens, and bundling new services into existing workflow, such as embedding HPV vaccines into routine immunizations or syphilis screenings into standard antenatal care with zero additional cost. Fifth on the list is the master panel insight, which confronts the systemic bottlenecks. Our roundtable panel discussion targets the root blockage of our health sectors. The experts did not mince words, and their exact positions must guide our strategy. The first is academic pressure versus real-world impact. Professor Eleje directly challenged the publish or perish culture, stated that the pressure is to publish and get professor. What next? It is not the number of publications made that matters. What are the outputs? The research is higher than implementation. The implementation is lagging behind. Dr. Yusuf agreed, noting that the academic system rewards raw volume over genuine contributions to knowledge, and called for linking impact directly to the award of postgraduate degrees. Dr. Ajenifuja Solibo warned that our research system focus on commercialization, IP, and patents has been entirely subsumed by the quick returns of career advancements. The Lassa fever diagnostics. The panel identified that our Lassa fever response is fractured by poverty, ignorance, and sociocultural practices such as spreading farm produce on public roads. Dr. Pemi highlighted a critical danger. Healthcare workers are left exposed due to a lack of personal protective equipment, universal safety precautions are not observed, and diagnostic tools and drugs are frequently unavailable on the ground. To combat deep-seated myths, the panel emphasized that data-driven pharmacovigilance is our greatest shield. Professor Eleje observed humorously, one person said all of us who received COVID in the year will die. And this is 7 years past COVID. No one has died. Dr. Pemi noted that success requires a multi-dimensional approach. We must bundle vaccines into routine workflows, continuously campaign via the media, and actively engage traditional and community leaders. When a participant asked how to distinguish between implementation failure and system failure, the panel clarified that they are interwoven. Dr. Yusuf noted that implementation requires a functional system to run, and Dr. Pemi summarized that a system problem will be a bottleneck to implementation. If we are going to succeed with implementation, we must have a strong system. Now, our collective call to action. As we depart from this solution room, Nigeria must pivot from being a mere consumer of global genomic knowledge to becoming a regional architect and convener. We must advance and expand blueprints for national actions. First, we must enact a comprehensive national genomic policy to standardize clinical applications and precision medicine. Secondly, we must create a robust domestic funding mechanism to eliminate our fragile over-reliance on foreign grants. Thirdly, we must reform academic promotional criteria to prioritize intellectual property, product development, and tangible service delivery over pure publication counts. Number 4, we must institutionalize curriculum reforms by collaborating with national university commissions to establish implementation science as a core standard course in both medical and non-medical healthcare curricula. Fifth, We must expand regional sequencing infrastructure by executing Prof. Babak Benham's model, creating a federated network of sequencing laboratories with at least one major hub in each of our 6 geopolitical zones, coordinated directly by a national reference laboratory at the NCDC. Number 6, we must bridge the lab to clinic pipeline by integrating parallel vertical registries, such as Global Fund and PEPFAR data silos, directly into our National Health Management Information System, the HMIS. And lastly, we must build and sustain a resilient community health workforce through digital tools deployment, while driving North-South research quality with ring-fence funding for active surveillance in northern Nigeria. Ladies and gentlemen, the science is completely ready. Our health systems must now catch up. We cannot keep treating superficial symptoms while remaining blind to genetic, environmental, and systemic root causes. Let us live here committed to co-creation, to breaking down our professional silos, and to putting our resources where our mouth is. As a community of practitioners, let us echo this collective voice of today's panel. Nigeria's genomic moment is now. Thank you all, and let us turn this evidence into lasting change.
Thank you very much, Dr. Olatubosun. We will now hear a brief closing remark from Dr. Davis Bolorunduru.
Thank you very much, Miriam. And thank you, Dr. Agunbiade, for beautifully summarizing every detail of our discussions today. So as we bring this JBI solution to Nigeria 2026 to a close, I would like to sincerely thank our speakers, panelists, colleagues, and participants for their generosity with which they have shared their knowledge, experience, and perspective today. Our discussion have reminded us that while significant advances have been made in genomics implementation science and evidence-based healthcare, the real challenge lies in ensuring that evidence is translated into meaningful action that improves health outcomes for our communities. Today's dialogue has demonstrated the value of collaboration across disciplines, institutions, and sectors, and has reinforced the importance of building bridges between research, policy, and practice. I sincerely appreciate members of our faculty, Dr. Benham and Dr. Gilbert Ekman, for their immense support in contributing to the success of this program. I also want to appreciate our core members, particularly our compare, Miriam, Chukwu, and Olatubosun Agunbiade, for their diligence and support in contributing to the success of this event. So on behalf of the JBI, Nigeria Evidence-Based Healthcare and Genomics Center, and the Florence Center for Advanced Genomics and Bioinformatics Research, I thank you for being part of this conversation. We look forward to continued engagement and collaboration as we work together to advance evidence-informed healthcare in Nigeria and beyond. We encourage you to reach out to us on our social media platforms and on our websites as well. Thank you all, and I wish you a good evening.